Good morning, and it's absolute pleasure to be here today morning at this wonderful conference. And I shall be presenting a patient box. And can I have my presentation, please? Patient we're taking today is a 62-year-old male. He has a history of Parkinsonism and presented with acute coronary syndrome. Came to us with triple vessel disease from a different hospital. And we had planned an angioplasty stenting, very heavily calcified right coronary, diffusely diseased, and we're going to tackle that today. Can I have the presentation? So, this is the right coronary. And do we have the voice or do I play over? Do I speak or? Yeah. Okay. So this patient had extensive calcified right coronary artery disease, and we started from the radial root. With us, and this is a 62-year gentleman, and he's a patient of Parkinsonism, and he had an acute coronary syndrome. He had undergone an angiography elsewhere, and angiography had shown a double vessel disease, a mid-LAD disease, and then a right coronary which was diffusely diseased, heavily calcified, and critically narrow. And it's a dominant vessel, and you can see the disease is starting almost from the proximal RCA, and it is extending to mid-segment. And then there's some disease in the distal part of RCA, but the PDA, which is actually a bifurcated PDA, there is a disease which is about 60 to 70%, and we will take care of that as well. And before we go further, I think we should image first to see what is the type of this lesion which we are going to deal today, and how much is the calcium, and we're going to do an OCT. And this is a OCT, as you know, this is a AI-enabled OCT. We have the catheter across, quite a tight lesion. Yes. And we're ready to do a first OCT run before the, right? We're done with the first run of OCT. Okay, distal vessel 3.3. And this is the disease segment, and we can see the calcification almost 360 degree, 337, and we will need to a block modification. So I'm going to do a balloon dilatation first, and then we'll take a see how we go about it. If we, so I taken a 2.5 into 15 millimeter balloon. Quite a tight lesion. Okay. Yeah, we chose the radial root, and we chose an OCT because we wanted to study the extent of calcification, what is the arc of calcification, what is the length of calcification, what is the thickness of calcification, and then plan our plaque modification strategy. And I thought that we can use a cutting balloon first, and if the response is not adequate, we'll go with an intravascular lithotripsy to take care of that calcified lesion. And we were from the radial root. Guide is backing up. What I'll do is I will take a guide liner. Give me an ear 2 or thing.
So I think it's a good idea always to test with a 2.5 NC balloon as you have done. If the NC balloon doesn't go to the site of the lesion, I actually, that's the decision point for me. IVL will not work if 2.5 NC balloon doesn't go. Then you can either make a decision whether you want to do atherectomy upfront or not. So I just use the NC balloon not even without inflating, just advance it and see if it goes. Okay. So here is yeah, I had taken an AR1 guide catheter first, but the sport was not very good. So I changed the catheter because I think guide sport is of extreme importance in such complicated patients. So we took an AR2.
After the OCT and the balloon dilatation, you changed the, you
Yeah,
switched
I
the catheter.
switched to an
So,
20.
why didn't you take an AL1 first itself?
We could have taken, but I thought AR1 would give me a.
So little touches artery, but
You changed for 7
we
French
have
or it is
changed the
still
guide
6 French?
catheter. Now we have an
The
AR2
guiding
guide
catheter
catheter,
you changed for 7
and we'll
French?
predilate,
Six French
fill
only.
the lesion with a
Six French only,
2.5
but
millimeter balloon, and then we'll go ahead with a block modification and use a cutting balloon and then an IVL and see how things go. Okay.
Non-compliant balloon.
First for the
and,
non-compliant balloon,
2,
and
4, 6, 8, 10.
you take
we taken a
12, 14, 16,
3
18,
millimeter cutting balloon, Opata,
Leaflet.
and this is a little smaller in size than the vessel size which we had
22, 24.
anticipated. So that's the way we go these days for the cutting balloon. Is one size lower than the approximate size, and we can
20.
go to
So
high
let's
pressure.
predilate.
As you
We've
can
seen
see
a good
here,
inflation of the
long
balloon. Yes,
segment, I
please.
went to even
Deflate.
28
Deflate.
atmosphere to modify the block. So this is
So,
a distal modification.
6, 8.
And the middle part you can see is
10,
very heavily calcified.
12,
That was the tightest.
14,
And there is the two sides of
16.
tightest lesion.
It's deflate.
And then
This is a heavily
middle part we could
calcified
not
area
dilate with a cutting balloon even at a very high pressure.
and needs a pop modification
anybody
here.
else wants to comment from the expert
So we
panel?
will take a 3 millimeter cutting. So we have some bradycardia, but it's okay. Heart rate is coming up. That was because of the guide. So 3 into 13 millimeter cutting balloon, Opata. And we'll see whether we can negotiate it. We are across. Slowly. 2, 4, 6.
The previous
No.
balloon was not a cutting, sir.
No, this is the cutting. This is the first cutting.
Yes, please. 2.
This is where we could not get a good
Oh.
dilatation. This side, mid-RCA.
See the tight lesion? 6 atmospheres. 8 atmospheres.
How do you usually choose
10
the cutting
atmospheres.
balloon? 1-to-1 ratio and lower pressure or
12.
rather smaller and higher pressure?
A little
Okay.
smaller, one size smaller and high pressure.
16.
One size. Oh.
One size.
Down.
What
Get
pressures
an
do you go up
IVL
to?
there.
I went even 28 atmosphere.
2.
Do you have any option of using OPN NC or
Six.
you have considered
Yeah, we
OPN
use it
NC?
quite commonly, OPN also.
10,
There also I go
12,
one size lower and go at a high pressure. I gone to even 50 atmospheres with them.
16, 18,
Still one question that when
20.
we talk about calcium,
This is 28 atmosphere
Down.
cutting balloon.
we talk about
So we have used a 1:1 cutting balloon and we've seen areas where there is not dilatation, undilatable lesion. So I think this is a very good lesion for an IVL. We saw 360 degree of calcification, so we'll use a C2 plus and we're going to use a 3 millimeter IVL. That area is not as much dilated as we would like, but we got some dilatation, so I think IVL should do the trick.
Anybody would have used an atherectomy.
So he's stable, there is no problem.
Standard back.
Normal flow, not much dissection, some controlled dissection you can see in the proximal and the mid segment,
I think
which is okay, which is what we expect from a cutting balloon.
made people shy away from
So we're going to use a 1:1 IVL.
I think there is so much calcium and
We have Dr. Randeep here.
with one
He was a bit busy earlier, but now we have got.
IVL
We
in this case upfront. I mean,
knew that
after
we're going to do a
predilation
cutting
was 2.5
and
because
then
it's
a
only our
block
also our
modification.
approach.
So we have chosen
in this case, ma'am, I would also go with
3 millimeter
since it's a balloon cross
IVL for it.
yeah.
and a bit
So we have
tortuosity
some
at the very
problem
point of
negotiating,
calcium.
but
So
I think that should be okay. So I think this is the tightest lead.
shock cut versus rotor cut. How do you see perforation as a complication
Of?
in shock cut versus rotor cut? Because we many times use a combination strategy in many of the cases. So which one is more prone to perforation in your practice or anybody else's practice?
I think I've rarely seen a perforation, coronary perforation. Perforation is a little higher with the, I would say, rotablator, but chances of only occasional patient may have that. It is how you plan the procedure, how you proceed it. And if you use proper tools, the chances are very low. But one reason why I avoided a rotablator here is because I wanted to avoid the femoral root. He was a patient of Parkinsonism, very restless, and I didn't want him to have issues with the femoral side. So I wanted to complete the procedure from the radial. That was one reason, but not a very strong reason, but that was one reason.
Sir, could you continue?
So let's start from there.
Continue
Maybe.
the.
I would say
4
only about
atmospheres.
IVL because we did also.
So we go to 4
last year we had
atmosphere.
observed no
So this is
perforation.
C2 plus,
If you
which
go,
has
if you go
120
with
shocks.
pressure, how it's recommended, I mean 4+2 or even
So
2+2.
we are going to do an
atmosphere.
IVL of the entire range.
Talking about, Dr. Martha, the
can you-
combination strategy. After shock, if you want to just optimize
Aftershock
it and do
orbital
a
or-
cutting balloon.
Usually I use it on a different way. So I mean first rota or orbital and then shockwave.
Yeah. So I think we'll give another one here. 4 atmosphere. Hold it.
So I actually, I mean, I think unfortunately, or I might have seen more perforation.
I think I'm muted it now. You can go ahead.
I just actually sharing with somebody earlier that even just last week, severe aortic stenosis and a patient with heavily calcified vessels. I did the BAV and then LAD, mid LAD, my balloon and perforated. And patient actually could not tolerate any hypotension when she died. It was so fast. We intubated, we put covered stent, we did CPR for 50 minutes, it didn't recover. Balloon at 14 atmosphere. So I'm saying that's probably my luck, but theoretically, rotor perforations are less, if you think, than IVL because you're actually going to deeper calcium with IVL. Rotor is only going to affect the luminal calcium, so theoretically. But that said, if you keep on rotating for so long, you can perforate anything.
So, sir, what?
Yeah, I think that was an issue. We should have used a 3.5, 1:1, which is absolutely essential for that. But we had done a cutting earlier, and the IVL gave us a very good result.
Yeah.
And you can see the OCT after that. There are nice cuts in the calcium and deep cuts in calcium, and that was quite good.
Richa, you probably didn't see the first attempt, balloon did not cross. Then everything has to be changed. So, I mean, I don't know whether I would, I think it is still a balloon difficult crossability lesion. It crossed, but the moment you have to struggle to push the balloon so much, that means you'll be struggling. My point is that at least I'm sure all of us have experience in this, that rotor with a balloon and stent is going to take maybe 45 minutes. Balloon, cutting balloon, IVL, and then another balloon, and stenting, and another balloon will take about 1.5 hours. So, at least in my experience, I actually think that if the balloon crosses easily, that's fine. IVL is fine. If balloon doesn't cross and you're struggling, you're asking for a guideliner, probably better to do atherectomy upfront.
Okay, I think then after doing the IVL, I took a 3 millimeter balloon and went to about 24 atmosphere to see that palpated the lesion, that I've done a good job, and then I was ready to go first. But I had a distal PDA to be taken care of, where I decided to go ahead with a balloon angioplasty and a DEB. It's about 2.5 millimeter vessel. So we tackled that first and then stented it. So we have a balloon, then a cutting, then an IVL, and subsequently a 3 millimeter balloon for a blood pressure.
Did you do a OCT post this?
Yes, we done the OCT. We just have this is the OCT.
Yesterday, Dr. Kalia did a very good talk on how to shock the rock, like the pillowing effect, putting the emitters at the base of the.
And you can see the cuts here. This is a 360-degree calcification which we had to begin with.
Luckily, in spite of using a smaller size,
Yeah, we got a good.
But IVL 1:1, maybe you would have got better cuts.
Couldn't have been better than this, but ideally we should have used that. And now I'm doing ballooning of the PDA. The long vessel, not a very large vessel, but a long vessel supplying a large area of myocardium. Is about
Can
8
you
to
fast forward to the site where you put because we are running short of time? where you put the DCB and then, yeah.
At that particular point where we saw the dissection reaching
is
up
the
to
depth.
the adventitia, what is your strategy of doing the stent and post dilatation? Because usually calciums we post dilate at a very high level, and since the dissection has reached up to adventitia, should we control the post dilatation atmospheres, or we go usual way?
I go with the usual
Usual.
high pressure. Once I've stented it, then there's no
So
issue.
you don't think that there is any
No, I
risk
don't.
of
I've never had an issue with that. And I use a high pressure, even for post-dilatation. I still go, although the recommendation is 16 to 18 atmosphere, I still go about 24 atmosphere. So this is a
So
depth,
these are what is the
this
size
is a
of-
Paclet XL eluting stent. It is 2.5 into 30 millimeter long, prevail, and we went for 90 seconds. Then
Sir, isn't it small for that artery?
no, this was a
2.5.
2.25. No, this is a 2.25 millimeter vessel. If you go previously, it was 2. So this 2.5 was quite okay with it.
So I sorry, I misunderstood your question.
This is after the depth.
Distally,
Distal.
is
Dis-
yeah,
Distal is
But you would have gone with 2.75 distally also, or
2.5. The 2 point, and proximally is the hybrid that.
This is the first stent. This is 3.3 into 38 millimeter.
it looks like it went very easy.
Yeah, after the preparation it went easy. So next 3 into
Did you
38.
use one TCP because distally also distal to the stent which you're implanting there is
Yeah, there is some disease there, but it was not critical.
dilated it previously.
No, I have not dilated the mid part. The distal part I have not dilated. I just dilated up to the place where I'm standing now. And then I done dilatation of the PDA.
Sir, what is the size of the stent?
This is 3 into 38, but I ultimately went on to 3.5 into 30 post dilatation here. This is the second stent. This is 3.5 into 38. This stent boost that.
Three point five.
3.5 into 30. There's some disease in the proximal RC also. So ultimately I stented that way as well. The 3.5 into 18 and then post dilated the entire length with 3.5 and then the proximal part with 3.7.
Right, I was actually thinking I would have gone with the 48, 38.
Yeah.
I don't know whether 48 is available.
It's still not, 48 is available, but it probably would have not covered that part.
I thought even the distal RC, I would have put another drug below.
No,
Already.
that was not tight. When we had done the NGO earlier, means our NGO also and the NGO done outside did not show a critical lesion.
Sir, can you go to the OCT run where?
Tortuous RCS sometimes, if we take smaller stents, this is better, or 48 stent, because sometimes because of the tortuosity, the stents get deformed at the bend or kinked. If we go for 48 stent,
I actually
so
choose.
do you feel something?
So for me, RCA always I choose longer stents because in the first few years of my practice, I was always missing the lesion. I think it is 12 millimeters, and then actually it's not, the stent is not enough.
Single stent or two small stents, because 48 sometimes it gets kinked.
The guideliner.
In your mind, just be prepared for whatever this lesion, probably atherectomy, guideliner.
Sir, can we run? What are the
OCT.
MSAs you got? After 3 stents in the RCA, the distal RCA looks critical. Dr. Kalu.
I would like to check it with the OCT, but if it will be the dissection, I will probably treat it with DCB portion or not stenting?
We took a multiple views here. We gave nitroglycerin. I was of the opinion that the proximal lesion had
could
been
be also
taken care of. So
spasmodic,
proximally, as compared to the proximal, it's looking smaller, but it's not critically narrow. I didn't do the OCT of the mid part. I did the OCT of the stented part.
What's the MSA proximally in the?
I think 9 or so.
Are you happy? Not happy.
I don't have it.
I would like to say that I'm a little bit afraid about the distal part. If I have OCT on table, I would like to try to do the imaging of this part for sure before I end my procedure, because if it looks really very great proximally and in the mid portion, I don't want to have the distal occlusion in a while. So I would like to go with at least with ballooning, and then if it's possible with DCB.
We are bringing him back next week for the LED angioplasty stenting. I'll have a look at
And
it,
then you
do an
can
OCT, and if need be, we'll tackle that. No.
The other point actually is, Antonio believes in FFR, and so all DCBs are done with FFR, so that's the other one. But I still am worried, FFR wire will be very good, not FFR, PDPA. So he looks at PDPA more than 0.93, that's good. What happens when you pull the wire? That's what I'm worried about. While the wire is in place, everything looks good. When you pull the wire out, actually, I have done some similar, whenever I left some disease like that distally, I pull the wire out, wait for 10-15 minutes, and then take one final shot, and I give agrostat, and then hope for the best. If I don't want to balloon, or because DCB for us is extremely expensive, and it is not approved for de novo lesion, so we can't use it. I'm the inspector. I can't use, and I can't tell others not to use it. It's only indicated for restenosis in our center.
We are blessed in that way, because we come across a lot of diffuse disease in young patients, and definitely it's a great tool for us in India. So thank you, sir.
Thank you.
Thank you so much for the. Sarita, you want to say something?
So I was just saying it was a great case, Dr. Bali, beautifully done, very nicely done case. But for us, I think DCB is something that we are now expanding our indications on. And if you look at the distal lesion, although after the stenting of the proximal and mid, the distal lesion doesn't look so good. But if you look at it, there is no staining over there. That means we don't have any dissection which is type C or more than that. In that situation, we typically do what Dr. Dagubati said. We pull the wire, we keep the patient on for 10 minutes. If it has to occlude, it will occlude in that time. Shift the patient on tirofibin to the ICU. Usually nothing happens. This has been our experience, but it's an expanding. There was no significant dissection which would probably shut the vessel down. And yes, we also use the FFR a lot in this situation. And it usually works well because the vessel remodels, there's late lumen enlargement, and usually at 6 months, 9 months, when you bring this patient back for a CAG, the vessel looks beautiful. So thank you.
Thank you for that comment, Sarita. And now we have Cecily. So
in Italy, I just heard that the FFR is more expensive than DCB.
Yes. If I would decide in this case to do FFR, it will be much more expensive than using DCB. So it depends on the situation and the region where we work.
okay, thank you. Cecily is the professor of cardiology at a specialties hospital in Chennai. So, go ahead, Cecily.
Thank you, ma'am. I thank the organizing committee, WCC, Dr. Sarita Rao, ma'am, for having given me this great opportunity. Respected moderator, ma'am, respected panelists and esteemed chairpersons. This is from a government sector in Tamil Nadu, left main bifurcation PCI. Good morning to one and all. We have today here a 47-year-old male, a known diabetic hypertensive, who presented with the anterior MI treated outside, now again having acute chest pain and referred to us. His LV is around 38% with moderate LV systolic dysfunction. His routine coronary angiogram showed left main with critical double vessel disease of both the LAD and L6, and in the RCA there was around 60 to 70% stenosis. We will now have a look at his coronary angiogram. See the coronary angiogram in the LAO caudal view. We have the distal left main with ostial L6 critical, as well as the LAD Medina 111 classification, as well as mid LAD lesion. And also in RCA we are able to see that the proximal RCA is around 60 to 70%, as well as the mid RCA has got another 60 to 70% disease, which we are not going to address now because the patient has come with an anteroval MI followed by an acute chest pain now, and now we are going to address the left system only. This is the angiogram of the patient and other views. In the RCA, it was not very significant lesion. We thought we'll not deal with the RCA at present. Now, after engaging the left system with the EBU 3.5 via the femoral approach, we wired the LAD and L6 and pre-dilated the lesions with 2 into 12 NC balloon, and then we had a OCT pullback from the LAD. Since the mid LAD had the lesion, so we brought in the OCT distal to the mid LAD, and from there we had a pullback of the LAD, as well as the L6 we had a pullback of OCT from the L6 to the left main, and here are the OCT images. Now after engaging, actually this patient, initially we did the semi-compliant balloon inflation for the mid LAD, but for the proximal ostial LCX and the ostial LAD, we had to do an NC balloon because the OCT initially couldn't go through the tough ostial LCX. So initially it was done via semi-compliant balloon for the mid LAD. Then we tried it for the ostial L6 and LAD, but since the OCT couldn't go, then we did an NC balloon dilatation, and then we could take in the OCT. The OCT pullback via the LAD and L6. There was a large major OM astriding that lesion. So we were concerned for that also. And the mid LAD astriding, there is a large diagonal. Everything was kept in mind. We should not occlude these branches. Back, we are able to see the pullbacks of the LAD and LCX.
Can you go ahead to the OCT?
Yes. This is the OCT run, ma'am.
This is after pre-dilatation.
Yes, ma'am. After pre-dilatation only we could take in the OCT across the L6. Back, we are able to see the pullbacks of the LAD and LCX. The mid-reference of the distal the ostial circumflex was very tight. Now we have the OCT images pullback from the LAD and L6. In the mid LAD, there was a plaque rupture. We are able to see the plaque rupture as well as the lipidic pool in the mid LAD. As well as the distal reference in the mid LAD was around 2.47 millimeter. The distal reference in the L6 was 2.7 millimeter. The MLA of the left main was 2.16 millimeter, and the ostial L6 was very narrow. We are able to see in this OCT images. This is the mid LAD. We are able to see the ruptured plaque with cavity, which was the reason for the acute coronary syndrome. As well as here we are able to see in the L6, there is a lipid pool, as well as the MLA, the minimum is 1.66. So we
What's your
proceed.
plan? What was your plan?
Yes, ma'am. So the plan was first to stent the middle lady because that is the culprit for this ACS lesion. So we thought we'll fix up the middle lady first, then plan because L6 osteum was also very tight and yeah, relatively a young patient. We asked for the consent. We also gave him the option of CABG. Patient was not willing. So we first fixed the middle lady and then we went ahead and did the bifurcation strategy, which I'll be showing.
So what bifurcation strategy were you planning?
In this case, we were planning a DK crush that was the straightaway that came into our minds. And whatever that was the best strategy, which for this patient I thought would be essential. And also more familiar with this strategy, we went ahead with the DK crush. This is the image showing the middle lady. We are able to see the OCT findings. The middle lady is the culprit lesion which has got a plaque rupture with cavity and a lipidic tube. So this is the main culprit for the acute coronary syndrome. Hence we have to address the middle lady. So we plan to deploy a drug-eluting stent 2.75 into 24 millimeter into the LAD, post-dilated area and fix the LAD lesion first. So in this yes. So I hope everyone agrees with this strategy of DK crush in this patient because
Just one question, that osteocircumflex is a very fibrocalcific lesion.
yes, ma'am.
So what was the strategy to prepare that lesion? Because with that 2O balloon, there is no dissection at the, or nothing has happened to the ostial circ. So
No. We pre-dilated, yes ma'am. We used a scoring balloon, Apata was used, I'll show it.
so with that comes another point that if the dissections are pretty controlled at the ostial circumflex with your
Now what we did was again, we used a scoring balloon around 2. Yes, please.
then provisional left main to LAD with a DEB in the side branch, or still a dedicated bifurcation with 2 stents?
Yes, ma'am, because the LCX osteum was pretty tight. So I thought DEB, though DEB is in our mind, now we have started doing DEB for the osteal LCX being the Achilles heel there. For this case, I thought double stenting would be the preferred strategy. But nowadays, for if it is not that critical, we put in from left main, then we can put a DEB on the osteal L6. But this osteal L6 was very tight, and now he had presented with unstable angina. His previous was an anterval MI, now with unstable angina. We didn't know which was the main culprit. So we fixed the middle AD, then we thought we'll go in for a
Fair
DK
enough.
crush.
With the definition criteria, it falls into dedicated bifurcation. But
Bifurcation.
with the advent of DCB and a controlled dissection, preparation of the lesion, because we have started DCB in calcific lesions as well. So that's another area of interest that we can
Yeah,
always
definitely,
explore.
ma'am. Definitely, that was taken into account. But after this Apata cutting balloon, 2.75 13 scoring balloon at the L6 ostium, and then from the left main to proximal LAD, using 14 atmospheres at LCX and 20 atmospheres from left main to LAD. There were minor micro dissections in the OCT runs. So that is why we went ahead and straight away went in for a double strength strategy at the L6 ostium. So this was the scoring balloon dilatation, which it was pre-dilated well. For sake of time, I'm just showing a few images, but it was dilated. 2.7 millimeter into 18 millimeter drug-eluting stent at LCX, 3 millimeter protruding into the left main towards towards the POC. We kept 3 millimeter into the left main, and we deployed a drug-eluting stent 2.75 into 18 millimeter. Then we also post-dilated this stent, and then before keeping that, we also kept another balloon simultaneously when the L6 was stented. We had also kept another NC balloon into the LAD, so that we could immediately crush after the L6 stenting. We can crush it initially. 2.75 into 8 millimeter balloon crush was done. The next aim was to crush the L6 stent. We did a 2.75 into 8 millimeter balloon crush of the L6 stent, and then a port 4.5 into 8 millimeter a port crush was done on the L6 stent. The next aim was to crush the next step was to recross the side branch, which is very essential. And in this, there was a lot of difficulty to recross the side branch, which was very important. And we also made sure that it is a proximal, via the proximal stent strut. The initial recrossing for the DK crush via the proximal stent strut, we assured that it is via the proximal stent struts, and we recrossed the L6. It was little tough, but finally we could make it and confirm that also, and also put in at very important. Then we also did the first kissing balloon once again along into the L6. We recrossed and we did a kissing balloon inflation across the L6 and LAD. Across the L6 it was 2.75 into 12 millimeter, and across the LAD it was 3 into 12 millimeter, and the kissing balloon inflation was done. It was done with the NC balloon. Now the next was we had to do a left main to LAD main branch stenting using 3.5 into 18 millimeter left main to LAD stenting, and once again a port was done 4.5 into 8 millimeter using the port. The next was
can you final pictures
next step was to take out the jail wire and then recross the side branch wire via the I would like to ask our expert panelists. See, the initial cross via the L6 was through the proximal stent strut, but for the second, before the final kissing, second kissing, we crossed through the distal stent struts only, so that the metal area would be less in that the POC. So we assured that we crossed it via the distal stent struts. And then once again 1.5 into 12 millimeter and 2 into 12 millimeter balloon was used for strut opening, and the second kissing inflation was done from L6 to LAD. We after recrossing through the distal stent strut into the L6, we dilated the stent struts using a 1.5 into 12 millimeter, then a 2 into 12 millimeter balloon was used for strut opening. Then the second kissing was done using 2.75 into 12 and 3 into 12, 2.75 into 12 balloon was used for the L6 and 3 into 12 into the LAD, and the second kissing balloon inflation was done. It was, using once again a 4.5 into 8 millimeter port balloon, and now then the final OCT run was done. This will be shown in our next step. Using see the OCT run following the post DK crush. The stents in the LAD are well opposed. There is no evidence of malopposition, not much of edge dissection. We are able to see it is a well opposed stent. See the OCT run. This is the bifurcation zone where the crush stents are. We are able to see. And this is the final images. Though there is a disparity from the proximal to the mid LAD, I have left a gap because we had definite landing zones. Though there is a disparity, but I didn't want to take a very long stent for the bifurcation because already there were 3 stents in place. In case we can plan for a DCB for the mid LAD between the proximal and the mid LAD stents at a later time. The major OM was not occluded. The diagonals were all flowing. So this is the final OCT in this young male. So in a young patient presenting with evolved anterwall MI, we had to do an upfront left main bifurcation for bailing him out. The routine use of OCT will definitely, image guidance is the key, and it is there's a DK crush is a steep learning curve. Definitely, gives the best outcomes. Patient is on regular follow-up and doing well. Thank you for the opportunity.
Sorry, one question probably should have asked long time ago. What was his EF? I forgot. I did.
38%.
38.
38%.
So,
yes.
and he was turned down by cardiac surgery.
Yes, sir. Yes, that is why we have to take.
Right, right. I mean, I think definitely surgical patient, absolutely with Lima to LAD, vein graft OM1 and OM2, I think would have
Yes,
been
sir.
good
He
for
was
him.
surgically turned down, and he was also not willing for surgery. Normally, we send the government sectors. We don't have so much of this thing facilities. Normally, we send him to the surgeon, but the patient also being 47, he was not willing, so we had to take him up for the procedure.
Congratulations,
Yes, sir.
excellent case, because how I understood it was acute setting, so especially for that. And I have one question regarding to the dual antiplatelet therapy after such complex strategy.
Yes, sir.
And
normally
acute
give-
coronary syndrome, what kind of drugs do you give these patients?
We put them on ticagrelor, ma'am, and ticagrelor 90 BD and aspirin 75 OD with 80 milligram of atorvastatin for 3 months. 80 milligram, then step down depending on their lipid profiles. We step down to 40, but ticagrelor and aspirin are given to 1 year for 1 year. Even though in the government sector we have all the facilities and we give it.
And I have also, when the patient was uploaded before coming to the cath lab, the patient was uploaded with the dosing
Yes, ma'am. He was
before
uploaded
coming to the cath lab.
after. Yes, ma'am. Yeah, he presented with unstable angina, so he was given the loading dose.
Why I'm asking, because we know that the cangrelor now is intravenous antiplate therapy, which can be used in very challenging cases, especially in patients who are not uploaded with the loading dose. But of course, the price is also higher, and we
Yes,
must
ma'am.
be
We don't have-
very careful with the history of bleeding in the patient. But I think it could be also an option. I am asking because we are using it more and more, but since I think 1 year, not longer. So I am also learning of this strategy.
I have one question. You put the LCX stent across a diseased OM. Could you have considered stenting that into the OM?
No, ma'am, into the OM because I didn't want to complicate much. But I have it in mind, but I was very careful that it should not injure, and the OM, by God, it was flowing well, ma'am, till then.
Okay, thank you, Cecily,
Thank you,
for
ma'am.
this awesome presentation.
Thank you, ma'am.
And
Thank you.
doing it in government sector is not an easy job. So congratulations on that. And I think we'll hand over to the next session.
Thank you, everyone. I would like to request you to correct all the mementos. We now move on to the next session on MCS hemodynamic session, an important segment that will focus on advancing our understanding of hemodynamic management in mechanical circulatory support. The chairpersons for this session would be Dr. Madhuri Nagori, Dr. Stephen Herb, Dr. Saiko Takahashi, and Dr. G. Selvarani. Supporting the discussion, we'll like to have on the dais our expert panel, Dr. Jasmine Bora, Dr. Aditi Singhvi, Dr. Ritu Bhatia, and Dr. Swapnil Gade. To moderate the session, would like to invite Dr. Hetan Chandrakant Shah on the dais, please.
I'm here. Okay. Can I have my slides, please? Yeah, thank you. So, thank you, Dr. Sarita, for having me here. So, and this is a topic with plethora of questions, but very few answers. But I'll try to answer, taking few cases into consideration. And these are the options we have for a patient in cardiogenic shock, IABP, Impella family, or tandem heart family, and ECMO, and also Centrimag. But one problem though, tandem family is not available in our country. So, and Centrimag, yes, it is available in very few centers. In fact, even we don't have in our center. But that's also a good device, often for open implantation, but it can be also used as a ECMO equivalent when possible. And the quantum of support with these devices, you can see this is a quantum of support we get with the tandem heart. It's lesser, sorry. So, otherwise, all other three devices gives you similar kind of support. And what's an ideal MCS device? Of course, there is no ideal device available, but one which is easy to implant, easy to maintain, and easy to remove, and provides a good hemodynamic support without any need for LV unloading, and which is durable as well as biocompatible and cost effective. So, and there is no answer as of now, and there is no ideal MCS device. You have to choose between what is available for you. But these are the factors which influence decision making in labs. One is lack of robust evidence for any of these devices, and also there is conflicting evidence on some devices, and the most important thing is availability of human resources in the hospital, which can take care of this device management as well as management of these patients. That is shock teams. And next is availability of devices and preference of centers as well as experience of people. And this is one thing which is quite consistent in terms of data. If there are shock teams, that will change the outcomes of patients, these patients. It could be with a drug or it could be with a device. So, but the presence of shock teams is the most important thing which changes outcomes. And it is very important to balance, the risk versus benefit in these cases while moving on to a device, because these devices can spoil the outcomes because of their complications like hemorrhage, infection, hemolysis, limb ischemia, and also embolic episodes. And these are the factors, you have to consider while choosing device. Anyway, I'll take you through a few cases. You can see this is a young male, 26 years. You can see the ECG, came with an acute antral MI, and in ER, he crashed. And almost 3 episodes of VT, pulseless VT, cardioverted, but not maintaining hemodynamics, so repeated shocks. So that's when, and we checked for his, lactates, already lactates were high, and he was on significant dose of inotropes. And what's the choice now? So it's an acute MI, almost like shock, C to D stage, and unstable rhythm. So of course, IABPs, it doesn't give, such good support, and we have now data available which is against this device usage. Though it is the commonest device used across the world, in fact even in the West. And when the rhythm is not stable, again, impellers may not be a great device in such patients. So the best is have a VA ECMO. And so we went ahead, so while continuing CPR with the CPR device, we went ahead and, commissioned the VA ECMO on the patient, and then checked angio. You can see, there is a total occlusion, and then we opened the LAD, And subsequently, we continued VA ECMO this for this patient. Of course, for all patients, we use distal perfusion. So distal limb perfusion is created. And you can see this was the echo at the time of admission, and this was the echo after 3 days of procedure. So there is a huge improvement. And this is a simple guide, when you want to explant, device for these patients. When to explant, our minimal inotropes, reversal of metabolic parameters, and LV function is another guide in these patients. So another patient, 34-year-old, came with a VT storm. He was throwing VT in emergency department, and no one has a clue what is the reason. And patient was apparently normal 30 minutes before he presented to the hospital. You can see his heart rate high and BP is borderline, and lactates are already high, 6.7. And this was the ECG. You can see funny rhythms at different points of time, 2 ECGs. And this was the echo. So that's that baffled all of us, because his LV is perfectly, seems okay. There is not an issue in LV. So we thought of, looking at, since his sensorium is very poor, so thought of doing imaging, but in the course, he crashed, VFs, defibrillation, and then we took patient directly to cath lab instead of imaging, and we did an angio that further baffled us because angio was normal. So, and then what to do? So the only thing we can do in this patient is just to stabilize, his perfusion and his metabolic shock. That's what we thought, because we were not aware of the reason what he was going through. And this won't give you sufficient support, and this doesn't work because patient is throwing into repeated VFs and VTs, and we just went ahead and positioned VA ECMO. And to our surprise, after VA ECMO, this was his ECG. So he dramatically improved. Only one finding in him was his potassium was very low, that is 1.9. But we don't have a clue why it was low. So later rhythm stabilized. We continued VA ECMO for 48 hours despite rhythm stabilization, and all metabolic parameters settled and no inotrope requirement. Then we removed VA ECMO. And later, 2 days later, patient revealed what he has done. Basically, he took caffeine overdosage. So he took almost like 100 tablets of caffeine. So, and no one knows what is going on. So that's a reason for his VT storm. And another case of ACS with cardiogenic shock, and this patient, a cardiomyopathy, ischemic cardiomyopathy, presented with ACS and with decompensation. So in all such patients, and there are no apparent ECG changes, you can see this is a LV. So I'll just take 2 minutes more. So this was his LV, and this was his coronary angio, total occlusion of LID, total occlusion of RCA. So in such patients with the cardiogenic shock, already stage C, and on inotrope support, needs revascularization and turned down by surgeon, and these are the risk scores. So what device we can use? Of course, again, this may not work, because if this patient really needs, in the course of procedure, this won't really support anything. So out of other two devices, the most important thing is RV function, because often in these patients with chronic heart failure, even RV can be a problem. So, and you can see almost 50% of patients, even RV is dysfunctional. So assessment of RV is crucial. Once you put impella, your RV function will further come down because of the septal movement and septal pull towards LV. And all these assessments helps you in understanding RV function. And best is the PAPI. Take PAPI, pulmonary artery pulsatility index, before you jump onto device. And if the PAPI is good, then it is isolated, LV dysfunction. That's where, you can use only impella. So since this is one algorithm which we can use, we used impella and we revascularized. You can see this is RCA, and this is LAD which we opened. and subsequently, we weaned off after 12 hours. Since he was in shock, we took more time to wean off. And this is the wean off protocol which we used for this patient. And another patient, similar cardiogenic shock, triple vessel disease. But this patient, as the shock was not responding to, conventional strategy, so intensivist already moved him on to IABP. So IABP was inserted in the middle of night just to stabilize his shock. And in the morning, we took the patient for angio, and you can see again the triple vessel disease with RCA total occlusion. And it's a poor LV. So how to go about, whether to continue IABP and do intervention, or you want to use another MCS for good support. So we had a discussion, and this patient is basically a father of our VA ECMO in charge. So, and we had a discussion, and we decided to move on to, VA ECMO, because it may not support IABP if really I need during procedure. So, and access management is very important. Already IABP is there from left groin. So we used right groin for VA ECMO. And this is when we can use this technique. So you can do PCI through the VA ECMO sheath instead of taking one more axis. That is what we did. And this is a technique which can be used in such patients. So we continued VA ECMO along with, IABP. Probably thinking, requirement of afterload for this patient after procedure. You can see, in fact, his LV gone bad after procedure. So, and we felt that decision of VA ECMO was correct, just to tide over, procedure. But this is what happened after that. So, this is very important. These devices can give you a lot of issues. Patient went into limb ischemia on the side of, VA ECMO. And again, it is only distal ischemia, mostly because of the distal perfusion. He also developed a GI bleed on day 3. And finally, we lost the patient despite everything. So, to conclude, a structured cardiogenic shock response team is very important, to change outcomes, not just the devices and medicines. And consider MCS if shock is progressive despite conventional therapies. And assessment of RV function is very important to decide the type of device, and availability and also affordability also plays a key role. And early detection and management of complications is key again. And of course, we need to learn more on these devices, when to choose, when to shift patient under device and right patient, right time, and how to wean off all that stuff. Thank you.
Thank you, Sharat. This was an excellent talk. You really showed nicely which device is apt to do what support. And I think we have to see this together with the next talk. But I want to ask if the panel has to pose a question to Sharat.
Early introduction of MCS is better. So we have to decide earlier. Just in the third case, you kept overnight in the ABP, and then you went ahead with the Impel Isinat.
Yeah.
So instead...
No, IABP plus VA ECMO, yes.
VA ECMO, yes. So it is better to go and decide early and do the procedure early.
Yeah.
That is a strategy as far as MCS is concerned, is it not?
Yeah.
Do you accept with me?
Yeah, see, the reason why I showed third case is often when these patients present in middle of the night, so that is when, initiating VA ECMO, Impella becomes, very difficult. Even in my center, despite, we have all the teams, so it becomes very difficult. So that's when sometimes it so happens that, they put an IABP to just tide over the crisis and manage, shock, not to let the patient deteriorate further. And then, we have to, these are the real world problems. So, and morning we had to take the case up for procedure. And that's when I have to decide between whether to switch to another MCS or, continue both and do procedure. So there are some choices to make. I mean, I have to make some choices. Yes, it is
Dr. Reddy,
difficult.
not a question, but a comment. Very good presentation. This idea of having a shock team in place in high volume centers make a real difference, I guess. It's a very good idea. We have PE teams, these are all kind of structured teams. In big setups, I think having a shock team in place, we don't have any in Pune.
And everybody does one job at a time.
Perfusionist,
I agree.
having an intensivist on board, alerting them, like VT storms. If you have a team in place, it's a fabulous idea.
And I just would like to ask one question. What is your crossover time? If patient is not responding with whatever mechanical circulatory support you had done, then how long you will wait and what is the crossover time?
So in our center, we assess patient every 4 hours.
Okay.
And we analyze data. Shock team will analyze data. And our cardiac intensivist is the key in the team. So every 4 hours, 4 to 6 hours, we analyze data. And if patient is not responding and deteriorating despite whatever stuff we are doing, then we'll move on to the MCS device. Yeah.
Good. Yeah. Thank you. Thank you for your excellent talk. And with the interest of time, shall I invite the next speaker, Dr. Poorna? The topic is LV unloading in VA ECMO.
A very good morning to one and all present here. So, unlike the previous presenters, I'm going to present more of data and less of clinical scenarios here. So, my topic is on LV unloading in VA ECMO, evidence, controversies, and real-world practice. And again, the data is very split in this regard. So, in a VA ECMO, it's a centrifugal ECMO pump, which is preload sensitive and limited because of the afterload. We want to achieve a native cardiac index and also allow an ECMO flow that is capable of organ perfusion. We want to achieve ventricular decompression so that myocardial ischemia can be prevented. The reason being coronary perfusion pressure is diastolic blood pressure minus LV end diastolic pressure. So in the presence of a VA ECMO, when the end diastolic pressure rises, the coronary perfusion pressure goes down. And we want to achieve an ideal map that will balance tissue perfusion with afterload reduction. So this ideal map, it can change from person to person. In a young adult with acute myocarditis, this map goal can be lower. But in an older adult with diabetes or peripheral vascular disease, we may have to aim for a slightly higher mean arterial pressure. So these are all individual and case-based. And again, mortality after cardiogenic shock is really high. So there are two concepts. One is venting and the other one is unloading. So in venting, we reduce the volume, we decompress the left ventricle, and we reduce the end diastolic pressure. In unloading, what we do is basically reduce the myocardial oxygen consumption. We reduce the myocardial work. We let the myocardium rest and recover. So these are two different concepts, although the terms are used interchangeably. So this is again the same scenario, and we see that we want the pressure volume area to be less so that the myocardial work done is less. So this is a fine balance between decompressing the right ventricle and preventing LV distension. So we want to make sure that the RV is not overloaded. We want to give enough ECMO flow. At the same time, we don't want the afterload to be too high that the left ventricle becomes too spherical with reduced pulsatility. So there are two main contributors to resistance in the ECMO circuit. One is a venous inflow and the arterial outflow cannula, and the other one is a gas exchange device. So we all would have learnt Poiseuille's law in physics. So the resistance is proportional to the viscosity of the fluid, the length of the tube, and it's inversely proportional to the radius of the cannula. So basically the key concept is that the widest and the shortest cannula will have the least resistance and allow the most blood flow. So for example, let us take a person who is 100 kilos and weighs and is 5'10". So with a BSA of 2.18, the predicted flow is 2.18 times 2.4 liters per minute per meter square, which will be around 5.2 liters per minute. So the cannula which can give that is going to be the 19 and 23. So the other ones cannot give because we want to not have too much of a pressure drop. At the same time, we want to ensure that the cardiac output is being established with the cannula size and length. So there have been a lot of studies on LV venting. Some of them are retrospective studies, and then we'll also look at some of the trials. So in these first 3 retrospective studies, you can see the number of patients were 50, 136, and 421. And these are all patients with cardiogenic shock on VA ECMO. So some of them prophylactically or therapeutically administered LV unloading, and the LV unloading in the first instance was a transseptal device, and in the third was an impella. So in all of these retrospective studies, they found that the mortality was significantly lower in the prophylactic unloading group. So, and the secondary endpoints were like reduced pulmonary edema, reduced frothing, and increased, quicker recovery from mechanical ventilatory support. And then the next one is these 2 trials, Evolve ECMO and Early Unload trials. These were from Korea. And they looked at LV unloading either early on or as a rescue strategy if they met the criteria for LV unloading. And they also used transseptal left atrial cannulation as their LV unloading strategy. So in these 2 trials, they did not find significant difference in the mortality or the 30-day mortality. So the earlier were retrospective studies and these 2 were clinical trials. But the authors of this trial do say that they were a single center study and they only used transseptal cannulation. They did not use the other modalities of LV unloading. And it might also have been possible that the power of the study was too low to detect a subtle difference in mortality. So and then this is another study that looked at multiple trials and studies, and it included a total VA ECMO patients of around 17,000, and it excluded a significant number of these patients which who did not meet criteria, and the study population was eventually around 12,000. So no LV unloading was around 9,000 and LV mechanical unloading was around 3,000, and balloon pump was a major LV unloader in this set that they looked at. And as you can see, the in-hospital mortality was slightly less with mechanical unloading with a p-value that was significant. The on-support mortality was also reduced compared to the conventional group and with a significant p-value. The 2 things that were slightly high were cannula site bleeding and hemolysis, which were also significantly higher in the mechanical unloading group. And I think these are all things that we have known and encountered in our day-to-day practice. So these 3 are the recently terminated or ongoing RCTs. So the unload ECMO trial, they took when the lactate was more than 5, the inclusion criteria with a systolic blood pressure less than 90 or needing catecholamines, impaired mental status, cold and clammy, oliguria with a urine output of less than 30 ml per hour, previously on ECMO for 6 hours prior to LV unloading, and resuscitation time of up to 60 minutes, and include both acute MI and non-acute MI cardiogenic shock. So in this early unloading, again, all-cause death and then rehospitalization, all of these were not significantly different between the early unloading and the rescue unloading. The conventional approach is where they did a rescue and unloading if they needed. So these are the clinical outcomes at 1 year. So what are all the indications for unloading? If you look at it, one is elevated pulmonary capillary wedge pressure more than 15. If the aortic valve does not open or opens very minimally or opens very sporadically. If there is spontaneous echo contrast, which is a precursor for LV thrombus formation. And when the LVOT VTI is less than 10 centimeters, which is a surrogate of the left ventricular stroke volume. If there is ventricular arrhythmia, pulmonary edema or frothy secretions, and elevation in PA pressures, and when the pulse pressure is less than 10 millimeters of mercury, that shows reduced intrinsic contractility and the fact that the ventricle is going to balloon. So some of the pharmacological strategies that we use, because not all patients can afford LV unloading, and LV unloading also comes with its own set of complications. So as a heart failure cardiologist, I always like to think of what all we can do. Diuresis, or if there is renal issue early on, starting on renal replacement therapies to optimize the volume status. Using inotropes minimally, as minimal as possible, and if they have a higher MAP, then what our MAP goal is, then start them on vasodilators or inodilators to reduce their afterload. And the thing that we want to look at is getting the lowest ECMO flow on board to achieve perfusion without distending the LV, and avoiding infections is also very crucial. So this is something that we can look at patients who come in with VA ECMO. So we first assess them. They are on VECMO. We do serial echocardiograms and then look at the LV volumes, LV sizes, and the VTI pulse pressure, and then assess the lactate and their urine output, and then decide when and where to place the unloading device and if they really need it or not. So in our clinical practice, it has been back and forth depending on the individual patient. If it is a patient who's coming with a, say, Takotsubo syndrome with acute cardiogenic shock who needs like a VECMO, those patients usually tend to recover. We don't think of putting them on unloading device. If there is somebody who has come with an acute anterior wall MI, I think in those patients, LV venting really helps. And in all these acute and chronic decompensated heart failures, we are not thinking of unloading or reducing the myocardial oxygen demand because they're already, their preload reserve is exhausted. So in those patients, all we want to do is just vent, reduce the volume and the pressure. So in that case, even an IABP with inotropes might be useful. Thank you.
Thank you very much for giving a good insight about the VECMO. I will ask any panelists or have any questions.
Thank you. That was a great presentation. What is your opinion of the short-term results of ECPELA versus no unloading? And
yeah, as a heart failure cardiologist, I always like Impellas. The one thing that I fraught with during training was that the Impella CPs would always keep moving and we had to keep going and repositioning them and all that. But with the advent of Impella 5.0, which was a axillary cut down, and those the position was quite stable and it did not create as much hemolysis. So in short term, if we know that this patient is going to recover quickly and it's going to be like for a very short duration, I think yes, it's a great option provided the financial situation is possible. Because it greatly unloads the ventricle. Impella is a great support provided the RV is not too bad.
Yeah, but what are the challenges you face during VECMO?
So during VECMOs is that we have to put them on inotropes sometimes if we can't unload the ventricle, and when we put them on inotropes, the increasing myocardial oxygen demand is there, so the end organs don't get better and the LV is not recovering or resting. And again, when patients go on VECMO, we have to have it for a short period of time because the longer they get infection, line-related infections,
and anticoagulations and other strategy also. There are challenges in a very sick patient.
And in our situation, we can't keep a PA catheter in for a very long time to assess the hemodynamics as well.
Okay, thank you. I think very good presentation. Now I would like to invite Dr. Harinder Pali, sir, for a talk on mechanical circulatory support in the AMI cardiogenic shock. Yeah, over to you, sir.
Can I have this projection, please? I'll be speaking on mechanical circulatory support in acute myocardial infarction, cardiogenic shock, why the trials disappoint. And I start with my 81-year-old female patient who presented with acute coronary syndrome, cardiogenic shock, had global hypokinesia with ejection fraction of 25%, surgical turn down, and this is what we found in angiography. Heavily calcified left main bifurcation disease, mid-LED disease, and the multiple views you can see heavy calcification, aleocaudal view, and then we had a right coronary which is critically narrow, heavily calcified, and we decided to go ahead with an angioplasty stenting and on an ECMO, a protected angioplasty. An ECMO 3.5 was put in. A rotablation of the right coronary was done. After that, we did 3 stents in this patient on the right coronary. And after that, we found that optimization of stents, the right coronary was taken care of. This is the final result on the right coronary. And then we went to the left coronary system, did a left angioplasty stenting, again rotablation to prepare the bed. And this is the rotablation 1.5 millimeter balloon dilatation. And then we did a DK crush and the left main bifurcation. Mid-LED stent, DK crush, angioplasty stenting, PART, all steps being followed meticulously. Optimization of the stent, and then we finished with an OCT, which showed that both the stents were very nicely deployed. This is OCT run, and we had a good result of that, and impella was removed in the cath lab, and this was one of our initial cases. The second case is an 89-year-old male, a journalist. He presented with a cardiogenic shock after an ST segment elevation myocardial hospital in a different hospital. He was put on triple inotropes. On triple inotropes, he continued to worsen, and he was shifted to our center for a protected angioplasty stenting. So we knew that he had calcified coronaries, and we started by putting a right heart catheterization, and then put a impella 3.5, and this is what we found on the left system. A left main critically narrow, heavily calcified disease, circumflex, non-dominant, totally occluded, proximal total occlusion, and left main to LED lesion was long, and right coronary had a CTO. Right coronary was filling via retrograde route. This is the right coronary. Starting from the ostium, heavily calcified vessel, and completely occluded in the mid vessel, filling retrogradely. So we went ahead and did an angioplasty stenting of the left system after putting an impella. And then we did a IVL in this patient for plaque modification, a 3.5 millimeter IVL. And then we did put in a stent in the LED, another stent in the left main to LED, and optimize that stent. You can see the stent, 2 stents in the left system. And after optimization, we got this result, which was very satisfactory. And then we thought that the patient was tolerating the procedure well. It's a good idea to complete revascularization, because we know that long-term results of complete revascularization are far better than single vessel angioplasty stenting. So this is the result on the left system, and we did the right coronary, which was completely occluded, heavily calcified vessel. We crossed it with a filter XT wire, and after that we did a balloon angioplasty, did a rotablator on the right side, and this is 1.5 millimeter balloon, and then deployed 3 stents in the right coronary to complete circulation and optimize those stents. And this was also an image-guided angioplasty stenting, and this is what found on the right coronary system. The complete revascularization done, protected angioplasty in a patient who had cardiogenic shock. It was shifted into the CCU, and impella was removed in the CCU. The OCT was done at the finally. Now, we have a lot of data on protected angioplasty, PROTECT series, which has shown that progressively the results are improving. Now, the PROTECT 4 is in, the enrollment is almost complete, and it has shown that we can do a complete revascularization in Impella patients, and the complete revascularization gives us a better long-term result than incomplete revascularization. And we also know that left ventricular ejection fraction improves when we do an angioplasty, which is protected angioplasty. And this left ventricular ejection fraction improvement is more in those patients where ejection fraction is very low to begin with. Lower the ejection fraction, better the improvement. And we also know it from RESTORE trial, improvement in heart failure symptoms, angina symptoms are better. And progressively these trials have shown, PROTECT 2, RESTORE, and Roma Verona trial have shown that angioplasty gives us longer long-term results and improvement in ejection fraction, which continues to do well. And we also have long-term results of DANGER trial showing that there is improvement over a long period of time, which persists. And so data is improving and we are getting better results. So we also know that with more experience, better devices, smaller French devices, the complication rates are progressively improving, and the local site bleeding and complication are decreasing. But still we are not there. We are not there because of the fact that we continue to have some complication of the local site because of large bore problem, and the Impella is put in much later than what it ideally should be. We should be putting it prophylactically. But protected PCI has shown that it improves life, and it enables us to do angioplasty stenting in very sick patients. And patients who have very low ejection fraction, we can do a complete revascularization. Patients tolerate complete revascularization. We can use all the devices in such patients. It also shows that AKI and other complications are lower with protected angioplasty. But why the trials do not show us as good results as we would have expected from what we have seen on our clinical practice is that the diagnosis of cardiac shock is delayed. We wait too long for patients to be taken up, and MCS is employed much later than what it should be. It should be done prophylactically, and large bore complications still continue to be there despite improvement. And with the lesser, smaller devices, we expect more experience. We expect things to improve, and that is what we need to do. And cardiac shock continues to have high mortality, even in the best of centers, about 30% mortality. But we are improving, and we feel that we can save lives by using a protected angioplasty and doing a complete revascularization in these patients. Thank you.
Thank you very much, sir. Very nicely demonstrated in your cases also that how Impella changed the outcome of a high-risk PCI. Very well done, sir. So my questions to you, sir. The Impella, we forget majority of the time the right heart cath. So all patients of cardiogenic shock, we should do a right heart cath. And if there is a right-sided abnormal hemodynamic, what is the role of RV?
Yeah, I think it's very important to recognize that cardiac shock, a lot of patients, about 1/3 of patients will have a right ventricular dysfunction. And we can recognize that by doing an echocardiography, as Dr. Sharad also said, by echocardiography we can do. But in all our patients now, we have a right heart catheterization.
Yes.
So we can diagnose that part. And if patient has a right ventricular dysfunction, Impella alone is not going to help. Either we add on to an ECMO, or we can use some other device to support the right ventricle, which could be right ventricle Impella, which is not available in India.
Yeah.
But we need to recognize that right ventricular dysfunction is an important component of cardiac shock.
And sir, one more question is, if patient, you have been given a call, like a patient is out of hospital cardiac arrest, you don't know the neurological status, and patient is in cardiogenic shock. So what is your strategy in such?
What we need to recognize is that large studies worldwide, registry data have shown that if a patient has out of hospital cardiac arrest,
Yes.
or even in hospital cardiac arrest, the mortality is much higher.
Yeah.
And the longer the cardiac resuscitation takes, longer than 10 minutes or so, then neurological problems do come in. And it's always been shown that mortality in such patients is to the tune of 70%. And mortality is because of neurological complication rather than the cardiac complication. So there has to be a clinical evaluation, involvement of the neurologist, to see that
So you
patient
have
is
to take
up,
a risk-benefit
neurology,
ratio. Yeah.
brain status is proper,
Okay.
and only then take it up. You may save the heart, but lose the patient because of neurological complications. So it's extremely important to resuscitate fast and to intervene fast in such patients rather than wait too long.
Yeah. Thank you. Any questions?
Sir, are there any specific objective criteria for this prophylactic use of in
Yeah, I think we have
devices?
international SKY criteria for use of protected for Impella, and now we have Indian guidelines also. So we have scoring system to see when we should go ahead, but we should intervene in early stage C rather than waiting too long. So taking all the clinical parameters and hemodynamic parameters, we must intervene early. This is a very, risk benefit ratio has to be valued. We shouldn't be intervening too early because large bore complications and cost factors are important components. But as soon as the patient is deteriorating and we are requiring higher dose of inotropes, lactate is rising, so we should be intervening in those patients.
Sir, excellent talk, sir. And the infarct-related artery, even if you open, sometimes the pump failure continues because of the coronary microvascular dysfunction. Coronary microvascular dysfunction. So, in one case, you have shown all the three vessels you have opened. Is it necessary to open the non-culprit also?
See, the data from the culprit shock syndrome showed that culprit vessel angioplasty alone is important, and that gives better results than doing a complete revascularization. But here we are doing a protected angioplasty. Culprit shock did not include patients on Impella. Now, patients who are in Impella with why did culprit shock patient not improve well? Because the contrast load was larger, and the time taken to do complete revascularization, and they tried to do total revascularization plus a completely occluded vessel angioplasty as well. But when we are doing a protected angioplasty stenting, patient tolerates the procedure well, and we can limit the load of contrast. And it's been also shown that if we do an image-guided angioplasty in these patients, the contrast usage is much lower, and we can complete the procedure in a shorter time with a lesser contrast, with the kidney being protected. And Impella is a costly device. If we have put it there, we should try to do a complete revascularization. And we now had data to show that complete revascularization in protected angioplasty gives better long-term results. So that is why we went ahead and did a complete revascularization in that patient.
Thank you, sir.
Thank you very much, sir.
Thank you.
It was excellent tips. And with interest of time, I think we would like to invite another.
Thank you.
Yeah, thank you, sir. Yeah. I would like to invite Dr. Trupti Deb, madam. Very interesting. The complications of temporary mechanical circulatory support. Yeah.
Okay.
Good morning, everybody. I'm Dr. Dev from Hyderabad Apollo. And when Dr. Sarita told me about this topic, I was so happy to share one of our very recent, very complicated cases. And I'm very indebted to WinCars, WCC, Sarita Rao, and Roshan, and all the WinCars Association for giving me this opportunity to share our experience, complication which was occurred recently and how we tackled it and how we got through it. That is the main important question, and how to handle it. That is what I'm going to talk now. So the determinants of outcome, whether it is grave or it is better, was already discussed by my previous speakers, and now I'm coming to the case. This case came recently to us from a different institute, like it was about 250 to 300 kilometers away from Hyderabad Apollo, and it was near Kurnool. This 51 years old patient who had multiple comorbidities had acute inferior wall MI on 13th of February, and he was thrombolized out of another hospital and shifted to Kurnool Apollo Hospital on 14th, and he was in cardiogenic shock. They called our Apollo, main Apollo, Hyderabad, and our shock team came and they went all together, including critical care interventionists and the vascular surgery team and the cardiothoracic surgery team. They took ECMO machine with them because it was right ventricular MI, so they wanted to deload the RV. And in the midnight, at about 2 o'clock, they put ECMO for this patient on 15th of February. And with the inotropic support, which was on board, patient was shifted to Apollo, Hyderabad, and immediately taken to the cath lab. And though the immediately coronary angiogram and the stenting for the culprit vessel, that is RCA, was done, and even after doing the RCA angioplasty, the patient was not stabilized. So to devent the ventricle and to improve the right coronary circulation, there was another escalation was done and IABP support was started, and then this patient improved and slowly the hemodynamic status improved. Though I will show you the coronary angiogram where you can see that there were triple vessel disease, only the culprit vessel was taken care of, and the patient had multiple complications according to this list you can see, and then that was tackled with the covered stent, and all the vascular complications was tackled immediately because of a big team. All the cardiothoracic as well as vascular team, as well as our cardiac cardiac coronary care unit and the cardiologist and the entire nursing team, everybody was behind. These are the few angiographic views I want to show you. And the patient had RCA culprit vessel done successfully. After that also, IABP support was started in escalation to improve the hemodynamics, and the patient was shifted to ICU. After 2 days, when the explantation of ECMO was done, that time patient crashed again, and we saw that there was some vascular complication, and there was a common femoral artery had a rupture, and that was bleeding, and that was stented, covered stent was put, and there was an axillary artery that was also had some, after explantation, some bleeding and perforation, that was also stented with a covered stent. So this case was tackled somehow with all the, even the CRRT was done, all kinds of complications were tackled, and finally he was discharged 15th day post this thing, implantation, post PTC. Successfully, now he is under follow-up, and after 1 month he came for follow-up study recently, and he is fine. His ejection fraction has improved from 15-20% to now 40%. He is walking around, no vascular complication which were tackled already, and luckily I think it is a profound combination of support from the entire team and fast, like everybody is saying, that earlier we start deloading the ventricle and the vascular complications, better we get the results. And that is the result from this patient. These are few cases we have done in our center, not many cases though. But what we found that women has got a worse cardiovascular complication rate, and our mindset is so strongly against putting the, any mechanical circulatory assist devices for women. We try to avoid because we think that they will have more complications, and these are the reasons why the vascular complications are more in women, like they have more vessel perforation, more dissection, more pseudoaneurysms, and major bleeding. There are a lot of studies amongst the women where we have seen that they get into higher risk complications, so that on their presentation, everybody shy away from putting the mechanical circulatory support. These are another key complications risk which are associated with in women. So these are the studies I have given, and they show that if we start, though in spite of circulatory complications, if we start the mechanical circulatory devices early support, the women do much better as compared to men, and that too in young women. So we can support many young women. Actually, in my practice, I have lost many young women because we shy away from putting the early circulatory devices. So this contributory factor of biology, women have smaller peripheral vasculature, delayed treatment, and this is the presentation is very delayed. So what we should understand from this is, if we have to use MCS in women, we should not shy away. We should start doing as early as possible and use full-fledged mechanical circulatory devices, whatever is feasible and applicable. Then we get the better results. That is the major, my take-home message. And as Abdul Kalam sir told us, that healers are the sacred. They touch our hearts and heal our ailment. That is why the woman needs the first-hand treatment much better than men. Thank you very much.
Thank you very much, madam, for your excellent talk and the case also. We should always, all the supports we need, we should not forget the groin, the access site and all. If patient is losing it, not improving, then we should have our checklist. And irrespective of, I think, gender, earlier in all the cardiogenic shock trials, earlier stage, if you do these devices, I think every life do better. Have a seat, madam. Any question?
Thank you for this excellent talk, Tripti. I'd like to ask a question concerning resources. In Austria, we do not have all these devices in every center that does acute service. And for instance, if we have an out-of-hospital lysis done, we would not consider this patient a candidate for a Gemella, for instance. And when we have seen the maximum that is possible, that is a Gemella, and but we face the situation also in Austria that we have restricted resources. So how are you coping with this? Are there like rules? Is there age limits? Is there what is the way? How do you attribute this resource to the patient?
Speaking, your question is very, very good and pertinent to our Indian scenario. Most of the patient was treated from a village and in a very lower, smaller area, like less than a state level. And there he was thrombolized on 30th of April. And after thrombolized, they thought he will stabilize, then they will shift to little first stage, means the first referral center, that is converted. And from there they will shift our. But in between the patient can stabilize, spite of inotropic supports, and then we decided to send the ECMO from our institute, going all the way 500 kilometers that place and putting on site. That was the best thing they did. Otherwise, he would not have recovered. But if you see, other than this, these two devices like IABP and ECMO, putting Impella or ECMELA, which is the ideal for this case, young man, I agree with you. But we have lot of constraints, not only availability constraints, but the money-wise also, support-wise also. So that is the main issue. Otherwise, we had only one or two cases of, ECMELA done so far, not many. And this case was done by your student, Dr. Rahul. This is Dr. Rahul's case, and it was done in our unit. That's why he told me to tell you about it. I told him about it.
I have to say, Rahul Kongara was a very special fellow at our center, and I know he has promoved. He's really extremely doing great stuff. And he knows that we have the same problem. It's not that we can have the service for every patient. So we struggle with how to attribute the resources in the best way. I'll say hello to him, and I'm very happy to hear that.
So that's why we do more of a IABP support, and whenever such hemodynamically unstable, before intervening only, we put IABP in the EMS and then shift the patient to the cath lab, so we can preserve as early as possible.
So I'll just add on to what you had mentioned about resources, and definitely in our constrained settings, Bella is not easily available for unloading. So our strategy for peripheral VA ECMO is put a transseptal cannula from the RA into the LA, so that unloading. And then the other option we have, either with peripheral or with central ECMO, is put an LV event via thoracotomy. That is much more affordable and provides very good ventilation. And ma'am, just one question I had. What is your opinion on ultrasound guided access for reducing vascular complications?
Yes.
Is
Yeah, all the patients we do use, but this was in a peripheral setup where they have put the ECMO in an emergency in midnight at 1 o'clock before shifting the patient. So I don't know, there was some problem probably that time only. It was really unstable. Somehow we were, stabilizing till we realized that this is happening.
So I conclude the session over here, and I thank all the speakers, my co-chairman, and the panelists for having a wonderful discussions on a very important topic of temporary mechanical circulatory support. Thank you. Yeah.
Thank you so much, everyone, and it's delightful to be here in this meeting. And I firstly thank the organizers for giving the opportunity for me to provide the platform to talk about provisional stenting. So my focus is mainly going to be provisional stenting in left main coronary artery disease. We know that the plaque burden in atherosclerosis in left main coronary arteries is actually mostly in the non-carinal aspect, and very little on the time and the carinal aspect, because of the flow divider region is much less compared to the non-carinal aspect of the coronary arteries. We also know from the data, particularly the intravascular ultrasound data, that the plaque extension from the left main coronary arteries also travels into the LAD 90% of the time, circumflex in 66% of the time, and both the LAD and the circumflex in 62% of the times. We also know that the left main coronary artery undergoes positive remodeling, while the ostium of the left anterior descending and the circumflex undergo negative remodeling. So with that background, I just go into the trials of the left main coronary artery management. So as you can see, the time frame from 2009 to 2017 or 16 is mostly driven by the differences between the CABG versus PCI. The trials are focused on the best outcome of treatment for left main, some either CABG or PCI. But over the years, we have known that the data from the Excel and Noble suggested that there is a criteria for the PCIs can be done in a better way, and therefore we moved on to a further trials looking into the different aspects of interventional treatment for the left main coronary artery. As you can see, the Noble and Excel had around 81% of bifurcation lesions. And even in those days, even the Syntax and the Excel and Noble, the provisional stenting strategy is around 60 to 65% of the time. You know that the majority, even before the EBC main, of the left main coronary arteries are treated with provisional stenting. This is just to show how the impact of the bifurcation angle changes how you look at the anatomy. So if you look at the two side branches, which are equal in size, but if you have a one which is a 90-degree angle, the plaque burden is the same. You see that the 90-degree angle bifurcation has a higher ostial narrowing compared to the acute angle bifurcation. As you can see that the ostium is not that much involved. So that needs to be taken into account when you do provisional stenting, particularly in terms of whether your bifurcation angle is acute or very more than 90 degrees. And that will also have an impact on your stent platforms and how the stent deform, particularly when you have a 90-degree angle in the bifurcation lesions. So coming straight to the point about the provisional stenting strategy, we have two important data coming from the EBC main and the DK Crush 5 trial, looking at the differences in outcomes between provisional stenting strategy and the two-stent strategy. As you can see, one of them is mostly Asian centers and Italian centers, and one is from the Europe. And there are slight variation in the variety of patients, particularly the EBC main has a lower syntax score, so lesser complex patients compared to DK Crush 5 trial. So what we also know from the data that in terms of the provisional stenting strategy arm had a 1 in 5 patients underwent two-stent strategy in the EBC main, whereas in the DK Crush, the provisional strategy arm had 45% crossover to the two-stent strategy. Nevertheless, the data suggests that in DK Crush 5 trial, the two-stent strategies has a better outcome than the provisional stent strategy in highly complex coronary artery disease in the left main coronary artery. Whereas in the EBC main, the first year data suggested there is no difference in terms of MACE outcomes, whether you do a provisional strategy or two-stent strategy. So, but you know that the EBC main has very specific criteria how you do the provisional approach. It's a step-by-step layered approach. According to the EBC consensus, you have a PART which is mandated immediately after you deploy your first stent, and the kissing balloon is also mandated. Where the systematic approach has also a step-by-step approach at each level, whereas in the DK Crush, there is no systematic approach in the provisional stenting strategy compared to the EBC main. Just coming to other few data about the differences between the two studies, looking at the KBI after first stenting, you can see 90% in the EBC had KBI after even in the provisional arm, whereas we don't have a major data about that in the DK Crush. But the final KBI is around 80% in the DK Crush in the provisional arm compared to 90% in the EBC arm. Otherwise, I think the transformation data is the same as before. So we also have more data from the 3-year results, suggesting that at 3 years, if you have a stepwise provisional approach, your repeat revascularization rate is much lower than the systematic dual stent approach. I think that is a very important data suggesting that provisional strategy should be your default strategy in most of your left main cases, unless you have a very complex anatomy as we discussed. So essentially the definition criteria which you all use to decide the complexity of your coronary anatomy needs to be accounted if you have LMCA with a side branch lesion of more than 70%. You have a minor criteria such as calcification which is more than moderate, bifurcation angle which is acute, or more than 70 degree, main vessel lesion of around more than 25 millimeter, or you have multiple lesions, or a main vessel reference vessel diameter is less than 2.5 and a thrombus. These are the minor criteria which take into account when you have a definition criteria. If you have a more than 2 minor criteria, you have to go for a 2-stent strategy, and particularly if you have a decay crush, as we have shown in the previous cases. So coming to some of the important aspects of provisional stenting strategy, is a size discrepancy nowadays a major issue with distal referencing, particularly your left main stem compared to the LAD? Definitely not, because we know the stent platforms have changed. We in fact have better platforms than this. This is a slightly old slide suggesting that most of your 3.5 stents can go up to 5.5. In Indian context, most of our left main is unlikely to be more than 5.5. Even if you have more data coming that the newer generations of the Boston and the Terumo stents can go up to 6.25 if you have a 4 or a 3.5 or a 4 millimeter size. But we also need to know that some of the transition zones are the 2 to 3 different platforms in the Boston and compared to 2 different platforms in the other stents as well. How do you do your PART? I think that's the most important. Even though we call provisional stenting strategy or a much more easier strategy, but at least unless you do your strategy in a very methodical and a stepwise approach, you may not be getting the best outcomes. So looking at the PART, we know the PART balloon, ideally there should be actually 2 PART balloons to be used, one referencing to the distal main vessel and then a one for the proximal main vessel. So the more and more data suggesting that it's better use 2 PART balloons, one for the LAD, ostial LAD, and then a left main PART balloon which should be much higher, and you should place the PART balloon at the level of the carina so you get a not jailing of the stent in the side branch ostium as such. We also need to understand the differences in the stent configurations and the designs. Certain stent has got peak-to-peak design and certain stents are peak-to-valley design. Nevertheless, that will also ideally decide your side, the wiring of the side branch. After your first stent stenting, you have a much more better areas in the peak-to-peak design compared to the peak-to-valley design. Coming to once you have your wire into the side branch, you need to decide your ballooning strategy for the provisional kissing balloon inflation, and most of us moved from the Murray's law to the Finnett's law. Finnett's law, as you can see, that it's a two-third of the rule. So if you have your parent vessel diameter is equivalent to a 0.68 times the combination of the main vessel, distal main vessel, and the side branch vessel. But we also know there is one more data coming from the Japanese data, the intravascular ultrasound data, on the principle that your parent vessel actually, the left main stretches asymmetrically up hugging the kissing balloons, and that needs to be taken into account. But the Mitsudo formula said that if the square of the parent vessel is equivalent to the square of your side branch vessel, but the easiest form is they have come with a table which, depending on your size of the distal main vessel and the side branch vessel, you can decide the PART balloon. Similarly, for your kissing balloon, depending on the size of your main vessel and the side proximal and the distal main vessel, you can choose the side branch vessel as well. So if you look at the Finnett's law, if you tend to use the Finnett's law, it tend to underestimate the size of the parent vessel while overestimating the size of the side branch vessel. So the rule of thumb is, if you are going by for the Finnett's law, you get a diameter between the 2 balloon sizes. For the PART, you use the larger diameter of that, and if you have a diameter between the 2 balloon sizes for the side branch kissing, you use the smaller size of that. With that into account, I'll just show you a few last slides. These are the cases we had about using the provisional stenting strategy and then using a drug-coated balloon at the side branch, and you can see the stent from the left main to the LAD and a drug-coated balloon into the side branch, and that gives a good result. So the take-home message is provisional stenting strategy has become the default in most LMCA PCI after the EBC main results. So the idea should be keep it simple and safe, but methodical stepwise approach is important to achieve excellent clinical outcome. Imaging has become mandatory, particularly in left main PCI, even though the trial data didn't have that much of imaging, but now you have to use imaging. KBA with appropriate balloon is recommended in most patients, and drug-coated balloon to the side branch ostium is still under investigation in randomized control trials, but there are more and more usage of this in the use of drug-coated balloon in the side branch. Thank you so much, Philip.
I think Dr. Pankaj Manoria is ready and he will give the first talk. I was in bifurcation.
Can I have my slides, please? At the outset, I'm thankful to the organizers, Dr. Roshan, Dr. Sarita, for having me here. While we speaking about what is the role of IVUS in the perfect osteal fix, how can we use this IVUS for perfectly placing the stent in the ostium? There are two important reasons why there is high TLR in osteal stenting. Number one is there's always an ambiguity in the angiographic osteal landing zone. We're not sure exactly where is the correct ostium. And secondly, the stent motion resulting in geographical miss or too much protrusion into the main branch. So these are two important reasons why we have high TLR in osteal stenting. So whenever we are planning to place the stent right in the ostium, it's like hitting the bull's eye. But this is possible with intravascular ultrasound, and you can have a perfect osteal fix with IVUS. How IVUS can be used for perfect osteal stenting? There are 4 techniques on IVUS by which we can utilize this. We can use an IVUS marking techniques by using fluoroscopic cine while using IVUS, or we can use a marker wire technique, that means putting another marker wire. Thirdly, IVUS measuring technique, and fourthly, the real-time IVUS guiding, that means the live IVUS. I'll describe all these techniques with case examples in my coming slides. The first is the IVUS marking technique. How to use IVUS marking technique for correct osteal placement? Suppose this is we plan to place a stent right in the ostium. We are not sure where is the ostium. It can be in the first position, second or 3. It is not possible because of limitation of angiography to correctly reveal where the ostium is. Now, in IVUS marking technique, the first thing we do is we take an IVUS, we start marking a distal and proximal landing zone and calculate the length and diameter of the stent. This is the first step we are supposed to do. Secondly, we do again the IVUS, and once we see the ostium, we stop the IVUS there and take a cine. And how do I identify ostium? When there is an absence of media, when we start seeing the circumflex from the LAD pullback, that is the point of ostium. To stop the IVUS pullback, take the cine and take a cine at this point. In step 3, mark this as your reference image and remove the IVUS. You take as a reference image. And fourth, using this reference image, put your stent looking at the reference image on the live. You got my point? I'm placing my stent and looking at the reference image where my ostium is, because I have my reference image. The IVUS is marked there, and this is the correct position of the ostium. So I'll take the stent and park it exactly the same spot marked by the IVUS using this reference image. And then there will be the final confirmation of IVUS whether I have placed my ostium correctly or not. Here you can see, if you see the IVUS carefully, the stent is placed right at the ostium. Neither I missed the ostium now, nor it is too much into the left main. And this was possible only because I have my ostium marked by IVUS. So this is where I was supposed to place the stent based on IVUS, and this is exactly where I placed my stent. You can see exactly at the ostium I have placed my stent. It is neither too in nor too out of the ostium. So this is what we call as IVUS marking technique, and it can be used for precise osteal placement. Second is the marker wire technique. Usually we use marker wire when we plan a zero contrast PCI, but it can be used for perfect osteal placement. This is a case of 54-year-old gentleman, post PCI to LAD, again had an unstable angina, and we had an osteoproximal disease. So plan was to place the stent right from the ostium in the LAD. So in this marker wire technique, what we do is we take 2 wires. One is the operating wire, another is a marker wire. So if we want a precise, we have to take 2 wire connectors because the position of marker wire shouldn't change. If the position of marker wire changes, then there's no point using marker wire. So to prevent the position from changing, we use 2 wire connectors. Here, then in step 2, take the IVUS on the operating wire and bookmark the distal and proximal landing zone, and then again stop the pullback the moment you see the LAD ostium. This will be our proximal landing zone. So I've stopped my IVUS when I saw my proximal landing zone, that is the ostium. And now what I'll do is I'll pull that marker wire and place the radio-opaque portion of the marker wire exactly at the LAD ostium, where the IVUS is showing me where the LAD ostium is. I'll place my marker wire, the radio-opaque portion, exactly at that point. Now in step 5, I will close the 2A and remove the IVUS from the operating wire. Now, as in the steps, so this is exactly the place where I have to park my stand, because the radio-opaque portion of the marker wire is exactly at the LAD ostium.
Now I have to do nothing but to just place my stent exactly at that radio-opaque marker wire, because ostium is exactly at that point. Now in step 6, I'll take the stent on the operating wire and place it exactly at the proximal radio-opaque portion of the marker wire, which is exactly where the LED ostium is. And then I'm placing my stent at the proximal portion of the radio-opaque wire, and because the ostium is exactly at that place. Now then you deploy the stent, and then you check for your result. Now you can see here, with this technique, the stent has landed exactly at the place where I have planned my stent, because the marker wire was placed exactly at that place. So there are two precautions which has to be taken while using marker wire. We have to be inserted through a separate wire connector, because if you don't insert a marker wire through a separate wire connector, because the moment you place your stent or you remove the IVUS, the marker wire position can change. But if you are using two wire connectors and if you tie it very tightly, then the position of marker wire won't change. Third is IVUS measuring technique. This is again third technique by which we can use IVUS for precise ostial placement. This is the case of tight ostial left main stenting. Now I am supposed to place a stent right in the ostium. It should be neither too inside the aorta nor I should miss the ostium. So what I do is an IVUS measuring technique is, I'll first do an IVUS. Now here from angiography, it's very clear that we can place the stent just before the carina. If I place my stent just before the carina, I'll just bookmark this segment and I'll bookmark my aorto-ostial segment. So here I can see that my distal landing zone and proximal landing zone, the difference is 9 millimeter. So if I take a buffer of 1 millimeter, that means if I take a 10 millimeter stent and if I place it right at the carina, automatically the stent will land in the ostium. You got my point? Because identifying distal left main carina is easy than identifying ostium angiographically. So I'm looking, and now I will deploy my stent looking at my distal landing zone, because I know if I land my stent in the distal landing zone, a 10 millimeter stent, and the distance from distal landing zone to aorta ostia is 9, I am taking a buffer of 1 millimeter. So if I place my stent looking at the distal landing zone, which is easier to identify on angiography rather than aorta ostium. Aorta ostium is not able to, it's difficult to identify on angio, but you can easily see that your distal landing zone. So I will implant my stent using the distal landing zone. I will not see the aorta ostia now. And based on this technique, measuring the exact length of the stent, if I place my stent at the distal landing zone, automatically the stent will cover the aorta ostium. It will not be too much into the ostium. This is what was done here. And here you can see exactly the stent. You can see the stent landed only 1 to 1.5 millimeter inside the aorta. This is what we desired, and this was possible by doing this IVUS measuring technique, seeing the distal landing zone, not seeing the ostium. The final technique is the live IVUS. That means the real-time intravascular guidance. This you can do is, you have to place an IVUS in your side branch, and when you are planning to place a stent on live IVUS. Suppose I've planned ostial circumflex stenting. So I place my IVUS on the LED, and I marked my circumflex ostia, and then I'll place my stent looking at the IVUS, not in the angio, looking at the IVUS, because IVUS is showing me where my circumflex ostium is. So based on looking at the IVUS from the side branch, I can place live stent on by this real-time IVUS guidance technique. But there's some catch in this technique, because once you use a live IVUS technique, you see lots of artifact, because the stent delivery markers, balloon markers, proximal stent marker all have different reverberation, different artifacts. So you should be well versed, where's my stent marker, where's my balloon marker, then only you'll be able to do this technique. So this is my last slide, I can say. I think if you want to hit the bullseye, if you want to perfectly fix the ostium, you can use all these techniques by intravascular ultrasound, and you can have a perfect ostial stenting with ultrasound. Thank you.
Thank you, Dr. Pankaj. Please join us on the podium. And now I would like to invite Dr. Shanmusundaram to say that OCT is better than IVUS in fixing the ostium. And he's the Director of Cardiology from Velamal Medical College in Madurai. And he's also a world authority in conduction system pacing. He's now to bat for a different game.
Yeah, I mean, regarding your marker technique with IVUS catheter, the tip of the transducer itself is almost like 2 to 3 millimeters. And imaging exactly happens at the tip of the transducer. I think this point has to be kept in mind. Second, when you're using stunt, whether that stunt is on the marker or off the marker, that's again important. See, these two are important when we're using all these techniques.
Totally agree with that.
With the co-registration with IVUS can be very helpful positioning, and also the positioning of the stent depends upon what stent you are using.
Yeah, IVUS angiochoresis is very helpful, but unfortunately it is not available in majority of these machines. Newer machines do have this IVUS angiochoregistration. That is why we use all these techniques for manual IVUS angiochoregistration.
Quick caution on live IVUS, positioning. Operator should know how to differentiate balloon wrap from the marker in the balloon and then the stunt. So that's the first practice has to be done off table and then go to table. Otherwise, you'll be like confused completely.
That is very important because all these will cause multiple artifacts. The stent balloon marker will cause multiple artifacts. The shaft will cause some artifacts. So you should be well versed with what artifact is signifying which part of the delivery system. So because we have to place the stent at the form, we have to identify stent balloon marker. That is where the stent is starting. So that marker, how it looks on IVUS, we should be well versed with it.
Thank you, ma'am. Now I'm going to defend OCT for doing bifurcation PCI. So we know the role of imaging while doing complex PCIs because simple angiogram sometimes misinterprets the data, will not be able to get a favorable result what we want. So the role of OCT in bifurcation PCI, these are all the things which comes into my mind whenever I'm going to use imaging, especially OCT for doing bifurcation PCI. So I'm going to assess the behavior of the side branch. I'm going to see the calcium status, and I'll be seeing the effect of atherectomy devices if at all I'm using it, and how I'm going to wire the side branch, whether it is going to cross into the proximal or the distal struts, and whether there is any abdominal wiring, especially in ostial left main stenting, and obviously at the end I'll look for malopposition and under expansion. So when I was asked a question of diagnosing a humerus fracture, I would choose an X-ray which gives a complete visualization of the fracture zone rather than using a CT to diagnose a fracture. Similarly, when it comes to left main PCIs, I would rather prefer a OCT which gives everything in front of our eyes rather than IVUS, which is sometimes difficult to interpret the data. A little brief discussion about left main disease. It is different from LAD and LCX disease because it's going to be a large vessel with a variable diameter, with a variable curvatures, and you can have predominant atherosclerotic distribution of plaque at the bifurcation zones, especially eccentrically, and you can have a variable angulation between LAD and LCX, and most often in nearly 10% of the patient you will have a trifurcation rather than a true bifurcation. So OCT, which is powered by this A, is going to give analysis of the whole segment, not only about the length but also about the distribution of the plaque, calcium thickness, and everything in front of your eyes with a single run as compared to IVUS, which takes time to interpret. Let us assess the first point, how the side branch is going to behave when you're doing a bifurcation PCI. So we know the predictors of side branch closure when you're doing a bifurcation PCI. When there is an acute angulation, especially less than 50 degree, when there is a very short branching point to cranial distance of less than 1.8 millimeter, there will be a predominant plaque shift or kernel shift which will result in acute closure of the side branch. So this can be easily seen in, while doing a simple single OCT run. So this is an example of a complex bifurcation. This is involving LAD diagonal. You can see the angulation between the LAD and diagonal is nearly 30-40 degrees. So it's going to get closed acutely when you are going to put a stent from LAD onto LCX. So when you measure this acute angulation and that BPCT, so it's going to predict it even before you are going to put a stent. So in case if you want to have an alternative strategy, probably you can plan it well in advance rather than just putting a simple stent from LAD across the diagonal branch. There's another example where you can see a wide open side branch where the angulation is more than 50 degree and branching point to cranial distance is also close to 2 millimeters. So this definitely will tell us that the side branch is not going to get closed. You can just put a crossover stent across the resisted side branch. So isolated circumflex stenting where you believe that you will be able to get away without involving the LAD. You have to do a run both from LAD into L6 and LAD into left main and LCX into left main. assess the angulation, assess the plaque morphology, not only in the main vessel but also in the side vessel. So this particular patient, though the BPCT was just touching 2 millimeter, but both LAD and LCX had a significant desist, and more so in LAD where the ostium was showing more of a fat along with fiber. So this definitely will tell you that once you put a stent, definitely this patient will have a tight occlusion of the side branch. So rather than going for a provisional strategy, when you do a simple pre-procedural run, you'll be able to decide which patient will get a dual two-stent strategy and which patient can be taken away with a simple provisional stenting. So in patients with calcified vessel, it will be even more difficult because we don't know how the calcium is going to get distributed over the vessels and how it is going to behave whenever you are going to have a high pressure dilatation. This is one of our case post CABG where the lima got occluded. When we did a run, pre-procedural run, we got all varieties of calcium extending all the way from the middle eddy into the left main. So even the left main distal has concentric calcium. But the most important point to note here is the side branch. You can see that left circumflex was a huge vessel, but still it is coming out at a 90-degree angulation. Though there were some calcium nodules at the carinal point, but it was a wide open circumflex with an angulation of 90 degrees. So we know that we are not going to lose the circumflex unless we are going to purposefully dissect the circumflex ostium. So we did a simple left main to LAD crossover stenting with calcium modification. We used both IVL as well as non-compliant balloon at 3.75. And finally, we got a very good result. But unfortunately, just before coming out, I lost the guide wire. I had to rewire it and did a OCT run. There was some here and there malopposition and under expansion. But what I also found was there was an abluminal cross from the left main ostium. So this is very important to diagnose whenever you are rewiring after deploying a stent in the left main. So I know it will be very difficult to diagnose with the IVUS, but with OCT, it gives us a clear picture where the wire is and where the stent struts are. Though it was an OX OCT catheter, still it went through the struts and it was giving a complete visualization of the LAD and left main. But only thing, when we did an oblique images in the fluoroscopy and the OCT, we could see that the wire was getting into the left main abluminally. So he had to rewire it, did the final optimization. We got an excellent expansion of both LAD and left main stent. So when you have a doubt about the side branch, it's a very big left circumflex, and there was a haziness at the left circumflex ostium, though there was a tight disease in the proximal LAD. But there was a doubt about the circumflex ostium. So we did a pullback from left main, LAD into left main and LCX into left main. What we could see was there was a tight disease in the proximal LCX with some calcium, but also there was some disrupted plaque in the circumflex ostium. So definitely this is not, this crossover stenting is not going to work. You have to go for a elective two-stent strategy. When you go for an elective two-stent strategy, the main thing is recrossing. You have to cross it through the distal strut, not through the proximal strut. Why? Because you have to protect the carina. You should not have too much of metal crowding in the carina. When you do a proximal cross, definitely you will have too much metals crowding in the carina, which will affect the long-term clinical outcome. For this, I would definitely say IVUS is going to be, or OCT is going to be better as compared to IVUS. So I can show here in the 3D reconstructed image where the wire is getting in. Probably with the rotation, you know where exactly the struts are getting crossed. The wire is getting crossed across the strut. But IVUS, though you can show it, but it is very difficult to understand, especially for a person like me who's not into all these IVUS images. It will be difficult. But even a fresher who's a student can easily see where the wire is getting in with the help of OCT imaging. So once it is done, then probably next thing is to do a final port optimization, and you can see when you do a distal cross with a good FKB and a port, you can see a completely metal-free carina. So there was a query of ostial imaging of left main as far as OCT is concerned, but still we can do it by coaxial alignment of the guiding catheter with probably increased volume, and you can place one more wire in the aortic sinus to make sure that you profile the ostium well. So this is the most common strategy which we use whenever we have a doubt of left main ostial disease. We make sure that we use adequate contrast with a high force. Whenever you are using an injector, make sure that you are injecting at a 6 ml per second speed rather than 4 ml per second speed. So OCT definitely helps in the management of left main bifurcation disease. Though it is different from LAD disease, OCT will give us a lot of information, not only in terms of deciding the stent length, but also about the wiring strategy and what balloon you have to use and how you have to decide between a provisional plus dedicated two-stent strategy. So definitely there is a big advantage of orange over gray in bifurcation. With the help of OCT, you know what the calcium distribution is, whether you are crossing from proximal or in the distal state, malopposition, under expansion, side branch behavior, what is a carina, and more than that, you have a AA powered with a dynamic co-registration, which helps you and which tells you where exactly you have landed across the disease zone. So the future is bright whenever you're going to use an image-guided PCA. All the tough PCs these days will become a routine PCAs in the future. Thank you.
Thank you, Dr. Sarita Rao. Good morning to all. And the background is too much metal we all know is harmful. And any bifurcation strategy, however perfect you do with two stents, has inferior long-term results with increased ISR and stent thrombosis. But single stent in a provisional strategy may not address significant side branch disease. Using a POBA has limitations for outcomes, and DCB is an attractive option. Coronary bifurcations are 15 to 20% of coronary procedures. A hybrid strategy of DES in main vessel and DCB in side branch, KISS with 3S, keep it swift, simple and safe. Advantage of DCB is that it is superior to plain balloon and it does not distort the carina. It avoids stent malapposition and fracture. Complex steps of rewiring, reballooning are circumvented. There is no stent distortion in the main vessel and there is no miss of ostium in the side branch. And there are no multiple stent layers to deal with. So the DCB bifurcation study compared paclitaxel DCB with NCB in about 400, close to 400 patients. Females were 23%. The side branch should be simple, not complex, as per the definition criteria. The target vessel MI was lower at 1 year with DCB, and there was better luminal gain with DCB. This is the new true coronary bifurcation lesion algorithm. Lesion preparation is very, very important by whatever method, NC balloon scoring, balloon cutting, atherectomy or lithotripsy. If there is no flow limiting dissection, you can use DCB. If there is a flow limiting dissection, you have to use DES on MB, but DCB still can be used on side branch. Meta-analysis of DCB versus POBA in side branch, there is lower late lumen loss and lower rate of MACE. And DES in DCB has been shown in left main also by my good friend Rafai also showed a case. Better outcomes than DES alone. Reduces late lumen loss and target lesion failure. So appropriate use, you should not handle the DCB very carefully, you have to prepare it. And DCB application is feasible only if there is less than 70% stenosis in the side branch and the STEMI3 flow. DCB to artery ratio should be 1 and should be applied for a minimum of 60 seconds. And when you apply the DCB in side branch, it should extend 4 to 5 millimeter into the main branch and 2 to 3 millimeter distally beyond the pre-dilated area. And this is very important. And if you look at whether DCB based PCI or DES based PCI fares better, DCB based PCI fared much better, especially in the bifurcation lesion subset. So this is where you definitely have an advantage of using a DCB, and also in high bleeding risk where you can shorten the DAPT duration, keeping it more simpler may benefit. So I'll go to a couple of cases. A 58-year-old frail male, diabetic CKD ESRD on maintenance hemodialysis. He had an inferior wall MI, stented primary PCI RCA in 2023, now failed AV fistula. His echo has dropped from EF50 to 26%, and he came in a very sick condition with breathlessness, hypotension, recurrent pulmonary edema, and troponin positive. And this is his angiogram. Densely calcific LAD and diffuse distal disease. Also, the diagonal has osteal disease and diffuse disease. It is also extremely calcific. And his RCA is patent. So now what do you do in this scenario? So pre-dilated the LAD and diagonal, applied a DCB to the diagonal, and also distal and mid LAD 2 sequential DCBs were applied, and a spot stenting of osteoproximal LAD with IABP support. The procedure was done, and post dilatation, and this is the final result. So you have a TIMI3 flow in the diagonal, and you have a TIMI3 flow in LAD. It does not look very great, but it did work for a functional recovery. Patient was removed of IABP. He was returned to maintenance hemodialysis, is in class 2, walking to the OPD. AV fistula is functional again. If he has recurrent symptoms, it can be considered as an investment procedure. You can always DES it again. This is another patient, a 37-year-old diabetic male with angina. And you have a bifurcation lesion of LCX and OM. Here I went with a provisional strategy with the idea of putting a DCB in the LCX and a stent into the OM. So a port was done, a sequential dilatation was done, the struts were opened, and a DCB was applied to the distal LCX, and this was the final result. I was quite happy with the result, and the patient was asymptomatic for 5 months, but subsequently he came with angina for about 1 month duration, and his angina worsened, and he came with an ACS, and this is the scenario now. So what do you do now? So you have a peristent ISR, you have thrombotic lesion and ISR in the OM branch, and you have a distal bifurcation disease. Putting another stent into the OM will be disaster. You can't reach the distal bifurcation. So what I can do is convert it into a culotte DES into LCX and put a DCB in OM because we know that DCB works in ISR. So that's what, with the plan, I put a stent from the mid LCX into the ostial LCX, and a port and a kissing balloon, and a final DCB into OM. You can see that it is projecting into the main vessel, and a final report. And the first mistake you cannot repeat when you come back. So I did not image the first time. This time I have to image it. So the imaging showed well opposed throughout the distal vessel. There was some slight malapposition proximally, which was corrected with a bigger balloon. I went up to 3.5 balloon, and I had a good MSA of 6.7. And this is the final result. So using a DCB in ISR and putting a culotte stent helped me get over this case. Thank you.
Can I have my slides? At the outset, I would like to thank Dr. Sarita Rao ma'am for the opportunity. In non-LM bifurcations, most trials have favored a provisional stenting strategy over complex 2-stent strategy except DK crush. Now in case of a true distal left main bifurcation, provisional versus 2-stent strategy, I think it's not a debate anymore. Each strategy has a very clearly defined role now, with the data available from DK Crush 5, 1 year and 3 year follow-up, EBC main, 1 year and 3 year follow-up, and definition 2 trial. So let's see what the evidence say and how the evidence has evolved over a period of time. So in 2012, this 5-year clinical follow-up of unprotected left main bifurcation lesion stenting, 1 stent versus 2 stent techniques versus DK crush, was published in Euro Intervention. This was a prospective observational study conducted in her 633 consecutive patients with true distal left main bifurcation and see what it showed. Decay crush was associated with a significantly decreased 5-year MACE compared to other 2 stent approaches as well as compared to 1 stent approach. So the conclusion was, with the distal left main true bifurcation, 2 stent technique excluding decay crush is an independent predictor of long-term MACE. Decay crush is associated with more favorable long-term clinical outcomes, and confirmation of these findings is required from randomized control trial. So in 2017, decay crush 5 trial was published, which was a randomized control trial comparing provisional stenting versus decay crush planned upfront 2 stenting strategy in 482 left main bifurcation, true left main bifurcation patients, and it showed superiority of the decay crush over provisional stenting approach. The target lesion failure, which was the primary endpoint of the trial, was clearly low in decay crush. Similarly, target vessel MI, definite and probable stent thrombosis were lower in decay crush group as compared to provisional. Even the target lesion revascularization was lower, but it was not statistically significant. When a subgroup analysis was performed, as per complex lesion versus simple lesions as defined by the definition criteria, the absolute benefit of decay crush over provisional stenting was more in the complex subset with a statistically significant p-value, and decay crush performed better than provisional even in the simple lesion subset. However, the p-value was not statistically significant. This made decay crush the preferred strategy for treating the unprotected left main bifurcation lesions, giving a class 2B recommendation for the decay crush over provisional T-stenting strategy in 2018 ESC myocardial revascularization guidelines. Then in 2019, a 3-year outcome of decay crush 5 trial was published, and it again showed the same thing. All the advantages of decay crush over provisional stenting were sustained over a period of 3 years with significant reduction in the target lesion failure, target vessel MI, definite and probable stent thrombosis, and target lesion revascularization over a period of 3 years became statistically significant. Again, a subgroup analysis was performed in this 3-year data of decay crush. It showed that provisional stenting was comparable to decay crush for simple lesions, and however, decay crush was associated with less target lesion failure for complex lesion. So even at 1 year and 3 year, decay crush also said that decay crush is particularly beneficial for complex distal left main bifurcation. So it established the place of decay crush for complex lesion as defined by the definition criteria. Then in 2020, definition 2 trial was published. It also consolidated the fact that upfront planned 2 stent strategy is better for complex lesion as compared to provisional, and provisional does not fare well if the lesion is really complex. Then in 2021, EBC main trial was published. It compared 467 patients with true distal left main bifurcation, provisional stenting versus 2 stent strategy. However, the point to note that the 2 stent strategy used in EBC main was not decay crush, but it was mainly Q-lot and T stenting. It showed similar outcomes between the provisional and the planned 2 stents technique. It did not show superiority of the provisional over 2 stent. However, it showed that provisional did as good. However, then finally in March 2025, 3-year data, 3-year follow-up of EBC main was published. Now what did it say? The primary composite endpoint of all-cause mortality, all MI and clinically driven target lesion revascularization was not significantly different between the 2 groups, provisional versus 2 stent. However, subgroup analysis suggested that side branch vessel size and lesion length significantly influence the outcome, with possible advantage of a dual stent technique in a larger caliber side branch and more side branch with more extensive disease, that is side branch lesion length of more than 10 mm. And it concluded that provisional strategy should be the default strategy for majority of the left main bifurcation lesion with low complexity anatomy, not for complex. And dedicated dual stent techniques may have a role in patients with long segment of disease in a large caliber side branch. Similarly, these graphs show the same thing. If the side branch is more than 3.25 mm and the lesion length is more than 10, then provisional did not go, did as good as a upfront 2 stent strategy. And we must know that though decay crush 5 and EBC main studied the same disease process, that is true distal left main bifurcation and its treatment, actually both the trials enrolled very distinct, anatomically distinct population. EBC main had mainly enrolled a non-complex or a simple subset. You can see that the average side branch lesion length in the EBC men was 7 millimeter. In DK Crush 5, it was 16 millimeter. DK Crush 5 trial, 44% of the patients had syntax score of more than 32, whereas EBC men excluded patients with syntax score of more than 32. EBC men trial had only 1.5% of the patients who were defined as complex by the definition 2 criteria as compared to 32% of the patient in DK Crush 5 trial. And even the lesion length in the main vessel was less in EBC men. So overall, EBC men enrolled simple distal left main bifurcation, and that's why it could show that provisional stenting is as good as 2 stent, whereas DK Crush enrolled a highly complex subset of patients, and that's why provisional could not stand the 2 stent technique. So I think based on all this data, we can say that in any bifurcation lesion, particularly the distal left main bifurcation, you have to divide it into true versus non-true. In non-true bifurcation, obviously provisional stenting is the strategy of choice, and for the side branch, leave it alone strategy is the one which you should apply. In case of a true bifurcation, simple versus complex, for simple you can do provisional step side branch strategy. Whether to do final kissing balloon inflation in all the provisional, we don't have the answer for the same, because COBIS 3 registry from the Korea said that there was no difference between the final kissing balloon versus no final kissing balloon. Now this IKISS left main randomized control trial from India is going to give us the answer for the same question. And if it is complex 2 stent, then it is DK Crush. Which 2 stent strategy for the complex 2, or undoubtedly DK Crush has the best evidence in its favor as a strategy of choice. In DK Crush 3 trial, DK Crush was proved superior to culotte stenting for true distal left main bifurcation. And in DK Crush 5, in the provisional arm, literally 47% of the patients underwent a rescue stenting, and the technique used was a T and protrusion. And a subgroup analysis showed that these were the patients in the provisional arm who required rescue stenting with TAP. They performed the worst. So DK Crush is even superior to TAP and culotte. Only thing is that we must remember that in DK Crush 5, the DK Crush stenting was performed by a highly experienced operator who had to perform more than 300 PCI per year for 5 years. And they had to perform 3 to 5 DK Crush procedures, submit them to the steering committee. They will review it, whether they are doing it appropriately, and then they were enrolled into the trial. So only while doing DK Crush, you have to not only be well versed with the multiple steps, it's a complex procedure. You also need to know the nuances of performing the DK Crush, like you have to crush the stent with a larger balloon. You have to do the proximal side optimization. And one important point I would like to highlight, that while doing the final kissing balloon dilatation, you must do a sequential high pressure dilatation of the individual branches, followed by a low pressure simultaneous balloon inflation. And my slides are gone, but only one point. In DK Crush 5 trial, the mean average LVEF was 60%. And more than 85% of the patient had a EGFR of more than 60 ml. But in our clinical practice, sometimes we land up in a situation where we have to perform a complex 2 stent strategy for a true distal left main bifurcation in patients who have a highly compromised LVEF. We don't have mechanical circulatory support. They have renal compromise. So in such situations, sometimes a quicker mini crush may be as equivalent. I had a slide which showed, now we have a Evolute Crush registry which shows equivalence between DK Crush versus mini crush in particularly true distal left main bifurcation. Maybe in a hemodynamically unstable patient, a mini crush, a meticulously performed mini crush may be as good as. So only my take home slides, sorry. I'll just read my take home slide. Yeah, I think I've completed, yeah.
Stage Seema.
Thank you.
So, question first, Dr. I also wanted to add provisional stenting. We would look at image, doing more image guided, and like the Korean, maybe look at the side branch, look at the plaque burden, look at the ML and less than 70%, we are more sure of doing a left main. So because the imaging is only 40%. So what do you think?
I think so. I think particularly when you're going towards left main PCI in the 2025, I mean, remember those trials were 20s and 18s and 20s. Now you crossed 5 years since its publication. So at the present time, if you're doing a left main, unless the patient is very sick, we should ideally image all the left mains. And as you rightly said, particularly pre-PCI, at least you should image both vessels. Post-PCI, sometimes you may get stuck in the sides arms, but try to get the second side branch as well. But at least in the pre-PCI, to get all the information prior before you deploy the stents. But after that, if you can manage to get the second branch as well, it's good. But if the patient is hemodynamically unstable, you want to finish the procedure, got a poor LV function, you just want an acute MI, you just want to get out the patient, you just image from the left main to LAD or the main branch and just come out as well. As long as you don't have the side stress focusing on the ostium of that. I think imaging is becoming mandatory in left main PCI at the current era, particularly when you're deciding to do your provisional stenting. We know from data that the OCT and the intravascular ultrasound imaging showed that there's a lot of stent deformation, which is like October trial, optimum trial, showed enough of stent deformation which is not being picked up on the angiogram. And when you're investing a procedure for a long term, you need to make sure you do imaging, make sure that you correct all those deformations before you come out of cath.
I also want to add that we can look at the ostium of the circumflex and see that there are no struts.
To add, there was a recent data from Asan Medical from Korea. If the plaque burden, you were saying, plaque burden is less than 56% and the MLA is more than 3.7, 80% of chance you will not need a second stent. So it's always good to look into the side branch, assess the plaque burden and the MLAs. So you're in a better position to predict what is going to happen once I do a crossover stenting from, so what will happen to the side branch.
You have IVUS data, but what about OCT? If you're using OCT, how do you decide whether you need a second stent or not?
A single pre-procedural run definitely will give an idea about what the angulation is and what the plaque burden is, at least about the ostium of the circumflex. So definitely a pre-procedural run will help us in understanding the side branch status, and especially in the with the distribution of calcium in the distal left main at the carinal point. It gives valuable information in deciding about going well ahead with a two-stent strategy or a provisional left main to LAD. And majority of the patient, like if there is no significant disease, they'll end up smoothly with the left main to LAD crossover stenting.
What is your opinion about post-PCI crossover stenting from left main to LAD? When would you like to do an FFR into the side branch, or would you like to do it routinely into the side branch?
No, so if the post-PCA run is showing not much of metal carina across that bifurcation zone, or if there's no flow compromise, or if there is not much of disease in the L6 ostium, we don't do it routinely unless the patient has any symptoms on table. There is routine FFR assessment of the side branch unless the patient is symptomatic, or if you see some haziness, or if you get some clues from imaging, we don't do it routinely.
So when do you do it?
If there is some plaque shift, which we believe that it is going to compromise in the future of the patients, if we believe that they can develop events in the future, in that case, we'll go for a side branch assessment. Otherwise, we don't do it.
Yeah, Shanmugam, nice to see you on coronary stage. And regarding your point, visualizing wide outside stunt starts by OCT at LMCA ostium, I agree that you have showed it in your case.
But the other two people's
But
names?
with IVUS, you will see each and every time. With OCT, you might see, you may not see. So IVUS is the best tool. That's where I disagree with you. Probably, Pankaj can add.
So you may be able to see LMC ostia if it is disease with OCT, but for average operator, it's difficult to identify if it's disease. To do an OCT if there's a severe disease in the ostial segment of the left main. If there's a left main ostia is diseased severely, I think the best is to go 5. There's no doubt. There should not be a debate in that. If the ostium is healthy, then you have multiple options. You may go with either.
It's about stunt starts, whether your wire is outside or inside.
It's always easy with IVUS, no doubt.
Yeah, that
always
best is
easy.
IVUS.
No doubt. Because
Yeah.
we're not able to clear the dye completely if you're not hooking the catheter. If you're hooking, then you miss the ostium.
I totally agree with you. As far as the left main ostium is concerned, IVUS is still the investigation of choice, the modality of choice.
Sundam, you didn't answer. For ostial fix, how do you use OCT? Because I have told you
My
number of
concern
techniques
is-
with IVUS. What are your techniques on OCT if you are planning to do a perfect ostial stenting with?
So we have now angio-core registration in the OCT as well. With Ultrian 2.0, we have beautiful ACR, which can give us where exactly we can land, and even we can minimize the contrast. But ultimately, whatever we do at the end of the day, when you do a post-dilatation, you will have some LSD, and that will pull the stent back into the left main. That is one of the biggest concern in doing a left main LED osteal PCI. But still, we have some clues from OCT, though we cannot do it live. But still, we can get it from angiochorogistry.
I think the boom technique. Dr. Silvamani used to mention about the boom technique. Dr. Pankaj, in the interest of time, we will conclude the discussion now and take it further down. And we will go for a quick picture and conclude the session. I'd like to thank my co-chairpersons and all the speakers.
What an insightful session. We now move on to our next segment, the depth session, focusing on the evolving role and clinical applications of drug-eluting balloons on contemporary interventional practice. Guiding this session as chairpersons are Dr. Brijesh Srivastav, Dr. Vaibhav Shukla, Dr. Stephen Herb, Dr. Saiko Takahashi, With that, I would also like to invite as experts Dr. Ruchi Gupta, Dr. Shiba, Dr. Mahendra Chaurasia, Dr. Bhushan Shah on the dais, please. To moderate the session, I would like to invite Dr. Ritu Bhatia.
Hi, good morning all. Should we be starting the next session? Yep. So we have Dr. Sunita. She'll be talking about drug-coated balloons, the technology. Please come.
Good morning all, respected chairpersons, panelists, and my dear faculty members. And I'm very thankful to the Dr. Sarita Rao madam, Dr. Josna madam, Dr. Sujata madam, and all WinCaps team for having me here. So today's session is on DCB, and so I will be talking mostly here on the drug-coated balloon excipient technology. So it's mostly a technical part of DCB. You know, for any DCB delivery, there are 4 factors which are important. One is a balloon platform, second is a drug, third is your excipient, and fourth is a coating process. So with this, I will take you the drug-coated balloon deliver an anti-proliferative drug, either it is a paclitaxel or sirolimus, directly to the arterial wall during the balloon inflation and enabling stentless PCI. What are the problems in balloon drug delivery? The balloon inflation lasts for 30 seconds. Drug delivery, which is loss is there, is about 70 to 90%, and blood flow washes the drug away. So excipient technology was developed to solve this problem. What is an excipient? It is a carrier substance mixed with the drug on the balloon coating that facilitates the drug stability, its transfer and uptake into the vessel wall. So what is the key role of this excipient? It stabilizes the drug coating on the balloon surface, facilitates adhesion of the drug to the vessel wall, facilitate drug uptake into the vessel wall, and enable rapid drug release during the balloon inflation. So already the topic was discussed by the previous speaker, and we have got a drug that is the delivery time is 30 seconds. Then its inflation time also it is about few seconds only. So we have to ensure all these factors when the incipient is taken into account. So why incipient matters clinically? It determines the drug transfer efficiency, tissue drug concentration, duration of the antiproliferative effect, and inhibition of the neointimal proliferation. So there are different incipient systems. They will explain the differences between the DCB platforms. So what are the engineering differences between the paclitaxel eluting balloon and the sirolimus eluting balloon? So you know both the drugs, some chemically there are differences, they are there. The sirolimus is a cytostatic while the paclitaxel is a cytotoxic drug. Then the paclitaxel has a more rapid delivery into the tissue while sirolimus has a more static and sustained delivery is there. So paclitaxel, it is a what is excipients also they vary, like it is a urea, it is a citrate and shellac, while it has got a more rapid drug transfer is there. While with the sirolimus balloon, we have got some adhesive advanced carrier system is there with nanoparticles, lipids and polymer, and it has got a more controlled and sustained release is there. So commonly used paclitaxel eluting excipients. So various devices they have come into the market by various companies. So we have got agent which is there by Boston Scientific. The excipient is ATBC, and you know the different concentration of the drug varies. It is from 2 up to 3.5 about, and some contains 2 to 3 microgram per millimeter square. So we have got a Prevail, Pantera, Proteage and the Clear Pack. And the different companies, similarly we have got commonly used sirolimus eluting balloons and excipients. They are the Magic Touch which is commonly used by Concept Medical, and it has got a phospholipid based nanoparticle carrier. Then the newer which has come is a solution SLR which is come into the de novo trial by Cordis. It has got a biodegradable polymer, micro reservoir like PLGA, and the concentration of the drug is about 1 microgram per millimeter square. Another is a Mosaic SEB by Marine Life Sciences. It has got a solid lipid nanoparticle carrier about 3 microgram per meter square is the drug. So it varies with the device and your excipient technology. So what is the evidence gap in the excipient technology? Here several excipient technology exists across what I depicted. There is a direct head-to-head comparison between all excipient systems are limited. There are some few trials coming up. Current evidence is largely based on mechanistic and the preclinical studies. So this is one of the study which is in an animal model, the vascular effects of paclitaxel following the drug eluting balloon angioplasty. It is in a porcine model. So here the porcine coronary arteries were studied. Balloon angioplasty, it was without stent, and the paclitaxel dose was a constant 3 microgram per millimeter square. And these were the excipients studied. The ipромide, BTHC, ATAC and the lecithin. So of this, the ipромide and the is a hydrophilic one, while BTHC and the ATACs, they are the mostly lipophilic, and the lecithin has a phospholipid carrier. So of this, they have found the endpoint as a inflammation and the fibrin deposition and the paclitaxel tissue concentration. So they have found effective excipients are the ipромide and the BTSC, while intermediate effect with the ATEC and ineffective with lecithin was found out. So these are the different properties of the different excipients and different again agents. So ATBC again is a lipophilic, urea is a hydrophilic, and the shellac is a new material which is there from one of the female bug. It is we obtained is. So different shellac contains protease and the BTSC in the Panteralux, while Prevail which is commonly urea as excipient. So all these either hydrophilic or the hydrophobic lipophilic which are there, they causes the improper drug adhesion and the transfer despite the lower paclitaxel concentration. And other drugs also which stabilizes the crystals and allows the control transfer. So these are the other properties like phospholipid nanoparticle in a magic touch, which encapsulate the sirolimus in a nanoparticle to enhance the vessel wall penetration and the cellular uptake. Similarly, we have got in newer one, which is a biodegradable polymer, PLGA in a solution SLR. This polymer matrix creates micro reservoir, enabling sustained sirolimus release for more weeks. So depending on the design, we get either sirolimus or the paclitaxel containing all these excipients, and for a better delivery into the tissue, better adhesion to the vessel wall, and the better tissue concentration. So what is future? Future is, again, we have got a future newer technology which are there. Here we have got a targeted nanocarriers which has got enhanced tissue penetration, longer intravascular retention, that is very important. Then hydrogel-based coatings, they are the hydrophilic gel expansion, and the uniform drug retention has to be there. Another are the smart response carriers are there, which causes controlled drug release, and there are also some enzyme or the temperature activated. And still more are the bioadhesive polymer coating, which has got a strong vessel wall adhesion and improve drug transfer is there. And now we can have a combination of all these components, leading to better dual antiproliferative and the healing modulation can be there. So all these balloon, that is the coated drugs, this DCB should have a proper coating should be there. We should have a proper excipient technology, drug transfer, tissue penetration, and the proper clinical outcomes. So we may have a different clinical outcomes and the angiographic outcomes also. So future innovation will focus more on smarter excipient systems for enhanced drug delivery. So what is the take-home message? Next time you pick up a DCB, you have to check the excipient also. It determines how the drug actually reaches a vessel wall and what is the actual tissue concentration. So thank you for your patient hearing. So there are newer trials which are coming up. Just previous speaker discussed that we can compare this DCB drug coated balloon with a DES also, and they are found to be non-inferior. And what we indications already we know is a bifurcation lesion, mostly the ISR and the small vessel disease. So one trial, it is a agent ISR trial, which compared the newer novel technology with the standard DCB, and they have again found to be better results with the all these newer novel technology and the all these excipient system.
Thank you, Dr. Sunita. We'll allow one question and then go to the next talk. Anything from the expert panel? Anything? Any question from the audience? I invite Dr. Sunita Rao for the next.
Thank you.
Dr. Sarita Rao for the next lecture, please.
A very warm good morning to everybody. And today, I'm just going to be talking about the trial which really reaffirmed our faith in drug-coated balloons, and because of which many of us have again enhanced our usage. So I'm talking about the solution de novo data. The one-year results of the solution de novo trial comparing a strategy of PCI with a sirolimus-eluting balloon and provisional stenting versus a systematic DES implantation to treat the de novo coronary lesions. Now, the device which was used in this was the solution SLR drug-eluting balloon. And what is unique in this device is that it has the micro reservoirs, these 4-micron spheres of sirolimus mixed with the biodegradable polymer, and that is what causes the controlled release of the sirolimus. Of course, it has a proprietary phospholipid coating, and it enhances the drug transfer efficacy. So the beauty of this is that the solution SLR drug-eluting balloon delivers a sustained drug release that maintains therapeutic tissue concentration for as long as 90 days. This is the pharmacokinetics, and you can see that the drug concentration in the target vessel remains right up to 90 days, And that's why it performs so well. Now, the solution de novo, the study design, was that it was a prospective randomized open-label multi-center non-inferiority trial. The candidates were those for PCI who satisfied the trial inclusion and exclusion criteria. What was important in this trial that all the patients were randomized before the procedure. So if you thought it was suitable, you randomized the patient before you started the procedure, either into the DEB strategy or into the DES strategy. Lesion preparation was done as required, and the first co-primary endpoint was non-inferiority for target vessel failure at 1 year. There was a second co-primary endpoint, the non-inferiority for target vessel failure at 5 years, for which we are still waiting, and a conditional superiority analysis if non-inferiority was established. The inclusion criteria in this trial were that all target lesions who were suitable for the solution SLR DEB or the DES treatment, a reference vessel diameter between greater than 2 and less than 5. There was actually no limitation on the number of lesions or vessels, and all target lesions were treatable with the strategy allocated by randomization. What was also interesting to note that this trial, they excluded the STEMI, the unstable non-STEMI left main, CTOs, ISR, saphenous graft lesions or arterial graft lesion, or a previous PCI in that target vessel. The procedure guidelines in this trial, there was a mandatory 1:1 lesion prep. So the most important thing when you do a DEB is the lesion prep. So 1:1 pre-dilatation, using the solution SLR was mandatory if the DEB was required. A minimum DEB inflation time was kept at 30 seconds, and the use, it was a bailout DES if there was a residual stenosis recoil of greater than 30%, if you had a high-risk dissection that's type C or greater, or your FFR came to less than 0.8. It was also allowed that all patients in both the arms could have use of adjunctive devices depending on what the operator thought was required in that patient, a cutting, a scoring, a high-pressure balloon, atherectomy, IVL. Use of imaging was not mandated, but if the operator wanted it, yes. FFR, IFR if the operator decided he required. Antithrombotic regimen was based on the guidelines and what was the local practice of that area. Stage procedures allowed if performed less than 45 days after the index procedure. This was the study flow, the consort diagram. Patients were randomized before the procedure to an DEB or a DES strategy, and a 12-month follow-up was done. The number of patients in this trial was also huge. So it was 3,341 patients which were looked at. These are the baseline characteristics. All patients were matched in both the arms for baseline characteristics. It was similar. Angiographic characteristics in all of these patients, including the vessels which were treated, were also similar. These are the procedural characteristics. And as you can see, majority of the patients had the radial access. Specialty balloon was similar, was more in the solution arm, rotational, and again, imaging was more or less similar. The primary endpoints, target vessel failure at 1 year in the DES arm was 4.4% versus 5.3% in the solution SLR, and the non-inferiority margin was met. The cumulative incidence of target vessel failure, again 5.3 versus 4.4 in the DES arm. The components of the primary endpoints were similar, except that was clinically driven target vessel revascularization was slightly higher in the DEB arm. Secondary safety endpoints were all similar. This was the subgroup analysis, again similar, and the limitations. So this trial had broad inclusion criteria, but excluded certain subsets such as the STEMI, the CTO, the ISR left main grafts. So when you want to do it in this subset of patients which are excluded from this trial, we would require more data, more dedicated trials. Lesion prep reflected the current European practice. So there was a limited use of specialty balloons and calcium modification. The QC analysis is still ongoing, and this study was performed with the solution SLR DEB. So these results cannot be applied to any other DEB or DES. We don't know if this is a class effect, so it applies only to solution SLR. So to summarize, the solution de novo was a large investigator-driven pragmatic strategy study that randomized patients before lesion prep. There were no acute or late safety concerns. The strategy had low rates of cardiac death, lesion thrombosis, and target vessel MI, similar to the DES in the other arm. 80% of the participants treated with solution SLRDB did not require a stent. And these results, with broad inclusion criteria, apply to significant segment of PCI procedures, including high-risk patients and complex lesions. A 5-year follow-up is planned to assess long-term non-inferiority or a potential superiority of the solution SLRDB strategy with minimal stenting. So at 1 year, the solution de novo trial said that a strategy of PCI with a solution SLRDB and a provisional DES was non-inferior to the systematic use of DES for the primary endpoint of target vessel failure. Ladies and gentlemen, thank you so much.
Wonderful talk, Dr. Sarita, as usual. I think, as you pointed out, of course, this trial has reinstated our belief in DCBs. I think about solution as a balloon, I mean DCB, there are two important points I would like to highlight apart from what you have given the data. It is very trackable balloon. So if you have a very long lesion, 40 millimeters balloon easily goes up to the distal LAD or distal RCA. I've got a lot of experience with these. I've done few cases where the entire artery is calcified, and when you're going for a hybrid approach, proximally you stent and distally you take this 40 millimeter balloon, it easily tracks. That's number one. And of course, I think there was always has been debate about aneurysm formation in paclitaxel versus limus balloon. So because paclitaxel causes aneurysms and especially in inflamed arteries, versus limus balloons are much safer in these things. So what is your opinion?
So first point, I fully agree with you that solution is a very trackable balloon. And I have had great results in my patients whenever I've used this. So that I agree with. The second is, when we had concerns regarding the use of paclitaxel in the area of when we used the DES, and when we had paclitaxel coated stents, we did see a lot of late aneurysms, and that was the drawback. So, but with the DEBs, that is not so much there, I will say, because the concentration of the drug is much lesser. So with DEBs, we don't see so much of aneurysm formation with paclitaxel coated, but I would still say that we have years and multiple decades of experience with the sirolimus coated stents, and we've had great results, and we've never had all of these adverse events with that. So having said that, the only problem with the sirolimus was that it's not lipophilic, so the drug transfer time is there, the tissue retention time is there. All of this have been circumvented in the solution, and some others also. So the idea of the micro reservoir technology, which allows it to stay for 90 days and at a very small dose, eluting the effect like the DES, probably that is what has given this the benefit and the great results that we got in the de novo trial.
Yes, I've used
Thank you, Dr. Sarita. So you have mentioned that we have to use only 30 seconds. It's not 60. Makes any difference?
Okay. So let me clarify that. I said that you should keep it, the trial mandated that you should keep it inflated for a time of at least 30 seconds. But that does not mean you cannot keep it inflated for 1 minute or 2 minutes or 3 minutes. Mandatory was 30 seconds to allow the drug transfer. But typically in practice, what we do is we keep it inflated as long as the patient tolerates. At least 1 minute is what I do in my practice. Sometimes small vessel, distal disease, patient tolerates very well, we go up to 1.5 minutes also. But 1 minute is what is our routine practice. But this trial mandated that you should have at least 30 seconds of inflation. So that was mandatory in the trial. But routine clinical practice is we do 1 minute for it. Now, even having said that, very important point to remember is that 90% of the drug transfer, they've tested it in bench studies and they found that it occurs in the first 10 seconds. So when you're using DCB and you have an acute hemodynamic emergency, and you want to deflate, don't worry. In 10 seconds, 90% of your drug has already been transferred. But the best thing is that if you can keep it for 1 minute, you're good.
Sarita ma'am, I have one question for you. Did this trial include larger vessels more than 3 mm in proximal locations also?
Okay, so Seema, as usual, I like her very much. She reads. And because she reads, she knows that this was one of the criticism of the trial. The criticism of the trial was that the benefit that we got was possibly accrued to the fact that they took small vessels a lot. There was a very large segment of patients in this trial in which the DEB was used in the small vessels, where we know we have got a great benefit of DEB versus this. So that is the issue. Thank you.
Thank you.
So we invite the third speaker, Dr. Madhuri, for next talk. Just leave nothing behind. Is DEB ready for prime?
Morning, everyone. I would like to thank organizers for having me here, especially Dr. Sarita Rao. We know that DEB is a specific novel PCI strategy which is based on the principle of leave nothing behind, except the anti-proliferative drug which it leaves. So still we are confused. We want to add more to our knowledge whether is it ready for the prime time. So let us see by this talk whether we can reach to a conclusion or not. DEB provides several advantages over stents in the sense that it preserves vessel compliance. It allows for shorter depth duration. It is ideal for complex anatomies like in-stent restenosis, where it has been given class 1A recommendation by latest TSC 2025 guidelines. In small vessel disease, it has been given class 2A recommendation by latest TSC guidelines, and this is the most strongest endorsements of DEB in the recent guidelines which we got. And it is also recommended to be used in bifurcation disease for the side branches. It has also advantage of preserving the future treatment options when we are using DEB. The theory and trial data only tells part of the DCB story, and we know that what we have gained from our own experience, clinical experience, works better for us. So I would like to present few cases which we have done in our center with DCB, and that worked well for the patient. So what are the patient subsets? Let me come to the first case. This is a case of a diabetic with ISR, and the ISR happened in a small caliber vessel over a short distance like of 15 mm. So the LED has already been implanted a long length stent, and it got instant restenosis in the distal part of the stent. So we tackled it with the DEB balloon dilatation and got good results. The next case was a recurrent ISR case where I did first primary angioplasty in an ostial proximal disease, and then that patient after 2 years came back at the restenosis in the same segment, and again we implanted another stent. The third time the patient came, we were discouraged, and we thought that we cannot implant a third stent in the same place. So let us try DEB. So DEB was done, and the third time on the same place, and the patient is doing very well, and she is still on our OPD follow-up and is asymptomatic. The third case, is of again of ISR, where osteoproximal LED was being dealt with DEB, and also along with this we got very good results in this case as well. This was the class 1 recommendation of DEB. Now coming to the class 2A recommendation, that is the small vessel disease, where we had a case where long LED lesion and a diagonal lesion. The diagonal was a small caliber vessel, and we thought of using a DEB in it, and the main vessel LED was being stented, and we used DEB in diagonal, so that we got a good result, and the patient came with non-ST elevation MI, is asymptomatic since then. The fifth condition, where there is nothing to show, but we just discussed the case scenario that we had a patient who is 82-year-old male in AF, was on anticoagulation, had a recent history of GI bleed and RCA mid-stenosis. So in this patient, we were worried about the increased bleeding risk, and so we thought of implanting a drug-eluting balloon in mid-RCA. And we were able to discontinue DAPT therapy after 2 weeks, and the patient continued on oral anticoagulation after that. After 12 months, the patient is still stable, and there is no MACE or bleeding events. So we were successfully being able to treat this case with DEB alone. The other set of patients, like our bifurcation case, where a LED D1 bifurcation, the large diagonal was there, we used DES in LED, and in diagonal we use a DEC. So we were being able to achieve TIMI-3 flow in all the 2 vessels, and the great results. This is a case of a complex anatomy where we were, the patient was of anomalous left circumflex from right coronary cusp, then LED D1 lesion, and there was a small size bifurcating ramus, which we did not want to leave alone. We wanted to do something about it, but the lesion complexity said that we need to fix it with DB, and that worked well with us, and we were being able to achieve a good result in this case as well. Coming to the distal small vessel use of DEB, here the whole of the RCA was being diseased, and we were planning to fix the proximal vessels, and we ended up fixing up with 2 DEB and 2 DES, and the proximal vessel was being taken care of. The PDA was left, and we wanted to make the outflow more clear for the 2 long stents which were being implanted. So we decided to fix the PDA with DEB, and that worked well, and we got a good result. And the inflow was being fixed with DES, and the outflow was being fixed with DEB. So to sum up all this, how to choose DCB in which patients? The ideal candidates would be those who had instant restenosis, those with small vessel disease, high bleeding risk, diabetics, or a bifurcation lesion with a large side branch. The suitable candidates would be those who have stable de novo lesions and with a good pre-dilatation result, where we can try this DEB technology, and we should take those patients with caution who has ACS presentation, who are heavily calcified, CTO lesions, and the severe dissection after pre-dilatation. There we should use DEB with caution, and there is no current recommendation to use DEB in such a patients. Thank you for patient listening.
Thank you, Dr. Madhuri. We have any comments?
Yeah, ma'am, just trying to ask. In ISR, it is important to understand the mechanism of why ISR is happening before using DEB.
Yeah.
So,
Neointimal hyperplasia is the most common cause of ISR.
Yes.
So this was the recurrent ISR case I did was, it's an old case, so we did not use IVUS in that patient, but otherwise neointimal hyperplasia in our clinical practice is the most common cause of restenosis, and where DEB works well.
And did you prepare the bed with cutting balloon there, doc? Because there were
pre-dilatation was very aggressive.
With the NC balloon or cutting balloon?
NC balloon and cutting balloon.
Followed by cutting.
Yeah. First time it was the resolute onis, everolimus, and the second time it was sirolimus, that is or0 stent was being put.
Thank you, Dr. Madhuri. We will invite the next speaker, Dr. Shiba. DEB for Australigen, a smart move.
A very hearty good morning to one and all, and thanks for this great opportunity. I'll be talking on DEB for osteal lesions. We know osteal lesions are defined as lesions within 3 millimeters of the origin of an artery. And 20% of all angiographically significant lesions are bifurcation lesions. And isolated osteal lesions are rare. 001 Medina is seen only in 3% of all PCI. However, the osteal lesions and bifurcation lesions are always challenging. Now, based on the location of the lesions, we are classify osteal lesions into aorto-osteal, non-aorto-osteal, and side branch osteal lesions. Due to the pathophysiology of the osteal lesions, these osteal locations are prone for immediate and late recoil following PCI. And because of the shear forces, these lesions are prone for high fibrosis and calcification, especially more in elderly subjects. So higher restenosis and target lesion failure and TLR. So managing LAD and LCS osteal lesions are always challenging because of the unpredictable extent of the plaque into the left main, and focal stenting may cause geographical miss. Crossover stenting may result in side branch compromise. So an ideal strategy for osteal LAD LCX lesion is always controversial. So what's the DEB concept and rationale? DEB is a non-stent technology that delivers anti-proliferative drugs directly to the vessel wall during balloon inflation. It enables uniform drug transfer without leaving a permanent metallic scaffold in the artery. DCB restores luminal patency in atherosclerotic lesions without leaving behind stent materials. Now, the strategy follows what is called leave nothing behind approach so that the native vessel anatomy and physiology is preserved. DCB alone or DCB and DAS hybrid strategy has been found to be useful in many situations. Let me come to that. So what's the rationale for the development of DEB? DEBs were developed to address the limitations of DES. We know that DES tackles immediate restenosis, but late stent thrombosis and chronic inflammatory response remain great concerns. So DEB therapy provides local delivery of anti-proliferative drug without an implant placement, which allows vessel healing and maintains the bifurcation anatomy. So in selected patients, they are useful. So DEBs are use lipophilic drugs which are anti-proliferative, which enable rapid uptake into the vessel wall. And lipophilicity allows the drug to remain in contact with the vascular tissue for variable periods. As Dr. Sarita mentioned, in the solution trial showed that the sirolimus drug remains for up to 90 days, almost similar to a DES. So continuous technological improvements are being focused on balloon materials, drug types, and advanced coating technologies. Micro-patterned or micro-reservoir techniques are coming up, ensuring better drug transfer. So the drug penetrates rapidly into the intima and medial layer, and smooth muscle proliferation is inhibited. So we are having anti-proliferative effect without a permanent metallic scaffold. Many drugs have been tried, and paclitaxel has been in use for a long time. Now we have the sirolimus agents coming up. Now, in which situation we use DCB? So DCB can be used in scenarios such as bifurcation for treating the side branch, then long lesions, small vessels, and patients at high bleeding risk, which support a leave nothing behind concept. So how do we optimize the drug procedure? The success of the DCB procedure depends upon optimal lesion preparation. Optimal lesion preparation is mandatory, but particularly in fibrotic and osteal lesions. How do we achieve that? And imaging prior to the procedure is very important, which will help us assess the plaque characteristic and distribution and extent of calcification. Then, how do we prepare the lesion? We have balloon technologies or the atherectomy modes. We have the scoring balloons, the cutting balloons or NC balloons, and even high pressure balloons, and also intravascular lithotripsy. If all this fails in highly resilient, highly calcified lesions, we can adopt to atherectomy, either rotational or we can go for the other atherectomy techniques. So a proper lesion preparation is to be achieved prior to implantation. What are the 3 important angiographic parameters you look for before using DCB? Number 1, the residual stenosis should be less than 30%. There should not be any flow limiting dissections, and there should be TIMI-3 flow. And an FFR should be done, if possible, prior to using DCB. If the FFR shows that there is more than 0.8, then it shows that there is adequate lesion preparation. Then you can go ahead with a DCB. But if it fails to achieve these angiographic results and FFR is low, definitely DES bailout should be considered. Do we have clinical evidence? A lot of trials are there. I'm not going into details. The PACO-CAT trials, the PEPCAR trials, the DBUT, the BELLO, all these trials are there. And Dr. Sarita mentioned about the solution trial also using the sirolimus drugs. Now, so I'm not going to the details. This is a virtual case. This is a 39-year-old female who presented with ACS, the risk factors being hypertension and smoking. She was found to have isolated ostial LAD lesion. So being an young patient planning for family life, etc., she was considered to be a candidate for a bare metal stent implantation. But 5 months later, she landed with recurrent ischemic symptoms, and angiography showed that there is diffuse ISR of the bare metal stent. So she was planned for a DES after a DEB, after appropriate lesion preparation, and DEB achieved very good result. A follow-up at 7 months showed that there is positive remodeling at the ostia of LAD. So to summarize, ostial coronary lesions are technically challenging due to complex flow characteristics, elastic recoil, and difficulty in precise stent positioning. DES at the ostium may lead to limitations such as stent protrusion into the parent vessel, multiple metal layers, and restenosis. DEB offers a leave nothing behind strategy, delivering anti-proliferative drug without permanent metallic implantation. Adequate lesion preparation with IVUS or OCT guidance are crucial to achieve optimal results with DEB-based therapy. Current evidence suggests that DEB may be a viable option in selected ostial lesions and in bifurcations tackling the side branch ostial lesion in carefully prepared lesions and carefully selected patients. So my question is answered. Is DEB an option in ostial lesions? Is it a smart move? Of course it is a smart move in selected patients, in selected lesions properly prepared. Thank you for the patient hearing.
Thank you, Dr. Shiba. Very nice presentation. Any comments or questions? Any comments from the panel? Any questions? We'll conclude the session.
Thank you so much to all the speakers and the chairpersons. Please join for a quick picture.
Thank you so much, dignitaries. I would request you to kindly collect your mementos. We now move on to the next agenda, challenging case presentations, a session that brings together complex real-world scenarios and the clinical insights required to navigate them. Guiding this session as chairpersons, I would like to invite Dr. Rini Pramasti, Dr. Antonia Anna Loketo, and Dr. Pankaj Manoria. Supporting the discussion, we have an esteemed expert panel comprising Dr. Puneet Goyal, Dr. Sojani, Dr. Saurabh Kapadia, and Dr. Swapnil Garde. Moderating the session, I would request Dr. Majella to kindly grace the dais. I now invite upon the dais Dr. Yukiko Morito. She will be having a talk on dynamic challenges in arthroscopy coronary artery aneurysm causing acute myocardial infarction.
Thank you. Thank you for kind introduction. I'm Dr. Morito from相模原 National Hospital, Yokohama, Kanagawa, Japan. Here I'd like to present an interesting case of coronary aneurysm which developed to acute myocardial infarction. I think this case is unique and interesting in the 3 points of view. First, this coronary aneurysm was considered to be atherosclerotic in origin. And second, the patient had suspected familial hypercholesterolemia. And third, it is most important, we were able to evaluate the pathophysiology of this coronary aneurysm using coronary angioscopy over 5 years. The case is a 55-year-old male with a history of hypertension and dyslipidemia who complained chest discomfort and was hospitalized to a hospital for acute myocardial infarction. Sorry. So we decided to perform emergency coronary angiography. You can see angiography which revealed an occlusion in the mid-RCA. And we proceeded to PCI. The system was as shown on this slide, and it was easy to pass the wire through the mid-RCA region, but the advancement to the distal RCA was difficult. With repeated thumb substitution, distal visualization gradually improved, allowing advancement of the wire. However, around this area, segment 3, the wire took on markedly moving course like this. Finally, we eventually succeeded in crossing to the distal RCA. But the vessel diameter appeared around here, appeared clearly enlarged, which was considered consistent with coronary artery aneurysm in this. After implanting a drug-eluting stent in mid-RCA region, with the support of a guide extension catheter, we were able to advance to the IVUS catheter to the distal side of aneurysm. This is IVUS image. It demonstrated an aneurysmal segment with a large luminal area, partial superficial calcification, and revealed massive thrombus formation within all of the aneurysm. And minimal lumen diameter is about 2.0 millimeter around here. Finally, we were able to inject NSC balloons through the region and dilate it, after which paclitaxel was delivered, so completing the procedure. Here is the final angiography, which demonstrated TIMI3 flow. To further clarify the lesion characteristics, we performed follow-up angiography, IVUS or OCT, and added coronary angioscopy at a later date. Accordingly, we performed repeat angiography on the day 11 after the onset of MI, while the aneurysm had appeared as a vague, enlarged structure at the admission. It now shows a normal-like configuration with 2 lumens, likely due to dissolution of thrombus. Here is the IVUS still image. In slice A, the large thrombus which had been presented at admission is no longer visible on the day 11 after the onset of AMI. Continued anticoagulation had resulted in complete thrombus resolution. Here is the coronary angioscopic view. After clearing the blood, we can appreciate the reddish eroded appearance of the vascular lumen along with mesh-like structures suggestive of fibrin. And we can see also yellow plaque. We observe pronounced atherosclerotic changes throughout the RCA, especially in the area surrounding the aneurysm. Based on this clinical course I have shown so far, we will need intensive lipid-lowering therapy and anticoagulation. In addition, we will perform ongoing monitoring of the lesion using serial imaging, including coronary angioscopy. Furthermore, when we investigated the patient's hypercholesterolemia in more detail, we found that one of his two sons had a total cholesterol level of over 300 milligram per deciliter in his 20s, raising suspicious of heterogeneous familial hypercholesterolemia. After discharge, with the addition of PCSK9 inhibitor, his LDL cholesterol level remained consistently low, approximately 25 to 30 milligram deciliter over 5 years. We perform follow-up every 1 or 2 years, including coronary angioscopy, during which no SCS or mortality occurred, and CAG and IVAS findings remained largely unchanged. This is the angioscopic view around the coronary aneurysm obtained at the 5 years follow-up. You can see that this portion of the vessel is now largely covered with a smooth neointimal surface. However, more proximately, the findings are similar to what we observed previously, with persistently yellow plaque and mesh-like fibrin structures. Over 5 years, anticoagulation successfully resolved mural thrombus without recurrence. Non-aneurysmal segments showed almost clear stabilization and intensive LDL lowering therapy. However, the aneurysmal segment remained biological active with persistent yellow plaque and incomplete healing. In this clinical course, preventing recurrence event is important to improving the patient's long-term prognosis, and achieving stabilization of the aneurysmal segment is essential for that goal. Beyond medical therapy, several invasive approaches, ligation, CABG, stent grafting, or coiling are theoretically available, but determining which option would best serve the patient remains a difficult clinical judgment. This is a take-home message. Over 5 years, we were able to continuously observe this coronary aneurysm using multimodality imaging, including coronary angioscopy. To further improve this patient's long-term outcome, these invasive options such as CABG, surgical ligation, surgical grafting must need to be considered beyond medical therapy. Thank you for your attention.
Thank you so much, Dr. Norito. That was a great case. Any questions from the expert panel?
Yeah, I think we would have, if covered stent is available, that will be the first option probably. And angioscopy is new to us. Do you use it routinely, or is it on an experimental basis?
Pardon?
Angioscopy.
Sorry, I can't follow you a little bit slowly.
Are you using the angioscopy, using the imaging inside the vessels with the angioscope? Do you do it routinely on a clinical basis, or is it used in special situations alone?
Are you doing angioscopy for every case?
Just in a hospital,
she's not.
Sorry.
She just wants to know whether you are using angioscopy for a research purpose only, or is it routinely available for your patients?
We use not so many times using angioscopy. We use in Japan imaging IVUS image or OCT image. We use many times the OCT or IVUS images. Not so many angioscopy.
Okay, thank you. I just wanted to know just one thing. You've used DCB for that distal aneurysmal segment. So does really DCB helps in such lesions? I'm really not sure. Because for drug delivery, you need adequate contact, and basically the mechanism of action of DCB is we want to prepare the bed well, we want to cut the intima with the cutting balloon so that your drug reaches the media. This is the basic mechanism we want to use a DCB. But in aneurysmal segment, I'm really not sure this is really going to help us or not.
And paclitaxel is known to cause aneurysm. So this has happened within 10 to 11 days after the PCI. So do you think it is caused by the drug?
Therapy in the future? Yeah. Okay, I see. Acute phase, we, as you point out, we had the same concern during the acute phase. But acute phase, I think we think it is important to get the TIMI-3 flow, and to the TIMI-3 flow, we did cutting. We used the cutting balloon after cutting balloon and the DCB. So after 1 or 2 years ago, after the onset of MI, in the as I presented in this presentation, not so changed, and stenosis is not so changed, but aneurysm segment is in the angioscopy view. Not getting that, not stabilization, and I think in the future, this we needed more in intervention therapy beyond the medical therapy, CABG or irrigation and stent grafting. I think stent grafting is the least invasive and most straightforward for the patient, and we are thinking in the future.
Okay.
Thank you, ma'am.
And made RCA a borderline. To put 2 stents to do a DCB distal may not be the best strategy. Okay, and when you do it in deep ulcerated plaque, even if you put a bare metal stent, we know it, sometimes that flap just shuts the aneurysm. So the strategy of, just seeing with a plain balloon and then deciding to use a stent distally may have also been appropriate. I'm just putting it for the sake of discussion because these are rare cases, and when you get them, you have to have many perspectives of how to handle them. Follow-up with the angioscopy gives images which are kind of, seductive, or they look good, or actually, but they don't contribute to science. We've done this 25, 30 years ago and we've stopped. Because the vein graft, degenerated vein grafts gave better images with horrible cheesy material in the graft, but it didn't help in making clinical decisions. What I want to ask is, what was the CRP of this patient, and did you use colchicine? And second, when you started, the rosuvastatin dose was only 5. Even optimizing statin before adding, a PCS Of course, the data is going towards hit it hard early and give a PCS or an inclisiran, but we are not yet there, particularly when you are underdosed on rosuvastatin and you haven't added ezetimibe or, and you're only on 5 rosuvas and benzofibrate.
Thank you.
Thank you, ma'am. Thank you. We will now move on to the next topic by Dr. Annapurna Kalia, validating lesion preparation with imaging in multivessel DEB.
Good afternoon, respected chairpersons and my dear friends. So today I'm going to talk about validating lesion preparation in imaging guided DCB especially. Just to start with the case, my patient was a 68 years old male, known case of DM hypertension. He had undergone PCI in the past. He had a stent in the LAD. He was presented to our hospital with unstable angina. His troponins were positive. ECG showed lateral wall STT changes. 2D echo showed anterolateral wall hypokinesia with ejection fraction of 45%. When we did his CAG, the LED showed mild ISR. There were 2 large OM branches which showed critical disease, and RCA was essentially normal. So this was the angiogram. In the first picture you can see it was a OM3 rather, but it was a sizable OM3, big dominant vessel, and it was almost 2.5 size, and large OM1. You can see early OM which shows very long disease, osteoproximal disease, which is critical. Now when we are talking about these lesions in a dominant circumflex, we know that whenever we have to, there is no space to put the stent in the OM1, because you can see the plaque is extending up to the ostium. So it becomes essentially Medina 001, and we know it's one of the most difficult lesions to tackle are the Medina 001. So these were the challenges in my patient: diabetic multivessel branch disease, large dominant circumflex. OM1 was showing us a very large territory, osteal disease, landing zone showed the size of about 2.75, Medina 001. OM3 it was actually mid segment 2.5 vessel. So what should we be doing for OM1 especially, whether we should be doing bifurcation stenting or DCB? Now in this current era I'm sure everybody would say DCB. When we are planning for DCB, the rate limiting step in the DCB, any DCB PCI, is lesion preparation. You have to be extremely patient and you have to be using the correct devices to prepare the lesion, because one wrong step and you are going to have a ghastly dissection and you have to end up with bailout stenting. So like everybody knows, the 80% of the time you need to spend on lesion preparation, followed by only 20% time, for 1 minute just to paint the lesion. Now what are the devices which are available currently for DCB lesion preparation? Most importantly, cutting balloon. We have Wolverine with the metallic stainless steel arthratomes. Importance about Wolverine balloon, it is a semi-compliant balloon, remember. So if you take 2.5 Wolverine balloon, it will grow up to 2.75 when you go up to 10, 12. So you are going to cause dissection. So if you have a smaller vessel, go undersize Wolverine, go high pressure. If you take 1:1, then you go up to only 6 atmospheres, 6 to 8 atmospheres, that's it. If you go high pressure, take a smaller size balloon, that is number 1. Secondly, Wolverine causes controlled dissections. So it is excellent balloon for DCB practice. And also if you have calcium, especially circumferential thin plate of calcium, it would create good cracks in the calcium. So good for calcific vessels, good for to create controlled dissections. But you should know how to use this balloon, that is one. Second balloon is scoring balloon. We have Scoreflex or Angiosculpt. These are again these are semi-compliant balloons. They grow, they will cause dissection. So you have to be very careful in using Scoreflex and scoring balloons, because scoring balloon, Scoreflex, we know there is it's like buddy wire technique what we used to do, similar kind of thing, but it doesn't help you much in calcific lesions. Now coming to Apeta balloon. Apeta is a very good balloon. It has got nylon triangular, three atheratomes. So these atheratomes they are very tall atheratomes, they are triangular, not like stainless steel blades. So the cutting with Apeta balloon is excellent. And one flip side of Wolverine balloon is in very tortuous vessels, or if you have a very thick calcium, tracking Wolverine balloon becomes a problem, especially 15 millimeters or larger balloon becomes a problem. Apeta easily trackable balloon, and in Indian scenario, when we have to use ox balloons, like repetitively when we use ETO balloons, Apeta is better than Wolverine, because ox Wolverine, you do whatever, it is very difficult to take it down the blade. So to cause controlled dissections and get good luminal gain, because after preparation of these balloons, sometimes if you don't have very good this thing, you may have to use NC balloons. That is how you need to prepare our lesion. So first we started with OM2. You can see reference vessel diameter was around 2.38, 2.4. There was an eccentric fibrofatty plaque. The MLAs were 1.94. So pre-dilated using 2.5 by 10 cutting balloon. Directly I took because it was easy, because it's not a very critical lesion. So this was the result after I did IVUS, just to document how much is the luminal gain. You can see very good luminal gain. Whatever was 1.9, post Wolverine I got MLAs of 4.65. So it is a very good lesion prepared. Now I don't have to take any NC balloons, and they were angiographically there was nothing. So I went ahead and did DCB to this vessel 2.5 by 15. So this is on the right panel, you can see the result post DCB. Then started tackling OM1 because it was much difficult. This thing catheter did not go, so I had to take first 2 by 15 semi-compliant balloon just to make space for the IVUS catheter. Further lesion preparation was done with 2.5 and first 2.5 by 15 10 cutting balloon. The lesion preparation was not adequate because there was some calcium, so I used 2.75 by 15 cutting balloon. So I had to use 2 cutting balloons. So sometimes you may have to take 2 balloons, and this was the IVUS picture. Here I have given into both the things. Pre-cutting balloon, you can see the reference vessel diameter was around 3. The first panel shows fibrofatty plaque mid OM. The MLAs were 1.65, and after cutting balloon 2.69, and the third image shows the tightest portion fibrofatty plaque 1.92 became 2.6. So you can see the good luminal gain, good cuts, and no dissections. So then this lesion was treated with paclitaxel DCB 3 by 30 millimeters. And this was the final result. You can see OM1, such a big large territory, and my LCX is also flowing well, and the OM3 also is flowing very well. So my take home message is imaging plays immense role in this case for tackling multiple large side branches OMs with DCB in a large dominant circumflex. Wolverine cutting balloon, by virtue of exerting highest pressure at the atheratomes, cause controlled dissections versus NC or semi-compliant balloons. The short-term and long-term DCB results, we know that it all depends upon the dissection and the careful lesion preparations. For the deeper drug penetration, we have already heard our previous speakers talking about it. And avoid producing flow-limiting dissections which may preclude DCB. IVUS helped us to assess the plaque morphology pre-post cutting balloon MLAs gains, so we could do straight away DCB after that without using NC balloons. Multiple stents in a diabetic may cause, there is a high risk of ISR, hence, and especially in small vessels, so DCB comes to our rescue. The OM lesion may have required bifurcation stenting as there was no landing zone proximally to nail the OM ostium. Across a large circumflex with size discrepancy, circumflex was 3.5 and this OM was around 3. So however, DCB made it simpler. My patient is doing well on clinical follow-up. Thank you.
Dr. Annapurna, just one question. IVAS is very good in deciding on the sizing of the balloon, preparation and everything. But do you repeat the IVAS post DCB or you differ from it?
Actually, if you are talking about IVAS, we can do IVAS post DCB because it is not OCT, we avoid doing it because OCT causes dissections are already there, and when you are injecting with force, you may increase the dissections. But here you can always use IVAS. There is no harm in using IVAS because it is, but then it will be like more of academic interest. If you have done it just before, after lesion preparation, you must do. That is very important to document the dissections, the big, small dissections and luminal gain. If you document good luminal gain, do DCB and come out, I think. The rest of it is academic interest.
Dr. Annapurna, I have one question for you. What ratio of the balloon to artery do you prefer or do you consider optimal for lesion preparation for DCB?
Yeah, very good question. See, when we are using, for example, if I'm using apeta balloon, that is a cutting balloon, if I have a small vessel, undersize is by quarter size, 0.25 smaller if you have a small vessel. If you are using it for example, in cases of ISR, go as per the stenting size. You can go up on any one. And if you are using it for bifurcation, go as per the distal reference diameter. That is what is one thing. And it depends upon what balloon you are using, preparation. If it is Wolverine is a semi-compliant balloon. It will grow. 2.5 for 12 atmosphere will become 2.75. So you are going to cause more dissection if you are especially using small vessels. Secondly, if you are using apeta balloon, apeta is a non-compliant balloon. So at 18 atmospheres also 2.5 will become 2.64, not more than that. At 24 atmospheres it becomes 2.7. So you should know the capacity of every balloon that you are using for lesion preparation, how much you need to go up on size. So ideally, in my practice, I go, and in calcific vessels, you go by MLDs, MLD plus 0.25 for the lesion preparation, MLD plus 0.25. That is what should be used. But in case you are in any time when you are doubt, if you want to sure shot do DCB, go quarter size small on Wolverine balloon and go high pressures. I go on Wolverine up to 14, 16 atmospheres, but provided I am going on a lower pressures. If you do not want to go very high pressures, then you can take 1:1 as per the vessel size and just go up to 6 atmospheres.
Excellent, ma'am. Thank you for these important learning points regarding how to use balloon. I have one more question regarding lesion preparation only about your practice. So I would like to know, do you do single predilation with these cutting balloons or you do give multiple cuts? Because recent evidence shows that we can give multiple cuts for better lesion preparation. We can just, at the proximal, we can rotate the catheter so that we can change the site of those cuts for a better lesion preparation while using cutting balloons.
Yes, very good question. So they have shown, because you know it's like a Mercedes-Benz, you have 3 arteriotomes, and in cutting balloons, the maximum pressure is exerted at the arteriotomes, not elsewhere. So sometimes if you have a circumferential fibrotic plaque, you may not be able to prepare it very well, and especially in long lesions. If you have long lesions and you have some calcific segments, then don't shy away from going again and again, as long as the patient is tolerating. Patient's hemodynamics allow you, then inch by inch you can do it, and multiple times you can just twist it if you want. But otherwise also, if you do imaging, see when we are doing imaging, we get a lot of confidence as to how deep these cuts are, and you know whether we will be able to do DCB or you have to do stenting, etc. Yes, we can go multiple times, and that is my practice. I go because again it's like 90% of DCBs is lesion preparation. So do that well, and rest will be taken care of by the DCB.
Thank you. Thank you.
Thank you so much, ma'am. Thank you. Now we move on to Dr. Rai. 2 cases of refractory coronary spastic angina accompanied by the menstrual cycle.
Hello, thank you very much for giving me this opportunity. I come from Japan. It's a pleasure to meet you. Coronary spastic angina, CSA, is caused by epicardial spasm and relatively common in Japanese women. However, female-specific factors such as menstruation, pregnancy, and childbirth have received limited attention. We report two menopausal women with refractory CSA recurring around menstruation. This is a first case, a woman in her 40s hospitalized for acute pyelonephritis, developed resting chest pain on day 2 with transient NSVT and complete AV block and inferior ST segment elevation. She was transferred to our hospital for suspected ACS. And she was a current smoker and she was on day of menstruation. Blood tests showed elevated cardiac troponin I, as well as increased inflammatory markers, including the white blood cell count and CRP. The platelet count was also low, suggesting a possible DIC tendency. Here are the findings from CAG and the acetylcholine provocation test. There was no stenosis in CAG, but a little bit spastic. The coronary spasm was provoked in the right coronary artery with 50 micrograms of acetylcholine and in the left coronary artery with 100 micrograms. In both arteries, the spasm was induced, so she was discharged on CCB therapy. I want to summarize the case one. After this case, Nicolangelo and CCB therapy, she had no further chest pain, and CAG and acetylcholine provocation tests were performed in accordance with her menstrual cycle. Latent CSA was considered to have been triggered by acute infection. The second case, a woman in her 40s presented with nitrate-resistant resting chest pain a few days before menstruation. ECG and cardiac enzymes were unremarkable, and coronary CT showed no significant stenosis, and the CSA was suspected, and CCB plus ISDN were studied. However, the chest pain recurred monthly just before the menstruation. And at the year on November, there was a ST negativity in V2 to 5. And the blood test revealed no significant abnormalities, and the estrogen level was within the normal range. And CAG performed under ongoing medical therapy and showed no significant stenosis, but just a little bit spastic. On provocation testing, coronary spasm was induced by 50 micrograms of acetylcholine, and it did not resolve after intracoronary administration of 5 milligram ISDN. And finally, the coronary spasm resolved after intracoronary administration of 50 milligram ISDN and 4 milligram Nicolangelo. This case clinical course. Despite anti-anginal therapy, chest symptoms persisted because they occurred consistently before menstruation. Hormonally-associated CSA was suspected, and low-dose oral contraceptives were studied. Symptoms improved, and the diltiazem, CCB, were reduced to 100 milligram, and she was remained stable without nitroglycerin. Her symptoms pattern suggested PMS-related CSA. Hormonal fluctuation was considered the trigger despite the normal estrogen level. Low-dose oral contraceptives control the attacks. PMS occurs 3 to 10 days before the menstruation and resolves at onset. Association with a rapid decline in estrogen and progesterone. Cycle-related CSA may reflect hormonal fluctuation. And low-dose oral contraceptives containing estrogen and progesterone suppresses hormonal fluctuations. Conclusions. We experienced 2 cases of menstrual cycle-related CSA. In premenopausal women with angina, menstrual history and PMS should be assessed. Catheterization timing should be considered as a hormonal phase may affect acetylcholine provocation results. Low-dose oral contraceptives may be effective in selected cases. Thank you for listening.
Thank you so much. That was really interesting.
Can I ask you one question? Have you done any functional assessment to know the microvascular dysfunction in both the cases?
Yeah, in both cases, from mediate dilatation in the upper artery was evaluated. Then both of the cases was decreased microvascular dysfunction.
You have done any test for it?
Yeah, done.
She's asking whether you did any coronary invasive
the risks of
IMR or coronary flow reserve.
No. Not CMD was evaluated, but the upper blood artery.
No, which hormone do you think produces vasospasm specifically? Any data onto that? Any earlier case reports like this?
Yeah. I think
Why do Japanese people have more coronary spasm? The literature says that.
Yeah, it's difficult, but in Japan, many young women have a coronary spastic angina. So we first see the young woman with chest pain. We always doubt CSA.
Related with the case of CSA, so many in Japanese. Are you routine to use the propagative test with acetylcholine? Yeah. And then the second, actually, we have in Indonesia, it's not available. Are you do the propagative also on the Minoka, something like this? For the patient, Minoka, you know? Something you use drug propagative on the patient with Minoka also?
Yes, sometimes we do the provocation test for Minoka patients because the medication depends on the with CSA or not. So we sometimes do the provocation test for Minoka.
Thank you so much for bringing out such interesting cases. Now we move on to Dr. Rashi. She is presenting a SNAD and STEMI, retrieval of dislodged RCA stent during primary PCA.
A very good afternoon to everybody. So I'll be talking about a very exciting case, SNAD and STEMI, retrieval of a dislodged RCA stent during primary PTCA. So this was a 81-year-old gentleman. He was a hypertensive and a diabetic with presented to me with an acute inferior MI with cardiogenic shock. Ongoing chest pain was present and the EF happened to be 25%. So this is the angiogram. We can see the LED has mid-LED disease around 80 to 90%. Ostial LCX is diseased and we have got 2 major OMs that are significantly diseased. In the cranial view, we can see there is significant calcification in the RCA. The calcium in the RCA can be seen. This was the RCA. Mid-RCA, 100% calcified and thrombotic. So, because the patient was having severe LV dysfunction with hypotension, along with, we could not give a lot of fluid in RCA, so IVP was placed. Now wired the RCA, wire went smoothly, then thrombosuction done and I could attain a flow. We can see mid RCA is having a significant disease. It is a long lesion, calcified with the maximum stenosis of around 90% in the mid RCA just next to the branch. So did the thrombosuction, RCA has a significant disease, mid RCA, then because it was a calcified fibrotic lesion, decided on aggressive pre-dilatation. Going to the age of the patient, it was anticipated that the fibrosis and calcification will cause problem. So the pre-dilatation was done with a 2 into 10 millimeter balloon initially, followed by a scoring balloon, 2.5 millimeter scoring balloon. The last shoot shows the bed preparation after semi-compliant balloon. Then I used a scoring balloon, 2.5 millimeter, and took a buddy wire for stent placement. Took a buddy wire and placed the stent. The stent went smoothly. Took out the second wire. Now, it was ideally I took the stent distally so that I wanted to cover a smaller stent proximally. It was a 3 into 38 millimeter stent. But while deploying the stent, the patient was very irritable, maybe because of hypertension, he moved a bit. And when the stent moved proximally, and when I took a shoot, actually I had landed in plaque. Maybe with some ejection or thrombus. The proximal landing zone was fine. Now what? So I decided I'll pre-dilate this, post-dilate this stent and then put a smaller stent distally because I need to cover that. Post-dilated it and then took a smaller stent. But the smaller stent was not going. So took a second wire also, but still it did not go. Took out the stent again, decided that I'll more aggressively post-dilate the stent, but while pulling out the stent derailed from the balloon and it got stuck in the proximal edge of the already deployed stent. So we can see a bunch of derailed stent in the proximal RCA. Now what? Now I tried for, thought I have to take it out because it was stuck in the, it was not just simply put in the proximal RCA, it was stuck in the already deployed stent. So took a second wire, tried to pull it out, no, then took a small balloon technique, took a smaller balloon, but the balloon did not go. Even a 0.75 millimeter balloon did not go. Now what? Then I snared it, a 5 millimeter snare. After multiple attempts, I could actually hold my stent and snare it out. You can see I'm trying to snare it out. And finally in this shoot, in the first shoot you can see with some attempts I can actually catch the stent and I pull it out. And it comes out in the guiding. Now. But the story does not end here. The stent that was stuck in the already deployed stent, when it came out, it brought the already deployed stent along with it. Now I had a bare RCA. So this was the, when I took the shoot, it brought the wire also. When I took the shoot, there was no apparent damage. So took 2 smaller stents, completed the procedure. This was the final result. And discharged this patient after 72 hours. This was the snared stent with the snare. And this was the stent. The already deployed stent was actually more elongated. Patient got discharged after 72 hours. Thank you.
Thank you, Dr. Rajni. It was a great case. Yes, ma'am, you have some
Yes. So you have you done IFAS after that?
Madam, it was a very, MI STEMI setting. The patient was in hypertension. Already some mishap had happened. I had attained good result, reasonably good result. So I did not do anything extra. And he was an 87-year-old male. So I did not do anything extra in that then. Yeah. What was the reason it got calcification? Ma'am, there was calcification. It is always a notion we should always deploy a distal stent first and then the proximal stent.
Yeah.
But in my case, it was because of the, the proximal longitudinal shortening maybe of the stent that I had to put the distal stent. So maybe the proximal edge of the stent was not
deployed.
Maybe, or maybe there was
Under
some
expand.
calcium spur, it was stuck in that, maybe.
I think it's a great save, good case. when the patient is having an age of 80 years and the artery is heavily calcific, I think one of the important basic is to have a good guide support.
Yeah.
You have used a JR guide in this patient. Did you ever consider using a guide extension catheter or maybe a better guide like a XBRCA to have a better support
But the guide
so that you
support
can
was
so that you can push your hardwares in with ease?
This scenario was not anticipated, and the guide support was good throughout the case. The stent also went nicely. Just the patient moved and the stent was pulled proximally, right?
Yes, but I think we should always take a better guide, a better supportive guide for such sick, for patients who are heavily calcific.
Hi, Dr. Rashi, very nice case. Just one observation that I would like to put. Whenever you have deployed the stent and the stents, I mean, you have to have a smaller stent which has to be deployed distally. It is always better to take a balloon and with that balloon supported, you pass a guide support catheter like Godzilla and then push the stent to the distal part. It is always, I mean...
Guide extension, you mean to say, sir?
Yeah.
Okay.
With this, I mean, this kind of a tortuous artery with some bend, some strut could be under deployed.
Yeah.
And those are the places where the stent gets
Yeah.
cut. So every time, whenever you are deploying a stent distally because of whatever a geographical miss or what, it is suggested that guide extension catheter should be traced down with a balloon support and then deploy the stent. But it was a very, very nice save. Congratulations.
Thank you.
Thank you, Dr. Rachi. I thank all the speakers as well as my co-chair and expert panelists. Thank you for this. Please come up to the stage for a photo and then we'll conclude the session.
Thank you all the dignitaries. I request you all to kindly collect the mementos. We now move on to yet another challenging case presentation session. Guiding this session, I would like to invite Dr. Prabhavati, Dr. Saiko Takahashi, Dr. Rakesh Jain, and Dr. Vijay Lakshmi to chair the session. Supporting the discussion, I would like to invite Dr. Arpit Jain, Dr. Suyash Tatel, Dr. Ashish Sharma, and Dr. Vatsal Kail. To moderate the session, I would like to invite Dr. Shiva George on the dais.
Audio also you needed? Ma'am, your laptop. Need audio? No.
I need a
because this mic doesn't work. Connect no. My presentation not connected.
Good afternoon, everybody.
we will start the session. The first speaker is Dr. Monica. She will be presenting on acute occlusion of ostial calcific left main with bizarre anatomy, a catastrophic event. Monica, you can start.
This is different, Monica. I think only photo is mine, name is mine, the description is different. Okay, no problem. I am Dr. Monica. I am Associate Professor in Cardiology and I am working at KMC Manipal, Mahe, Karnataka. And of course, I am Associate Professor in Cardiology and Monica J is my name and that photo was indeed mine. So we start with the presentation. Can you please connect? Somebody, please connect.
Please connect the...
It's not coming. Why they have to go? Okay. Fine. So my case is a 60 years old female, non-hypertensive, non-diabetic, presented with chest pain for last 3 hours. And when she was brought to triage, she was in ventricular fibrillation and resuscitated with 2 cycles of CPR. Now what happened was, she was intubated and started on inotropic support. With inotropic support as well, her BP was only 60 systolic. And on presentation, this was her ECG. So I understood we are dealing with left main, and I was in OPD and my boss was in Mumbai. So I had no choice but to take this patient up, keeping my OPD patients waiting. So I took up the patient, put the IBP first, and this is the angiogram. You can see there is a distal RCCTO and a bizarre anatomy. Ostium of the left main cannot be seen in aleocaudal view, in aleocranial. After something we could see in aleocranial. However, I had no time. I quickly wired. Just see this. We cannot see the left main ostium here because it is occupied by thrombus and a bizarre anatomy. So we quickly wired. I was lucky enough to get into that critical left main. I wired into LAD. First I went into the ramus, which was a CTO possibly, and then I wired into LAD. And then, you know, I actually tried wiring circ, thinking that I should not lose circ at all because there is no flow in LAD. No flow in circ will be another disaster. But I could never enter the left main ostium because it was so very tight and calcific. Then, because of the hemodynamics were not permitting me to wait, I just balloon dilated with 2 and 2.5 mm balloons here. And then IVUS could not cross. So I took the stent. It was difficult advancing the stent, but with slow, small push, I could advance the stent. And I thought in aleocranial, I have covered the left main ostium, and I deployed the stent there with 3.5 by 28 mm DES. And I post-dilated with 3.5 mm balloon initially, and then I did IVUS, which could not cross fully, but however it could cross up to the just after the left main, and I realized I need to further optimize the stent, so I dilated with 4 and 4.5 mm balloon, and ostium of the left main was done with 4 mm by 8 mm balloon, and this is the final result. So this is how, and I decided to come out of the cath lab with this result because this was enough for her to survive that day, and she survived to my luck, and we saved her. She was discharged on 5th day after plasty, and IBP was removed after 48 hours, and she has come for 1 month follow-up, completely healthy. EF has improved. Now we have planned for her RCA plasty in the next visit. Thank you so much. So I would still like to go for the take-home message. STEMI due to left main occlusion is a rare and a catastrophic event. We all know that. In the setting of STEMI, cardiogenic shock, even if it is left main calcific, CABG is not an option because patient does not give that much of time. And therefore, in such catastrophic event involving critical left main occlusion, primary PCI is the answer. MCS plays an extremely important role in dealing with left main PCIs as well as left main acute occlusions. Although SHOCK 2 trial did not show any improvement, any mortality benefit, however, it definitely improves the peri-procedural outcome. Thank you so much. With this, I conclude my case. Thank you.
Okay.
Yeah, that was, ma'am, ramus was actually ostium of the left main was occluded. There was a distal left main stenosis as well, post-stenotic dilatation as well as the proximal ramus CTO, which was collateralized partially from the right system with grade 2 collaterals.
So definitely it was one of the difficult case, and as the 60-year male in cardiogenic shock, and that LMC also was looking very poor. There was a trifurcation disease, and you have definitely got to manage it beautifully. And after that, you must have sent this patient for the bypass surgery, na?
I called a surgeon immediately after I did this case. Surgeon is a very good friend of mine. He came, he said, Monica, I am happy at least you could enter that LM ostium.
What?
Monica, I am happy that at least you could enter that bad left
yes,
main ostium.
it was the calcified trifurcation disease, very poor vessels.
So he said, go ahead. I have sent her for surgery, but he said once now you have already revascularized left main and LAD, there is no role for us at present. You can proceed with the RCA plus. Immediately in cath lab itself, I called him. Because I wanted to send her, I didn't want to lose my patient at all, at any cost. She is just 60 years old.
Monica, it was so tough case and you did a great job.
Thank you.
And you treated under the IAB balloon pumping, right? But I think this is maybe good indication for the impeller because...
Yeah, ma'am, I would like to tell you, impeller cost in India is 25 lakhs. Okay, IABP is free of cost. And at my hand, impeller is not available inside the cath lab for my disposal. IBP is available left, right, and center. We have we are the 100% imaging guided PCI center with 4 IBP machines, 4 defibrillators, 4 IVAS machines, 2 OCT machines inside the cath lab. Unfortunately, we don't have impeller inside the cath lab.
So if you have impeller, you think you use the impeller?
Absolutely. There is nothing like impeller. Impeller is a beautiful device. You can do any intervention, any coronary intervention with the impeller being there in place. Because cardiac output is maintained, whatever you do, you will never land up in a complication related to cardiac output when impeller is there. It's a beautiful instrument. I appreciate the impeller scientists who have designed this device. Absolutely, if impeller would have been there at my disposal, and if it is affording by the patient, I would have definitely gone for impeller. And it's easy to insert also. There's no difficulty for any interventional cardiologist to put impeller in the LV.
Thank you, Monica.
Thank you so much.
Thank you, Monica, for the great case and well managed. We will next move on to the next presentation by Dr. Somyata Somendra. From swelling to success.
Good afternoon, everyone. Thank you for the opportunity. So I'm going to present 3 cases of central venoplasty, which I've done recently. I'm an early career cardiologist, so this is my very early experience. This is the first case. She was a 71-year female. She had CKD, was on continuous ambulatory peritoneal dialysis, was a high bleeding risk patient because she had platelet dysfunction owing to CKD, also had bicytopenia, platelet count of around 65,000. During her hospital stay, she developed acute left upper limb swelling, as can be seen in the image. And we got a USG Doppler done for her, which showed a chronically occluded brachiobasilic fistula. So no new information could be gathered from the USG Doppler. We took the patient for a venogram. So as we can see, there is an almost 100% thrombotic occlusion of the left innominate vein. And honestly, at this point of time, I did not know what to do because this was my first case of any central venous procedure. So I just decided to, I think one slide is missing. At this point, I was very apprehensive of the risk of acute pulmonary embolism if I do any manipulation with balloon of this left innominate vein. So I decided to do a catheter-directed thrombolysis at a very low dose of altiplase of 0.5 mg per hour for 24 hours. And then again took up the patient for a check venogram the next day. That slide is missing, but it showed that there was a very less reduction in the thrombotic burden and the venous drainage did not improve significantly. So we took the patient for venoplasty. Initially, the thermovire could not be negotiated across the lesion, so I had to take a long sheet for extra support and then crossed it with a stiff angled thermo. After this, I took a distal venogram, so we can see that because the basilic vein was chronically occluded, it was draining into the axillary vein through the collaterals. The cephalic vein was fine and the axillary vein was also fine. So it was mainly a problem of the central vein, that is the left innominate vein. I think the slides got messed up, the sequence. I'm sorry for that. So this was the image I was talking about, that when we took the patient for the first time for venogram, I decided to do a catheter-directed thrombolysis, and this was on the right side is the result after the catheter-directed thrombolysis. So like in coronaries, acute thrombotic occlusion, sometimes we try to just plaster the thrombus. In this case also, I decided to avoid any balloon manipulation of this thrombotic vein and just went ahead with direct stenting with a self-expanding stent, Boston Epic 8x80. After stenting, I did a post-dilatation with 8x40 Mustang balloon, and this was the final result. Within 12 hours, the swelling resolved, and we can see on the right-hand side the image of the hand of the patient, and the patient got discharged uneventfully. So this is the second case. This gentleman presented to us with, in a very dire situation. He was a CKD patient, was in sepsis, septic shock. He received CPR outside and came to us on inotropic support, was immediately intubated, and later on during the hospital course, tracheostomized. He was also a high bleeding risk subset. Because of CKD, he also had bicytopenia, also deranged INR. During the hospital course, he developed acute onset facial and bilateral upper limb swelling, left more than right. So again, we took him for a venogram. We can see that the SVC is draining normally into the right atrium. The right innominate vein is also draining fine. But similar to the previous case, the left innominate venogram showed almost 100% occlusion of the innominate vein, and the left internal jugular vein also had a diffuse thrombotic segment. Again, defining the distal zone, we can see that the axillary vein and the subclavian vein are fine, and just before the venous valve, there is a good landing zone, which was free of thrombus. So first I decided to do venoplasty of the left internal jugular vein with a Mustang 8x40 balloon. However, the result was not satisfactory. There was a significant thrombus burden even after balloon dilatation. So I took a larger balloon, Atlas 14x40. That also did not give a good result. So I just decided that let us first address the innominate vein. This was the venogram just prior to the stenting. There was another challenge that we were facing. We were not able to negotiate the 14 mm stent through the through the Amplat superstiff wire. It was very difficult. It was not crossing the femoral vein itself. So we had to have a 10 French delivery system for it, but we did not have any dedicated catheter for the delivery. So we cut down the LifeTech ASD 10 French sheath to the desired length so that this wall stent can be delivered across it because the shaft length of the wall stent is only 80 centimeter. So we required to cut the ASD sheet to deliver the wall stent. So after this, we took the Boston wall stent 14 into 60 and deployed it across the left innominate vein. This was the result after stenting, and then we did the post-dilatation with a 12 into 40 Atlas balloon, and this was the final result. On the right-hand side, we can see the pre-image. For the left internal jugular vein, I took the left internal jugular axis and decided to do a catheter-directed thrombolysis for 24 hours with a low dose of altiplase, 0.5 mg per hour. After that, we did not take a check venogram from the left internal jugular vein, but as evident from the post-op images, after 48 hours, the facial contour almost returned back to normal, and the facial swelling, arm swelling reduced to almost negligible. This is the final case. I did it just before catching my flight to Indore. So I would have missed coming here if I was even 5-10 minutes late. So this was a 66-year male, acute facial swelling and bilateral upper limb swelling was his presentation. CCT chest showed CA lung and suspected SVC syndrome. So this was a case of cancer-associated thrombosis. And he also had hemoptysis, so anticoagulation, we could not go for anticoagulation. So I have made this presentation just now because I got the images from my technician yesterday only. So this was his SVC image. We can see there is a large thrombus chunk at the, in the SVC, which was hampering the drainage of the upper limb extremities and the face. A left innominate vein just at the junction of joining with the SVC also has a large thrombotic burden. So I did balloon angioplasty of the left innominate vein with Atlas 12 into 40 and deployed a Venovo self-expanding stent 16 into 80 mm in the SVC. And this image is also sent by my technician. I have not been able to meet the patient because I'm here. So there was a significant reduction in the facial swelling, and my technician told me that he could not even identify the patient. So I think it really works well. So the learnings from these cases, learning for myself also because these are my first 3 cases recently done. Central venous angioplasty is a feasible and safe option in acute thrombotic occlusions, especially in high bleeding risk group patients, including cancer-associated thrombosis. Every case is unique in terms of patient demographics and anatomical challenges, thus demanding tailored approaches, spontaneous thinking, and on-the-spot decision-making. Thank you so much for your kind attention. Thank you for the opportunity.
So, Mita, those were excellent cases.
Thank you, ma'am.
Go to the first slide and show me the hand. The moment I looked at it, I made. Because I want you to be an excellent cardiologist, that's why I'm showing.
Yes, ma'am.
Can you, the hands, go to the second slide. Okay.
Sorry, ma'am.
Look at the fingers, those who are there. This is the basic. Knuckle pigmentation is there, the nails are pale. And that's the megaloblastic anemia. The megaloblastic anemia, invariably B12 deficiency, will cause hypercystenemia, and then they will have the thrombosis and also the deep vein thrombosis, damage of the vessels. So the mediocre doctors treat the disease, whereas the excellent doctors prevent it. So I know CKD causes the anemia, but if you treat the B12 deficiency, you will not have the further thrombosis like this.
Thank you so much.
That's what I wanted to point out. These are the basic clinicals we are forgetting now, and that should not be forgotten.
I think excellent cases by Dr. Soumyata. I just want to ask you, since you have done a lot of study over this topic, so what are the outcomes of stenting versus just balloon angioplasties when we are talking about the venous system? And second is, are there any special types of stents which are particularly designed for the venous system? Because these arterial stents are usually having high thrombotic risk when we have placed it in a low pressure venous.
So personally, I don't have much experience. These are my only 3 cases. But in all the 3 cases, the balloon angioplasty alone was not sufficient. The series that I've gone through before performing these cases, there were good results with balloon angioplasty also. And the midterm results with stenting were also good. The restenotic rate was not very high, except in cases with cancer-associated thrombosis. They have a recurrence rate of 70%. And in two cases I have used dedicated venous stents. Venovo comes from Bard. It's a dedicated venous stent specially designed for SVC and IVC. Wall stent from Boston is also designed for veins. But the Epic stent, which I used in the first case, that is a cheaper stent, and this was my first case only. I had no idea about it, honestly. So I used Epic stent. I read it from a case report of my teacher only from PGI Chandigarh. So it was a very similar case that he reported. So I used Epic, but that is dedicated for peripheral arteries, not vein.
But excellent results. And what is the antiplatelet or anticoagulation strategy you follow after stent?
Sir, I have kept them on low dose of Epixaban, 2.5 mg BD, because they are high bleeding risk patients. Antiplatelets, I don't think they have a role in venous procedures. No. I loaded two of them with clopidogrel and kept them on clopidogrel 75 mg along with Eliquis for 1 month, but not after that. I don't think antiplatelets have much data on venous in venous thrombosis.
I have just one question, ma'am. Three cases very well, but I want to know that while doing this intervention of the venous system, like here innominate vein, are you taking care of any thrombus embolization during the procedure?
Yes, sir. My biggest concern during the first case was acute pulmonary embolism, because SVC is just going to go into the RA. The thrombus can very well go into the pulmonary arteries, but there is, in case reports and series, there's not much data about it, but there is negligible risk of acute PE in the series that I have gone
Still, if something like massive embolism happening, because of the venous system usually have a large chunk of the thrombus in such cases.
Maybe we
so do you have any measure to prevent the embolization?
I'm not sure of the upper venous, like upper central veins. In IVC or in the lower peripheral venous system, we have IVC filters, but for the upper system, I don't know, the best thing we can do is just stent it before doing any balloon dilatation.
Yeah, I agree with you, because if there is a deep vein thrombosis in the lower limb, you get the pulmonary embolism. And this sort of upper limb and the SVC we have seen in the patients with malignancy. Very, very common, and they come with the florid edema of the face, neck, and upper limb. So the cancer also has to be ruled out.
Yes. The third case, the patient had
last case was the cancer only. Last case was the cancer only. Yeah.
Yes.
Thank you.
Hi, can I? Three observations. One, the moment you cross the junction between clavicle and first rib, avoid stenting, because that's the thoracic outlet. Avoid stenting. Most of the cases that you have shown are dialysis dependent. So that is also, and in that case, avoid stenting. Third, speed of reperfusion is not as important as in arterial occlusion. So probably doing a balloon angioplasty, even if you do not have a brisk flow, you can top up with a half dose retiplase, a low dose retiplase, and an heparin. So that, usually venous system clears very well. So you can really avoid stent. Especially it is advisable in patients who have issues of dialysis, because the access will become a problem. So avoid stent whenever you are crossing the clavicle, and probably speed of reperfusion is not important. These are the two things that are takeaway.
I didn't get the second point, sir.
Speed of reperfusion in a venous is not important, and nowadays, of course, with Inari and Penumbra, they are very good choices in such kind of.
They're too costly.
I have
but
to,
they have, you can use it in 2-3 patients. Yeah.
Yes.
Yeah, I have to tell that in upper limbs, there are always chances of proximal dislodgement of the clot. Okay, not the distal dislodgement of the clot. For that, we have come up with 2 new devices. Okay, I don't know, Acura is yet to come in India, but I have seen the result, and it has a funnel to catch the proximal thrombus. Okay, that is called Acura device. Okay, there is a filter, proximal, so that if you have a subclavian thrombus, you definitely aspirate and you funnel it. Okay, that device is yet not launched in India. Inari device you can definitely use. Penumbra device in subclavians, the only risk with penumbra is proximal embolization, and proximal embolization in subclavian may not be acceptable because it might go to brain as well. Therefore, I would say you go through the articles, you go through the literature, and get Acura for such kind of case.
Thank you, ma'am.
I've seen that device in TCT, Washington. So I was very happy. And I had a patient who was a nurse who had subclavian thrombus like this. And I asked for the device, but it was not launched in India by then. Thank you.
Thank you.
Thank you for that excellent presentation. Give a big hand. Next presenter is Dr. Jasmine Vehora. Dr. Jasmine is there? Go ahead. If it is getting delayed, can we go to the next presentation?
It is there, madam, in this laptop?
Yes.
It is there in this laptop. So you've connected? Yes. This is your laptop? No, no, this one, that one. So, it's not getting connected? Yes. Let's sort it out there. Next presentation. No, sir. Will be connected.
Presenter is from the next session. Dr. Vinna Kotachdan. I think next presenter should be ready.
So thank you for giving this opportunity. to present my work here. So today I will be presenting a challenging case that highlights a formidable complication in the cath lab, LCX bailout PCI in the setting of osteal LAD thrombus migration. So our patient is a 50-year-old man presented with complaint of chest pain.
Can you go to the power
6 hours duration.
PowerPoint slideshow?
No, sir, it will not play in slides. So his ECG showed sinus rhythm with anterior STEMI, and initial assessment by echo revealed left ventricular regional wall motion abnormality with EF of 45%, and he was strop positive. After receiving dual antiplatelet and statin loading, he was thrombolized with streptokinase. And the following day, angiography, coronary angiography was done, which revealed single vessel disease, a total thrombotic occlusion of left anterior descending artery from the ostium. And as we can say, left circumflex showed only a minor plaque, and the RCA was normal. So our plan was straightforward, PTCA to LAD with one drug-eluting stent. So we began with LAD osteal balloon dilatation. So I started with 1.5 millimeter balloon, and it doesn't give satisfactory result. So again dilatation was done with 2.5 millimeter balloon. So this is with 2.5 millimeter balloon. So however, after balloon dilatation, I faced a challenging complication that thrombus from osteal LAD migrated to the left circumflex ostium, as we can see here. So analyzing the causes, the causes can be inadequate anticoagulation, manipulation with guide wire, stents or balloons, multiple times use of small size balloons, or multiple attempts with different size balloons, or high thrombus burden and angry clot. But in our case, we have adequately heparinized the patient, and antiplatelet loading was also adequate. So this is showing after 2.5 millimeter balloon, flow was restored in left circumflex ostium, as we can see. So I plan to put stent in LAD ostium. The stent was deployed, 3 into 32 millimeter drug-eluting stent. So after putting stent, again thrombus migrated into left circumflex, as we can see here. So again I have done POBA to left circumflex to clear the lesion. So this is with 2.5 millimeter balloon. POBA was done. So however, I was not able to clear the thrombus with only POBA. So I planned bailout stenting of left circumflex ostium with 3 into 8 millimeter stent, drug-eluting stent. As we can see here, ostial left circumflex stent was deployed. So both stents were adequately post-dilated. However, some thrombus was there in small branch of circumflex that was kept on tyrofeban. So in my case, I have chosen bailout stenting for left circumflex ostium. There are other management strategies also, like thrombosuction and adjunctive pharmacotherapy also sometimes be helpful. Yeah, thank you.
I think, ma'am, you did a very nice job by doing a bailout flush to L6 as well. But did you consider doing a left main to LED in the first go, or starting straightforward with a thrombosuction as you saw a huge thrombus burden? Even after doing a simple balloon angioplasty with a 1.5 balloon, you did see a huge thrombus burden. So did you consider thrombosuction or doing a left main to LED stent in such cases?
Yeah, I think management strategy can, like some other perspective can also be there. Like it is very near to ostium and heavy thrombus burden is there. So LM to LED stenting can also be planned. But in my experience, these type of complications are very few. Like we are able to do ostial stenting. So it was not expected in this patient. And heparinization was also adequate and antiplatelet was also given. So we were not expecting actually. But I think that multiple balloon attempts may be responsible. Smaller size balloon was used. And direct stenting also an option, but it was totally occluded. So anyway, I have to balloon once.
Maybe there can be a carina shift that has caused the pinching of the LCX rather than thrombus after stenting.
Yes, it is possible.
But anyways, the result is looking good. So did you did any kissing balloon of the LED and
No,
LCX?
sequential dilatation.
Sequential, but
yeah.
Okay. So actually the polygon where crowding of struts will be there. So this LCX stent might have distorted some of the LED struts which have been previously coming in front of the LCX. So either, as he's saying, you can do a stent from left main to LED to cover the whole area, and then again you can do the whatever we do in a mini crush with kissing and then pot.
Yeah, it
or
is possible.
else you can do at least a kissing balloon or imaging maybe, just to see what is going on at the polygon.
Imaging was not possible due to financial constraint. So
The
Yeah, that is
life-saving
okay.
procedure, it was perfect. The only thing was your LCX stent was also hanging. So the future procedure, if anything happened to LED, that time you have to wire it very
the
carefully.
patient is in close follow-up. So he is doing well.
In future, the wiring of LED will be tough because LCX stent is also hanging. Only that is you have to see. Okay.
Yeah.
And,
Nicely done, nicely.
One more thing I want to add, that means I have a query. that if even if doing the during the plasty of the LED, if there is a migration of the thrombus in circ, and if it's not a flow limiting, why not to keep the patient on anticoagulation for 2 or 3 days and then check if angiography should be done? Because unnecessary doing plasty for the double vessel, that at the bifurcation of the LMCA, I feel it's going to be difficult in the future for the patient.
But sir, that lesion was looking very critical, so I didn't took chance.
Patient was having pain at that time when the L6 was pinched.
Patient was hemodynamically stable.
And any complaint of pain or
just
angina
pain.
at that time?
Some chest pain was there, otherwise hemodynamically stable.
Okay, so we should move to the new case, madam.
Thank you.
Yeah, thank you, Dr. Jasmine. A nice presentation in spite of technical difficulties. I think next we are going to the presentation from the next session, that is by Dr. Vinnakota Sujani, case of okay. Anyway, she'll be talking on double whammy.
No, ma'am. That's also wrong.
Vinnakota. Vinnakota Sujani. Is it yours?
No, ma'am. They're doing it.
Same one, huh?
The last.
Anybody else is ready? Anybody else is ready?
It is here, but it's not getting. Yes, it has opened.
Okay.
Yes.
Okay. Go ahead.
Good afternoon, all. My case is a 71-year-old male who was admitted with us with in STEMI with ST depressions in V2 to V6 and RWM in the L6 territory with a mild LV dysfunction with a EF of 45%. He's a known case of diabetic and hypertension. This is his angiogram. We can see it's a severely calcified vessel with a tight stenosis in the L6. LMCA is diffusely diseased and LAD is also diffusely calcific disease. So the plan is, as it is the RCA is non-dominant and as it is a true complex LMCA bifurcation lesion, we have decided to go ahead with a upfront two-strand strategy and with the calcium modification and image guided. Right femoral approach was taken, 7 French EVU 3.5 was used and guide wires were placed in both LAD and L6 and the OCT catheter, this is the OCT imaging of the L6. We can see that the ostial L6 is a fibrocalcific with a very tight stenosis and the LM, there is a calcific nodule throughout its length. The OCT catheter could not cross the mid-LAD lesion which was very tight. So we went ahead and did an orbital atherectomy up to the mid-LAD and again to the L6 also. This is the OCT imaging of the LAD post-orbital atherectomy. We can see that it is a diffusely calcific 360 degrees ring of calcium. We can see some sanding effect caused by the orbital atherectomy. The lesions were predilated, the LAD and the LPDA was predilated with 2 and subsequently 2.5 NC balloon and LMCA to osteoproximal L6 with a 3 into 12 NC balloon and LMC and osteoprox LAD was pre-dilated with 3 NC balloon and 3.5 aperta scoring balloon. And then it was followed by stenting to the distal LCX to LPDA and osteoproximal to mid LAD. At this point, after stenting both the lesions, we could see a type 2 coronary perforation with an exit hole from the very distal terminating branch of LPDA. But at this point, the patient was hemodynamically stable, and we proceeded with the next step, that is stenting of the LMCA to LCX. But after this point, the patient became hemodynamically unstable and urgent pericardiocentesis was done. We kept a balloon inflated in the distal LPDA, a 210 balloon, and in the meantime, we completed the kissing balloon inflation and the POT. And we have waited for around 10 to 15 minutes. Even after that, the perforation was not sealed, only with the balloon inflation. And we thought of embolizing the perforation, but when we attempted to remove the balloon, the balloon shaft fracture occurred, and almost the 1/4 of the balloon shaft remained in the coronary artery. So first we attempted to remove the balloon shaft by intertwining the guide wires. It was partially success, but as soon as the balloon shaft reached up to the tip of the guide catheter, it was not going into the guide catheter. It was just stuck at the guide catheter tip. So we abandoned that, untwined the guide wires, removed the guide wire, and placed another guide wire. And through this another guide wire, we have taken a 2 balloon and entrapped the balloon shaft, which was remained in the guide wire, and then we removed the system in total. And to address the perforation, we proceeded embolization with a liquid embolizing agent, Onyx. The Echelon microcatheter was placed at the point of perforation. And once the microcatheter tip was in the desired position, first a 0.25 ml of DMSO was injected to fill the dead space, followed by Onyx. First initially 0.25 to fill the catheter, and 0.6 ml was used to seal the perforation. We have done again a kissing balloon and POT. This was the system which was removed, and the right side is the balloon shaft that was remained in the artery. This is the final result. We can the Onyx, which was used to embolize, is a radiopaque substance. It remains throughout like that only. So when we are dealing with the complex lesions, we have to hope for the best but prepare for the worst. And the complications are common, especially when we are dealing with the complex severe calcific vessels. It is important to be familiar with various bailout strategies, and treatment of coronary perforation requires early detection and immediate occlusion of the coronary vessel. Liquid embolization technique is a safe and feasible option in some cases where there are distal coronary artery wire perforations. Thank you.
I think very difficult case, and you bailed out very nicely at both the points. Just wanted to ask what the wire that was used in the LCX?
It was
the coronary wire.
Sion blue wires.
Okay. So it was normal workhouse wire.
Normal workhouse wire.
But Sion blue do cause many a times this kind of perforations. But you did a great job, and by sealing that perforation as well as pulling out that balloon into the shaft. What balloon did you use? That was a 7 French guide.
Yes, a 7 French guide for inflating in the distal LPDA you are asking.
Yes.
That is a NC balloon, sir, 2 into 10 NC balloon.
And you did that sealing of perforation later on. If you did pull that balloon first, so you did say that there was hemodynamic instability, and you had to do a pericardial tap as well in between. So doing a sealing first or removing the balloon?
Actually, this sealing with onyx, we were waiting for an interventional radiologist. In our center, the interventional radiologist commonly uses onyx for their neurological procedures. So we were waiting for him. In the meantime, we have kept the balloon inflated and completed the remaining procedure. But in between, the shaft fracture occurred. Again, we have to deal with that.
You did a great job, ma'am.
Really great job. The balloon was ox, which shaft got broken, right? Or it was N. How the balloon got broken? How it? Have you pulled it up or?
Actually, the point was that when we are doing the kissing, there were multiple balloons. So instead of pulling one balloon, the other balloon might have pulled out.
And when it got broken, the shaft part was in the guide catheter or it was completely inside the coronary?
Partially, it was in the guide catheter, sir.
So
We have done an OCT imaging to confirm whether the shaft is really in the guide catheter, and it was in the guide catheter so that we could entrap it with the balloon.
Really great.
Thank you, sir.
Thank to Almighty, the patient survived, and your efforts.
Thank you.
You are only presenting, Monica? They said other Monica. Okay, Monica, go ahead.
Can you connect my laptop, please? I need hand mic. Take this. Connect, no? Good afternoon, everybody. I know I am crashing into the session because I had overlap of two cases, one downstairs and upstairs. So I'm presenting what I was supposed to present downstairs. So I hope you enjoy this. Thank you so much. So thank you, Sarita Madam, Wincars, and entire organizing team for giving me this opportunity, and the panel and the judges. Thank you so much. It's not come. Can you connect? Let's start. It comes. Let's start with the case. My case is a 49-year-old male, non-hypertensive, non-diabetic, no comorbidities in past. He presented with 1 month of epigastric discomfort. He was with being treated by a gastroenterologist for 1 month with pantoprazole, omeprazole, and whatnot, I don't know. And then he came to me for clearance for UGI scoping. So I saw the ECG. ECG showed ST depressions. ST depressions downsloping in inferior leads. And there was no RWMA seen on echo. However, patient has typical angina when I asked the history. So I went ahead and advised him an angiogram, and troponin was borderline, 0.06 nanogram per ml. So I went ahead and did an angiogram, and this is the angiogram. So I initially, with the first angiogram, I could not understand what exactly it is, whether it is a CTO, whether it's an ACS, but his symptoms are just 1 month old. So I thought it is not a CTO, and there was no RWMA on echo, and he had persistent angina. So I went ahead and let us see. Left angio was okay, other than normal, other than some plaque in mid-LAD. So we did a simultaneous injection to know if distal flow is there. Yes, there was some distal collateralization, and we saw this. So I realized it's a huge ectatic artery with a high thrombus burden, and I considered it as highly thrombotic, organized, almost semi-organized thrombus in the ectatic RCA. So I tried to wire with Sion blue wire. However, Sion blue was not crossing easily. But somehow with balloon support, I crossed the lesion. It was a difficult wiring. I thought I might require fielder, but I could get away with Sion blue. and after I wired, I dilated with 2 mm and 2.5 mm balloon, and once I dilated with 2 mm and 2.5 mm balloon, nothing was crossing. So I decided to go ahead with laser. We have laser at our in our cath lab, so we went ahead and did the laser. First, we initially started with 60, 60, 60 rate and 60 fluence, and then we went with 60 and 80, 60 fluence and 80 rate. After the laser, this is the angiogram. We could really get away with lot of thrombus. And this is the IVUS. I must tell you, I always tell, I am from a center with 100% imaging guided PCI, whether it is ACS or non-ACS. So we stented distal RCA with 4 by 38 mm disc and proximal RCA with 4 by 38 mm disc and post-dilated with 4.5 mm balloon, and this is the final result. So we are happy with it. Let's move on to the next case. Now this was a similar case which was presented 2 days back by madam. 63 years old male, known case of type 2 diabetes and hypertension, history of RCA PCI way back in 2013, and he had angina which was class 3. He had one tight lesion ISR in the proximal RCA, mid RCA was thrombus, and distal RCA had a CTO. Now how to deal with it? Now patient said, okay, I will go home and come back. He was from Kerala. So he went to the train station, and at the railway station he developed acute angina, and he came back to me on the same day. So we took it as ACS. STs were elevated, so we did not have time to wait. We had to open the artery, and we went ahead and opened the artery. So initially we started with Sion, where we took the microcatheter in. Then we started with Fielder extriate, did not cross. Then I took a Gaia 2 wire, and with Gaia 2 we could enter the distal RCA. However, we landed up in minor dissection in the distal RCA, but yes, we were through the RCA. Then IVUS catheter was not going, so we decided to balloon also was not going, so we decided to do laser. We did laser from proximal to distal RCA with 640 to start with. We started with 25 and 40. Then we went ahead with 40 and 60, and then we did with 60 and 80. That is 60 fluence and 80 rate. So we did it successfully. However, distally we did it with 20 and 25 and 40. And after this is the result after laser. After laser, we stented the distal RCA with 3 by 38 mm disc and osteoproximal RCA with a 3.5 by 35 mm disc, and this is the post-stenting result, and this is the final result after optimization of the stent. So my take-home message is, excimer laser is a great addition to the cath lab armamentarium. This technology provides a solution to a variety of problems, and it's a one-stop solution for many problems we come across, like CTO, massive intracoronary thrombus in ACS, uncrossable lesions in SVG interventions, and in stent under expansion. So careful case selection, proper use of equipment, and safe efficacy lasing technique all play crucial role in successful LCA PCI. Thank you so much. That's my team. Every cath lab success is a teamwork. Thank you so much.
Any comments from the expert?
What is your strategy for using laser in mainly thrombotic cases? So which cases you avoid, or which cases you most commonly go for laser upfront?
We don't use laser in all the thrombotic cases, yes, but if it is a delayed presentation wherein you expect the slow flow after balloon dilatation, and even after thrombus aspiration, if you still see thrombus, you can definitely use laser. Delayed presentation is one thing wherein you should plan laser upfront.
Dr. Monica, may I ask you, your last case was especially appealing to me. I have no experience with the laser. Your wire was obviously in the end a subintimal position, and you said you did use different fluency and different frequency. Did you actually use laser to re-enter the luminal space there? How did that work?
No, the distalmost wire, the first one which caused dissection, was the Gaia 2. We exchanged it with Cyan Blue, and that time we confirmed with IVUS that we are in true lumen.
Okay.
After confirming only we are in true lumen, we went ahead and did balloon dilatation and lacing.
I see.
That is a protocol, sir. We don't do balloon dilatation or lacing on the CTO wires. We usually do it, 99% of the times we do it on a workhorse wire.
And is there any place for laser in
I
the...
thank all the speakers. In the
Okay.
interest of time, we'll conclude this session.
Thank you so much,
Thank you
Dr.
so much.
Stephen.
Thank you so much, sir.
Thank you so much to all speakers, chairpersons, and the experts on this session. Please come together for a group photo. Please come together for a group photo. Thank you so much. Okay. Vidhi, I will request you to please give mementos to all the chairpersons. We come to a very important point. We have just paused it for a minute because many people have flights to catch. I will request Dr. Sujata, who is the chairperson of Vinca's organization, to please announce the results of the Survey Research Award, the National PZ Quiz. And I will request Jyoti, Dr. Jyoti Rana, to please come up. She is from Surveyor, and Surveyor is a research partner for the Surveyor Research Award.
So I have great pleasure in announcing our research awards. The research award goes to Dr. Sade Tejasri. She's a student from Srikakulam RIMS Medical College. You didn't say hi to me. I'm the one who... The second prize goes to Mr. Shovan Kumar. He's coached by our own Chabi Satpati, and he's from Orissa. Next is the faculty. It is Dr. Surbi Handa.
Announced for WCC next year also.
After that. The National PG Quiz conducted by Asha. We have Dr. Rajeswari Lingala and Shashank Jaiswal. First prize. How come you all are faculty, no? Oh, okay.
Oh, they are conductors. Come.
Dr. Kamala Joshi and Dr. Vandita Sunil Sate. Kamal Joshi and Vandita Sunil Sate. I'm confused. Second prize is who? Okay. Who are they? The other two? Okay. I got confused. So, the second prize goes to Dr. Kamal Joshi and Dr. Vandita Sunil Sate. Where are my girls? The third prize is tied. We have Sai Sujana and Sai Sumana. They were here, the sisters. Oh. And it's shared by Dr. Shavan Kumar and Milan Kumar. If they're not there, no, you can give it up to them. Match fixing. I know them. Yeah. The abstracts, the special mention, Dr. Shiba George, our own faculty, Dr. Harmeet Kaur and Dr. Milan Kumar for the good abstracts. Shiba ma'am, Dr. Harmeet Kaur and Dr. Milan Kumar. Okay. Congratulations, very. Ma'am, Shiba ma'am is here only. That's okay. That's all, no, over, no.
We'll get going.
Sarita? So we are announcing the next WCC and none other than Asha Mahilmaran will be conducting at Chennai. So over to Chennai.
So congratulations to the organizing secretary of the next year WCC 2027, Dr. Asha Mahilmaran at Chennai. We look forward to everybody supporting and joining us there. Big round of applause for her.
Don't look so tense.
Welcome you all and make it a grand success next year. Enjoy the hospitality, scientific content and the ambience of Chennai. Welcome to Chennai in March 2027.
Moving on to the next case presentations. Guiding this session as chairpersons are Dr. Jayashree Kharge, Dr. Vijay Lakshmi, Dr. Nagmani, and Dr. Michael Hanno. Supporting the discussion, we have an esteemed expert panel comprising Dr. Shirish Agarwal, Dr. Parvathaniri Naga, Sri Haritha, Dr. Rashmi Verma and Dr. Abhishek Nagar.
Dr. Shirish Agarwal, please come. Dr. Vijay Lakshmi, madam. Dr. Vijay Lakshmi, ma'am. You're on stage. Huh? The madam will do it. Please come, ma'am. Dr. Rajeshwari Nayak. Oh, you have a flight. I need someone to moderate the session. Who is there? Who does not have it? Ma'am.
From yesterday, we have witnessed a wonderful batting by each presenters. Now let us see what the tail enders are going to do. Yeah, shall we call? Huh? Monica? Yes, ma'am. Tell me which one. Huh? Yeah. Dr. Monica? Done? Huh? Doctor? Where is it? Yeah, Dr. Maria, please. Yeah. Maria, please. You mark and show me. All are there? All are there? All are there?
Good afternoon, everyone. Thanks, Vinkas, Dr. Sarita ma'am, for the opportunity. Fag end of the day, trying to wrap up fast. Presenting IVIS-guided PCI intervention, a low-contrast PCI. I had got the second chance. Last time also I presented a similar case, but it is a different case of a low-contrast PCI. As we all know that when we deal with the multi-speciality hospitals or any hospitals, we don't have a normal set of patients. We have patients elderly, diabetic, hypertensive, we have CKD patients, they have an aversion to the risk of contrast-induced nephropathy or chronic kidney disease. They are very much worried to undergo angiogram. Even we ourselves as a cardiologist or even physicians or even our other fraternity would never refer the patient for an angiogram thinking the creat would go high. Contrast-associated acute kidney injury is increase in the serum creatinine of more than 0.5 milligram per DL or more than 25% increase from baseline at 48 to 72 hours following the administration of the contrast. So minimal, safe, maximum contrast dose is the ratio of the contrast volume to the EGFR is less than 1. So presenting my elderly gentleman, 80-year-old, diabetic, hypertensive, no ischemic heart disease, more than a year, and he's been referred by another hospital because he denied any procedure. He visited 3 OPD visits, and since he continued to have chest pain, then he agreed for an angiogram, where cardiac MRI done elsewhere showed the viability of only L6 and RC in the basal LAD, but other territories were non-viable. EF was 35% with moderate LV systolic dysfunction. To begin with, the creat was 2.17. We stabilized a couple of days after admission with the help of the nephrologist. Made sure it is 1.57 because the creatinine clearance was quite high. It was very low, 34 ml. And then the angiogram when we did, this is what it revealed. RCA proximal was ectatic followed by a subtotal occlusion. Looks a thrombotic one, and we can see the LAD distally filling through one of the RV branch entirely to the LAD. And at the same time, the left side shoots showed that L6 was moderate disease and LAD proximal was 70% followed by mid-total occlusion. It was a blunt angle there, and diagonal also was quite tight. It was almost like 99%, 95%. So the approach was, we know it's a elderly gentleman who had a high creatinine. We wanted to make it simple so that the patient will not come back again. We are aware of that. So we went through the IVIS guidance with a balloon anchoring technique. So the first approach was with the JR, 7 French. I had difficulty cannulating. I would have taken AL. But with the help of an anchoring balloon, sometimes if the wire doesn't go, we have buddy wire technique. An anchoring balloon really help us to pass through, and then we can drill the microcatheter into it. With 6 atmosphere or something with the other side branch, I deployed, and then we were able to pass through with this microcatheter, exchange the pilot with the BMW. Following this, I ran an IVIS to make sure what is there. Entire RCA from distal to the proximal, more than 180 degree of the calcium. A various form of the fibrotic lesions were there, not the thrombus. And even for the surprisingly, what we could see is even in the proximal part as we approach, this is all in the mid part, this is the proximal part what you're seeing. And then as we come towards the proximal, we can see the wire which is coming inside. This is actually the anchoring wire there. Even in the proximal part also, there was a good amount of the fibrotic plaque, because of which we had to land the stent from the proximal part. So by using an IVIS, if we understand the image modality, we can understand where to stand, where to place the lesion, the ballooning. So we did serial dilatation, starting with 1.5, 2 mm, then went up to 215, then cutting. But OPNC balloon we had to use because there were certain areas where the calcium was more than 180 degree. We had to go with high atmosphere. One of the advantage of using OPNC is every time it's not like you can use rota or the other modalities. If you use the modalities nicely and it has a double coating balloon, it opens up very high pressure. It's a boon for us when we use this for such people, and it helped us to, and it has no dog boning effect. And then of course the cutting balloon, which has a very good atherotomes which cut precisely, and then it helps the balloon to expand. In preparing the bed before placing a stent, these are very good plaque modification techniques. Following that, I decided the proximal landing zone and distal landing zone where it was to be. Always make sure the proximal landing zone is at least having less than 50% of the plaque burden, and that's how we can decide here. And always in IVIS, unlike the OCT, we compare the plaque burden not from the EL to the lumen, but to the reference vessel diameter. Then we had to use a cutting balloon because we know that there were a lot of fibrous lesion which was actually present, and especially in the proximal part of it. As we are approaching here in the proximal part. So you can see the calcium in the 9 to 12 o'clock position, and then quite a good amount of the fibrous plaque was also there. Deciding the pre-stenting IVIS measurement, we never used dye in this. We continued to only do with the IVIS. And then we understood that the proximal was around 4.49, distal was 3.69. Then we deployed with a drug-eluting stent. The advantage of Zyme stent is that it starts from the tip. So it's very easy to recognize where it starts. So we deployed with 3 into 48 mm, and then post-dilated distally with 3.25 and 4 into 12. Following this, we ran an IVIS, we could make out that there is an under-expansion. It is malapose and not expanded very well. So again, we went with 4.5 into 6. So following this, this is actually the result what we got. So it was a good expansion, and you can see that there is no edge dissection, good apposition. Following this, I was little brave enough to actually even start with the LAD. So slowly we thought LAD was a blunt end, will not go, at least we'll try to open the diagonal as the basal segments are viable. So for my surprise, yes, with the 6 French EBU Chion blue wire, we started going with the microcatheter. Went with 1.52 mm balloon, there the balloon is not expanding exactly at the ostal part of the diagonal. Then we understood that there is a 360 degree calcium which has been present, which is not allowing this to expand. So not the cutting balloon would go, nothing would go. So again I had to use another OPNC balloon. Luckily they were ox, we didn't charge much for the patient. 2 into 10 mm, we opened up very nicely, and then we did 3 into 10 mm cutting balloon, and then we pre-dated LAD with 3 into 10 mm balloon. Following that, the IVIS, we could understand that there was still some amount of the plaque which has been there. We can see some cuts here subsequently. Then we put a 4 into 12 mm drug-eluting stent in the proximal LAD because there was still a lot of, there was fibrous lesion was present, 70% stenosis, LAD pre-dilatation done. And then we decided to go with the DB to diagonal because nowadays this hybrid strategy is always better for elderly patients. Since it was dilated really well, I then went with DB and then POT with 4.5. Again, we ran an OCT IVIS. To a surprise, again, there was under-expanded. So this everything you can make out through the image guidance. You need not give any dye. As you see here, the under-expansion, what you can see, it's not well opposed. So we again went with the 4.5 into 6, and this is the end result what we got. So this patient is following up very well with us. It's been almost more than 6 months to 6 months, and his EF is also improved. So ultimate trial, the ultimate PCI, whatever the trials which came up, using an IVIS compare and also NO-CT will help us to reduce the target vessel revascularization significantly, which help us. And of course, our stepwise approach starting from optimizing the hydration, avoiding the nephrotoxic drug. Even if you do a normal angio, even in a normal person, make sure the dye amount is very limited. Use the road maps, dynamic road maps which is available. Use a stent boost. In this way, we can actually avoid. Thank you.
Excellent presentation, dear.
Thank you.
But I must say, I am a global proctor for ultra-low contrast PCI, me and Dr. Tom, both of us. So I would like to ask you 2 questions. One is, why did you use 7 French guide in right system?
It is because as we see that, we know that it is already a total occlusion. There may be a difficulty while passing through. And the vessel size is quite big. The angulation is also quite very difficult. Sometimes now I need to use an anchoring balloon. I can't go very easily with 6 French. Of course, IVIS can go through 5 French and 6 French. But when there is a long vessel, so I don't know what I will anticipate. It is a road where I can't see what is there ahead.
Whatever
I
you
might
take
need a
now.
rota, I might need any other modalities.
Whatever you want to use, you can use JR, 4, 6 French, IVIS with guide catheter, you can thread along with 2 wires. Okay? Possible. Cannulating or engaging right system with 7 French guide will be difficult. That is why you had to put an anchorage with the other wire and the balloon. It might not have been required if you would have used JR4 6 French. That is
Possibly,
100%.
I wouldn't deny it, but the way the calcium and way the things were there ahead, I had anticipated probably if in case I don't go with this, probably I might need a rota or something else.
Even if it is rota, you can cross with 6.
Yes.
Second point was diagonal, which ostium was calcified, heavily calcified. I would not use OPN because in a branch vessel, to use such a high pressure balloon, you are inviting.
Yes, I had anticipated if in case it happens.
You are inviting perforation up front. If it is a main coronary artery, like main LAD, main LCX, or a RCA, even if diagonal is big, it is not the LAD right now. LAD is type 3, almost leading to type 4, which is already collateralized with grade 3 collaterals from right system. So I feel I would not have personally used OPN in an ostium of diagonal, wherein you may compromise LAD, diagonal, and the patient with the perforation.
Yes.
One comment, you could have used a much more supportive guide rather than anchoring
could have
into the
used,
feeder vessel of the LAD, and patient could have crashed.
Yes.
So rather than that, you could have used guide extension. That is my comment on this.
Yes, but we were able to go through only with the wire, so we were happy about
Rather
it. The
than
anchoring
putting
wire.
anchoring balloon into the feeder of the LED, though it is not viable, it can cause ischemia and cause all sorts of
That's the
complications.
reason, yeah, that's also I anticipated because he was not coming back again. We did quite fast with this, whatever minimum.
6 French would have done the job.
6 French I did for LED. RCA.
No, RCA 6 French would have done the job. Anchorage would not have been required. For left also 6 French would have done the job. Anchorage would not have been.
Thank you, Maria, for a very nice presentation and
Thank
a
you, ma'am.
nice case.
Thank
Now
you.
I call
Thank you
upon
so much.
Dr. Rajeshri to present her case.
Good afternoon, dignitaries on the dais. Today I'll be presenting transcatheter plug salvation of aorta-fed intralobar sequestration. I am a resident at JIPMER. The patient was a 24-year-old female, presented with recurrent hemoptysis for 2 years. Vitals were normal. On examination, there was only mild pallor noted, and rest other examination was normal. And this was the chest X-ray. Here we can see there's some hyperinflation of the lung fields and a tubular heart, but apart from that, there is no any abnormality seen visualized on the chest X-ray. So on evaluation for hemoptysis, sputum studies were normal. Platelets coagulation profile showed no bleeding diathesis. ECG and echo were normal. CT chest with contrast showed no parenchymal lesion, no bronchiectasis or mass. There was one abnormality which was noted, that was dilated left inferior pulmonary vein. Bronchoscopy was negative, and CT-PA for PAVMs and pulmonary embolism was also negative. So what next? Here we have a 24-year-old female with significant hemoptysis for 2 years and negative evaluation apart from a dilated inferior pulmonary vein which was noted on the CT. So this is not incidental. So anything found on evaluation is not incidental. So it's actually the single most important clue which suggests a left to left shunt. Just like how in ASD because of left to right shunt there is dilated RARV, here because of left to left shunt there is dilated inferior pulmonary veins. Now we have to see from where is the shunt coming from. So we went ahead with the DSA of the arterial system. Here we can see from the descending thoracic aorta injection, there is an additional lung tissue which is filled in the in the left inferior region apart from the normal lung. So this is actually pulmonary sequestration, intralobal pulmonary sequestration with an aberrant systemic vascular supply from the descending thoracic aorta. What are we dealing with and why does it cause hemoptysis? Basically, lung sequestration is of two types, intralobar and extralobar. If it is shared with the visceral pleura of the normal lung, it is called intralobar. If it has a separate pleura on its own, it's called extralobar. So the clinical presentation would be of a recurrent pneumonia, hemoptysis or heart failure because it's a left-to-left shunt in the case of intralobar. When in the case of extralobar, it's a left-to-right shunt. So the arterial supply, it is predominantly from the aorta, like mostly from the descending thoracic aorta. It can also be from abdominal aorta or from the celiac axis. So this is the intralobar sequestration, and the below one is the extralobar. So our patient has an intralobar sequestration. There is a additional lung tissue which is getting systemic blood supply from the aorta that in the left inferior location. So we went ahead with transcatheter closure of this. Here we can see the dimensions on the angio. It has an inferior loop and then it goes and bifurcates into two. This is the systemic artery, the branch from the systemic artery. So we can see that the dimensions of the vertical segments are around 8.3 mm. So the device selection should be 30 to 50% larger in diameter than the target vessel diameter. So we chose a vascular plug of size either 10 or 12, like depending on whether we want to land in the vertical segment or after the second loop, the 10.4 mm if we want to land there. But we decided we want to land in the vertical segment for stability because this is like a high shunt region. The blood is directly coming from the aorta. So distal embolization carries a high risk. We want to land in the vertical segment, and proximal protrusion into the aorta should also be avoided. And then select views which show the like this origin and the bifurcation easily. So in this patient it was AP and RAO 30, LAO 30. So also prior to intervention, multiple or dual sources of feeders should be identified because all the possible feeders should be ligated for the symptoms to resolve. Then there is other classification called Price classification. It determines the extent of lung involvement. Our patient had no lung involvement, but the lung involvement can be in the form of bronchiectasis, in which case lobectomy or this segmentectomy should be done and not transcatheter closure. So the procedure, a 7 French JR guide was taken via the femoral arterial axis, and 4F MPA catheter was taken with mother and child technique. With MPA, it was difficult in negotiating beyond the lower loop, so changed the child catheter to 4F SIM catheter, and within that, prograde microcatheter with stillet was used to like engage the entire feeder. So, but beyond this, it was difficult to advance the guide catheter. Like the guide catheter was not even going into the ostium of the feeder because of the tortuous curve, and it was repeatedly like entire backing out of the hardware was there due to lack of support. Hence, alternate axis, that is left radial axis, was attempted. Same again, JR 7 French guide, 7 French slender sheath via that, and Termo was taken to negotiate it. It could only go to the initial lower loop. Beyond in the vertical segment, it was not able to track. But this was sufficient because our landing zone was in the vertical segment. So then a device was chosen to be cerebrovascular plug. Because our landing was in the 8.3 mm, that vertical zone, we upsized +2 and we took a vascular plug of 10. So the vascular plug 10 has a diameter of 10 and a length of 8 mm. How to choose the device for these cases? It depends on the caliber of the feeding artery and it depends on the tortuosity, the course of it. So if it is a large straight vessel, vascular plug would be sufficient. If it has a very short landing zone, AVP1 or a Sera plug, but avoid AVP4 if the landing zone is short, because there is a risk of protrusion into the aorta. If it is tortuous angulated, again AVP4 is better, or a Sera smaller sizes also are better because they have lower delivery catheter requirement of 5F. And if it is a very small tortuous vessel, coils are used, but as far as possible avoid coils because like this is a high flow shunt, left to right. If it embolizes, it goes into the left circulation via the pulmonary vein. And if there is any aneurysm, then covered stent, it is better to put that. So here we can see the device was deployed in the first image. After deploying the device on angiography, we can see there was no distal flow, like it was completely cut off. Then check for the flow beyond the device, and we should also observe for the saturation drop, because if there is a significant saturation drop, then it should not be closed. Because there is a significant amount of lung tissue which is not recruitable if it gets closed. Then Sera is ideal in this case because there is an even radial force distribution throughout the vessel, and the PTFE membranes within that, it has 3 PTFE membranes. They promote faster and complete occlusion, and immediate abolition of the intra-device shunt takes place. And the tin coating which is there, that prevents acute thrombosis and promotes endothelization. Now post-op what to monitor, this is a post-op chest X-ray. There is a slight apparent increase in the vascular markings. That is because of these 3 reasons. There is reactive hyperemia because the adjacent normal lung now compensates with increased pulmonary artery flow. Then there is a post-infarction inflammatory congestion which happens, and atelectasis, which vascular crowding of this intralobar sequestered lung. And we should also monitor for post-embolization syndrome, which includes fever, chest pain. Then there is a risk of infection to this segment because the inflow is restricted, but still there is a communication because of the similar pleural involvement. So through the pores of cone, the bacteria can come to this segment, and because of good environment, they migrate in this. Then we should, on follow-up, these are the 2 things that needs to be done. One is monitor saturation and CPET parameters. This patient had a normal VO2, like expected value within the normal range. Take-home messages would be, in a patient with chronic hemoptysis and normal lung parenchymal on CT, always look for vascular causes as the etiology. A dilated inferior pulmonary vein on the CT is not to miss finding. It signals high pressure systemic arterial blood draining into the pulmonary venous system. Think of sequestration. Then CTPA, it evaluates only pulmonary vasculature. It can be entirely normal in intralobar sequestration. Just by doing CTPA, if there is no cause of hemoptysis found, then we can't tell there is no lung pathology. So the next step should be CT aortography. Intralobar sequestration receives blood from the descending thoracic aorta most commonly, but there are other sources also. So CT coverage must extend till the upper abdomen. Then transcatheter embolization is a relatively safer alternate option in the management in selected cases, in especially type 1 Pruis classification, which means there is an aberrant artery only and there is no parenchymal abnormality. In type 2 and type 3, where there is an involvement of parenchyma, either segmentectomy or lobectomy is indicated. Then embolic agents used are coils, like vascular plugs. Avoid PVA particles as the first choice, again because of risk of systemic embolization through pulmonary venous drainage. And the plug should be upsized to 30 to 50%. Left radial access is an alternative in unfavorable anatomy like this case, and post-occlusion of the feeder, monitor for infection and hypoxia that is needed. Thank you.
Wonderful, wonderful case here. Well done.
Excellent. I have 2 questions to you. What's the difference between the AV fistula and this sequestered lung? One, clinically, how do you differentiate? The second, why did you choose the Sera plug over the vascular plug? Just give me 2 answers.
AV fistula still has the supply from the pulmonary artery, ma'am. Here it is from the systemic supply. So
Clinically, I have said. I asked clinically.
Clinically, pulmonary AVMs will have features of right heart involvement.
There, the cyanosis is there.
Cyanosis.
Here, there is no cyanosis.
Saturation
That is the
and
main thing. Saturation is normal. The second thing, X-ray will show the features in the multiple AV fistula. But here, we may not see on the X-ray. We may miss the diagnosis. That is the main thing. Okay, the Sarah plug, why did you use? I can understand, instead of lower limb, you went upper limb approach. I can understand because the anatomy was not suitable. But why did you use the Sarah plug? Advantage over the vascular plug.
Like Sarah is similar to AVP1. AVP1 can be taken only through the sheath. We took to the guiding catheter. So guiding catheter, Sarah is easier to deploy. Through radial access sheath, taking there would be difficult.
No. Advantage I'm asking. What is the advantage over the vascular plug?
One is this, faster occlusion because of the PTFE membranes.
Yeah, the occlusion occurs much faster within 2 to 3 minutes. So by the time you take a check angio, the no dye will go beyond that. That is one thing. And you don't have to oversize. There, the 20 to 30% oversize you have to do. And then you have to use a bigger sheath compared to this. So that is the advantage. Okay, any question?
So great case, Dr. Rajeshwari. I have a question. Is left to left shunt was the only DD in your head before going for a conventional angiography?
There
or
was
you have any other DD in your head? Differential diagnosis.
all the others were like looked
Ruled
into.
out. So why did not you opted for a CT aortogram instead of a conventional angiography?
We directly went ahead with the conventional.
So I want to know the rationale. No?
We thought like if it is there, staging procedure would not.
Yeah, the new and wonderful case, new form. I just want to ask you, if the patient is asymptomatic and you happen to see dilated pulmonary veins, say on echo in evaluation, if the patient is asymptomatic, would you treat?
Eventually,
And now the sequestered lung has to be treated now or never. Once it is there, detected, it has to be closed. Here there was a hemoptysis and there is an indication. Even if it is asymptomatic, it has to be closed. Okay, thank you very much. Now we call upon Dr. Ritu Agarwal. Please, double up. I think the speaker should come and sit in front, so that we can finish early. Yes, go ahead, Ritu.
A very good afternoon to all of you. So, full disclaimer, I'm a radiologist with a special interest in cardiac imaging. I do cardiac CTs and cardiac MRs, and I'm not a cardiologist like you all, and it's a great pleasure to be with you today. So, my role today is I'm going to be talking on the role of CT and MR in diagnosing a case of FF, and the patient had other anatomical problems as well. So this is a 8 years old female who had a known type 1 diabetes and hypertension, was admitted with history of body swelling, progressive SOB, unable to sleep. She also had a admission with similar complaints 6 months back at an outside hospital, was diagnosed pulmonary edema, managed conservatively, sent home, and then she came back to us now. She has been on treatment for hypertension and diabetes, but they were poorly controlled, and the family history was significant for type 1 diabetes on the maternal side and cardiac failure in her father, who died at the age of 48 years from some cardiac problems which were not investigated, and there were no details available. The lab said raised pro-BNP and the TROP-Ts were normal. Now, X-ray showed congestive changes, and therefore the cardiologist, the patient actually was under an endocrinologist who was treating for diabetes. They thought there is some lung problems and wanted to do a CT pulmonary angiogram to rule out any thrombus and a CCT chest. So these are the changes. So you can see here there is this bilateral pleural effusion. This is the thickening of the interstitial and septal lines. There are some areas of central ground glass dizziness. All of these are showing that the patient indeed has pulmonary edema. However, when we see on CT, the pulmonary arteries are normal. There are no filling defects. I just showed the main pulmonary arteries, not the segmental ones, but they were pretty normal. So, but then these are the interesting findings in this patient. So the patient had a thoracic situs solitus, but in the abdomen it was inversus. As you can see on the last image, the liver is on the left side and the spleen is on the right side, and there are two spleens. So it is polysphenia. Now, when there was inversus, we would have expected the IVC to go on the left, but the IVC was still on the right here. And then on this, this was a dilated azygous vein, which was showing the blue arrow, which is showing the dilated azygous vein through which the IVC was draining into the SVC. So this was a case of azygous continuation of the right-sided IVC along with which was draining into the SVC along with a thoracic situs solitus, abdominal inversus, which means it is a heterotaxy syndrome, and there is polysphenia. So it made anatomy a little bit complicated, but still we did not know what was the cause of heart failure in this patient. So the 2D echo was advised. It showed that the EF was normal, the cardiac size was normal. So therefore the diagnosis was heart failure with preserved EF and pulmonary edema. Now they wanted a cardiac MRI to rule out any possible cardiomyopathy or structural heart disease in this patient. So this is a cardiac MR, that is a short axis cine. For those who are not aware, a cardiac MR essentially replicates all the planes that the echo does. We take a short axis stack, we take a four chamber stack, we also do a 2-chamber stack. And putting all this, when we put this short axis stack into a software, it gives a very good calculation of EF and the volumes. So in this patient, the LV size was normal, the volumes, index volume was 65 and the absolute volume was 105. Global systolic function was normal, it was 58%. There were no wall motion anomalies and no thrombus. Also, the edema sequence did not show any edema. On the 4-chamber, you can see there is bilateral pleural effusion and a small pericardial effusion also. Now, this is interesting. This is the look-locker sequence. So, in a normal heart, in the look-locker sequence, first the cavity nulls, the LV blood pool nulls becomes black, and then the myocardium nulls, which becomes black. And in this sequence is lost, then this finding is very specific for cardiac amyloidosis. Also, a normal myocardium is jet black, and the cavity is white. And whatever you see white in the myocardium is the scar. So that is how we see a scar on cardiac MRI. If you have a normal heart, the myocardium will be black, the cavity or the blood pool will be white. But in this case, you can see it's not normal. There is a large areas of white in this black myocardium, and the pattern of scar can be subendocardial, which is just adjacent to the endocardium, or a mid-myocardial when it is within the center of the cavity, or epicardial. So in this case, you see the pattern of the scar is subepicardial, mid-myocardial, and transmural as well. But it is not in the coronary artery distribution. So it is a non-coronary artery problem. So it is a non-ischemic heart disease. It is and this pattern of scar is again in keeping with cardiac amyloid. Now, there is another number that we do, which is called a T1 mapping sequence. So T1 mapping is a more sensitive indicator for scar. It picks up interstitial fibrosis, which is a subclinical fibrosis, which is apparent, which is picked up before it becomes apparent on the post-contrast images as we saw earlier. So the T1 map was also elevated in this patient. So we had, in the previous scan, we saw there was some degree of biatrial enlargement. The ventricles were normal size. Function was normal, which means it is a restrictive pattern. You have bilateral pleural pericardial effusion along with the scar and along with this T1 makes the diagnosis of cardiac amyloid almost confirmatory. Without a biopsy, yes, you can treat it. Now, there are two types of cardiac amyloid. As we all know, it is AL versus ATTR. So without significant thickening, and the pattern of scar favored AL type over ATTR. This patient was advised PYP scan, but they refused it for financial constraints and opted for medical management of heart failure. So this is how, by using CT-MR, we can arrive at a diagnosis at the etiology for difficult cases where heart failure is there, but we do not know what is the cause and what cardiomyopathy we are suspecting. So this is just theory, I'll just skip it up. So coming to the most important point, so the difference between AL and ATTR, most important is the degree of hypertrophy, which is less common in AL and more significant in the ATTR. And from the scar perspective, you have a diffuse transmural pattern of enhancement in ATTR, whereas a more subendocardial kind, as we saw in our case with AL type. The T1 mapping is more elevated in AL, and the ECV, which is another number that we do in cardiac MR, is more elevated in ATTR. So this case emphasizes the multimodality imaging of heart failure, especially in cases of non-ischemic or restrictive cardiomyopathy, where cardiac MR is a one-stop shop, and it will provide a non-invasive diagnosis in this rare condition, which can present atypically as in our case. And CT and MR will also help to see the other uncommon anomalies which may be present, such as an azygous continuation of the right IVC, along with the heterotaxy as it was present in this case. Very grateful to my mentors in the Cleveland Clinic who trained me, and that's it.
Very much. Very well presented, very well analyzed. Your polysplenia, heterotaxy, and all that is not contributing to that. No, that is incidence finding, and your MRI or CT, they help you to get the details. Of course, if there is any intervention, then that is important. Like IVC is thing, we cannot take the IVC route. My question is amyloidosis. Can you be, what is the specificity and sensitivity with the MRI compared to the biopsy?
Compared to
Biopsy.
Ma'am, it is about more than 90% specific, and it is about 80% sensitive to pick up. So it might not pick up at times when the scar burden is less. But once it pick up and it shows you these numbers, elevated T1 and this pattern of scar with abnormal nulling, then we are more than 90% sure that this is cardiac amyloid. And we can treat the patient, we have treated the patient without a biopsy.
This patient, did he come back to you, ma'am?
Yes, she is on follow-up for heart failure, and she's in
How many days?
about a month.
About a month, okay. Because if heart is involved in amyloidosis, if not treated, I think the survival is less than 6 months. So pyrophosphate scan somehow we should do. If not anything, at least abdominal fat pad biopsy or rectal biopsy, which is a less cheaper one, we should do.
Yeah, fat pad biopsy was done in this patient. The biopsy findings were inconclusive. That is why I did not report them. And PY scan, PYP, she opted out.
Okay. Did you treat with tafamidis or not? Because pyrophosphate scan is must to start tafamidis.
Yes, I'm sorry.
The treatment for transthyretin amyloidosis class 1A after 2021 guideline is tafamidis, approved drug for transthyretin. Now, for that start the treatment, must have pyrophosphate scan. We have not started.
That is, you are talking of specific treatment for cardiac amyloid. This patient underwent treatment just for heart failure because she did not want to go further. She did not want to go for a biopsy. She did not want to go for a PYP scan. So they did not want it. So we treated for heart failure.
Great presentation and really nice, ma'am. As heart failure with preserved ejection fraction, one of the important DD is amyloidosis, and cardiac MRI help to diagnose. With the India, where tuberculosis is more common, inflammation also lead to the amyloidosis. Great, ma'am. Great, ma'am. A nice presentation.
That is the problem. So if we have a patient with a normal ejection fraction, we can differentiate on MR basis.
Yes, yes. Heart failure with preserved ejection fraction.
Differentiate on MR whether it is sarcoid, whether it is just plain HCM, or it is amyloid. That's the power of MR.
Yes, yes, ma'am. Yes. Sometimes the sarcoidosis, there was a case which sir is there. There was young female, recurrent VT, and gradually we diagnosed that sarcoidosis was there. Sir, our EP expert is there with us.
Yes.
Yeah.
So
Great, ma'am. Nice, ma'am.
Yes. Thank you. Thank you.
Thank you. Well done. Yeah, now we move on to Dr. Aditya. Please.
Respected audience, teachers, panelists, it's my privilege here to present at this August audience. So today I will be presenting a case of pleomorphic VT masquerading as cardiac. Sir was recently just telling about cardiac sarcoidosis. This is a very important topic which we miss many times in a female patient. I'll just show the presentation. So this is the ECG rhythm strip we got. Patient basically came from outside. 55-year-old female patient had shortness of breath. ECG revealed monomorphic ventricular tachycardia. The patient was cardioverted outside and sent to a hospital. So at the presentation, this is the ECG what we got. So it's important to note in this ECG, this very peculiar ECG, you will see alternating RBBB and LBBB morphology in the same ECG. And as opposed to polymorphic ventricular tachycardia, it is not twisting along a baseline. So you are seeing some beats of LBBB and then suddenly it changes to RBBB. So this is characteristic of pleomorphic ventricular tachycardia, which is a different entity itself. So generally, it is present in those patients which have extensive myocardial fibrosis. So it can be due to any cause. It can be due to inflammation. It can be due to ischemia. But only extensive fibrosis in the myocardium will cause this. And so we should be beware if we see any patient with this type of ECG. So on arrival, patient was conscious oriented, BP was 90/60, ECG revealed pleomorphic ventricular tachycardia, initial laboratory results showed positive troponin, electrolytes were within normal limit, and brief history of cough, hemoptysis, systemic symptoms were not present in this patient. So we are seeing VT, many patients with VT, but what caught our eye in this patient is the echo findings. We see that the basal interventricular septum was thinned out and akinetic with severe biventricular dysfunction. Not only LV, RV dysfunction was also present in this patient. And we did an angiogram which showed normal coronaries. So normal coronaries with basal wall thinning, biventricular dysfunction, and pleomorphic VT. So generally we are seeing many cases, and in the OPD we are not even thinking, just a VT, sustained VT is there, we'll plan for ICD for that patient. So that concept has to be changed. We should think of a patient as a whole, whether a patient is having any systemic illness which is causing that VT, especially in young patients, as sir was telling recently. And serum ACE was mildly elevated. So so we did cardiac MRI. So imaging is a must in these kinds of patients to rule out any inflammatory cause or infectious cause which is causing this VT. So when we did this cardiac MRI of this patient, we can see this LG, late gadolinium enhancement in the septum and the LV wall. Here also we can see in the LV wall, and in the RV side of the septum also we can see. And we can see severe biventricular dysfunction. So this pattern is not consistent with ischemia pattern. So cardiac MRI late gadolinium enhancement, what it does? Gadolinium is basically stays in the extracellular fluid and it readily washes out. But whenever there is cell damage, then it will remain in the extracellular fluid. So it may be present in cases of any inflammation, and also it may be present in case of fibrosis. So we don't know whether it's an inflammation or fibrosis. So that is the need for doing PET-CT. Because PET-CT, what it will do is that it will only identify cases for active inflammation. So it is taking fluorodeoxyglucose. So only parts of the myocardium which are having active inflammation, it will be taken by PET-CT. Also, it will be helping in, if you do an initial PET-CT and then after the treatment we do again, we'll be able to know whether there is any resolution of symptoms or the cardiac illness has decreased or improved. Because if we do cardiac MRI, again we see the same fibrosis, we are confused whether we have really treated the patient or not. But if we do the cardiac PET-CT, we know that the patient has improved because those inflammatory regions will go off. Also, it is more sensitive than cardiac MRI in detecting inflammation in any area of the heart. Plus, it has a third benefit that any extra cardiac inflammation is there, it will detect it. So, if the patient had initially presented with sarcoidosis, it was very easy for us to check the cardiac MRI and do PET-CT. But the patient here presented with only cardiac features. There was no extra cardiac features. There was no hilar lymphadenopathy, no skin changes, no other changes of other illnesses. So it was very difficult to diagnose from other criteria what was the illness. So here PET-CT will help because any residual inflammation in any lacrimal gland, etc., it will detect it. So this is so we proceeded with the biopsy. So you may say biopsy showed subendothelial non-necrotizing granuloma with scattered multinucleate giant cells and asteroids body suggestive of cardiac sarcoidosis, and special stains for AFB and fungus were negative. Now you might say this is a straight-cut case of sarcoidosis, but I would disagree with you because in India especially, we can have tuberculosis with almost the similar type of histopathology findings. Here the only difference is it is non-necrotizing granuloma here, whereas in tuberculosis we find generally necrotizing granuloma. But again, I may repeat that from the biopsy sample where we have taken, that part may not contain caseation or necrosis. So even tuberculosis might have a similar picture. And AFB, you know, it is very difficult to see under a microscope. Many times we miss. And thirdly, is that biopsy from that particular site taking is very difficult. It has been seen that even in established cases of cardiac sarcoidosis, biopsy was positive in only 20% of the cases. And if we do image-guided biopsy, then the sensitivity increases to 40%. So even cases of established cardiac sarcoidosis, biopsy may not, 80% of the times will not show anything. So we were very lucky in the sense we got this type of picture because it was image guided, because already we had seen in cardiac MRI and PET-CT where the lesions were. Thirdly, also I would like to say about the feasibility of biopsy, because when we go and take a biopsy specimen from the septum, it is easy to take. But if the inflammation is on the RV free wall, if it is on the LV side, then it can be done, but it is risky and difficult to take. So these are some of the practical problems when we are going to take cardiac biopsy specimens. So treatment, so already patient was having incessant VT with severe biventricular dysfunction. So patient definitely needed ICD. And endomyocardial biopsy showed features suggestive of cardiac sarcoidosis. Though it could be tuberculosis, but since all the features were more in favor of cardiac sarcoidosis, so we went in favor of cardiac sarcoidosis and started the patient on steroids. So this is basically schematic diagram of how we should treat. We should start initially with corticosteroids. I would not go into the complexities, just understand the basic concept. Is generally we start with steroid, prednisolone. If there is a flare in the disease, we will give IV prednisolone, methylprednisolone, and we can give interleukin-1 inhibitor infliximab, rituximab to the patient. If the patient is improving, then we decrease the steroid doses and start on steroid-sparing immunosuppressant like methotrexate, etc.
Sir, please summarize your case, please.
Okay.
So I have only one thing to, ma'am. Yeah. You showed a beautiful image of cardiac MRI, which was specific for sarcoidosis. There was one sign which is seen in that image. Can you name the sign?
Cardiac MRI?
Yes, the image you showed a sign of cardiac sarcoidosis, which is 90% specific and sensitive for cardiac sarcoidosis.
That is basal inferior wall thinning.
Can you name the sign?
Don't
Okay.
worry. Don't
I
get
am
nervous.
very good at imaging, so I can
There
tell
is
you.
some panda and lambda sign, but that
No,
is
no,
for
it's not all.
extracardiac.
It's called hook sign. Hook sign means the fibrosis and the calcium starts from the middle of the septum. It goes and bifurcates into the right and the left, both sides. That is like an anchor. So it is called a hook sign. It is 90% sensitive and specific for cardiac sarcoidosis.
Sarcoidosis. Okay, that is only 90%, which is 100% sensitive and specific.
Ma'am, there is actually nothing like gold standard because even the
But
diagnostic
still biopsy is the gold standard. Okay, in the world there is nothing like gold, or gold itself can go up and down, but still biopsy is the last one. So the science apart, don't get nervous, and well done. And now we move on to Sujani. Please come.
Thank you.
Is not there? Okay. Then we move on to Dr. Nikhil Rachani. Huh? Done? Okay. Fine.
Requesting all the chairpersons and the speakers of this session to please come up for a group picture. The speakers of this session to please come up for a group picture. Add all the marks. There are other genetic cases in the other halls. All the marks will be added. This marks. Picture, please.
With that, it is my privilege to invite Dr. Sarita Rao, President WinCars, to deliver the final vote of thanks.
So, we come to the close of the 18th Women Cardiac Care Conference, WCC 2026. And it gives me immense pleasure and deep satisfaction to stand before you today and to reflect on the wonderful academic journey which we have shared over the past 2 days here in Indore. WCC has started with a powerful vision to create a platform dedicated to advancing cardiovascular science, encouraging collaboration and strengthening academic exchange among cardiology professionals. Over the years, that vision has grown into a vibrant and respected scientific forum. At this moment, let me express our deepest gratitude to the founder of WinCars, Dr. Jyotsna Madari, whose vision and leadership laid the foundation for this remarkable initiative. Her commitment to building a strong academic forum continues to inspire us all. I would also like to sincerely thank Dr. Sujata Viparla, the chairperson of WinCars, for her guidance and continued support in strengthening the activities and the academic mission of this association. My special thanks also go to Dr. Shiba Thakra, Director WinCars, whose dedication and involvement have played an important role in shaping the direction and growth of this organization. Over the last 2 days, WCC has witnessed outstanding scientific sessions, thought-provoking lectures, engaging discussions, valuable knowledge exchange, and collaborations. The participation and enthusiasm of all of you Every one of you has made this conference meaningful and memorable. I extend also my heartfelt gratitude to our distinguished international faculty. I can see Dr. Marta, Dr. Stephen there, and also all the national faculty members who shared their expertise and with such generosity. All of your contributions have enriched the academic depth of this conference. I would also like to thank all the delegates, fellows, young cardiologists, students who actively participated in all of our quizzes, our PSS programs, our surveyor research, so many programs which were ongoing, the abstract sessions. It made it all vibrant and interactive. My sincere appreciation also goes to the organizing committee and especially Dr. Roshan Rao. And along with Dr. Roshan Rao, Dr. Abhishek Rathore, Dr. Shirish Agarwal, Dr. Abhishek Nagar. So all of these people really, Dr. Praveen Jaiswal, they're all our team of cardiologists at Apollo, without whose support I could not have done this. I would also like to encourage, acknowledge and thank a very important part, our industry partners. No conference of this magnitude is ever possible without industry support. And I take a moment to thank everybody from the industry, the pharmacological and the device industry who have supported us wholeheartedly. Behind every successful conference is a team that works tirelessly behind the scenes. I extend my heartfelt thanks to the scientific committee, the hospitality team, the logistic teams, everybody, my technical, my audio-visual team, to Vidhi and her entire team of people and the volunteers who ensured that every aspect of this conference ran smoothly. I also want to thank my research team, led by Dr. Kumar and his team of entire research students who supported this very well. At the end, I also want to thank my hospital, Apollo Hospitals Indore, the CEO, Mr. Abhilash Pillai, and all the people from Apollo, our marketing team, led by Mr. Ravindra, all the people who made this conference a great success, Mayank, everybody. So thank you, everybody, for being a part of WCC 2026, contributing to its success. I wish you all a safe journey back home, and I look forward to meeting all of you again at future WinCars initiatives. Thank you so much.